lesion. MRI, chemical shift imaging, as I had told you, outphase imaging consisting of lipid-rich adenoma. That means it is a loss of signal intensity, but it does not take up intensity. It is a bad sign. And you can see that CT with delayed contrast, absolute and relative washout values I have told you, and also absence of uptake or uptake less than that of liver. That suggests it is an adrenal issue. So I'll just give you some very quick rapid fires. So adrenal incidentalomas are mostly non-functioning, 75%, unilateral less than 3 centimeters, CT value less than 10 HU, lipid sensitive imaging washout is very good, 30% are lipid poor. That is why atypical adenomas, heterogeneous functioning adenomas have to be gone and check. The liver intensity is important, and always do a contrast washout to confirm it. This is the picture presented in the NEGM very early, but it still holds true. Whereas you can see here that a 70-year-old female comes incidental lesion, size is also small, given only follow-up, does not increase, just requires a careful annual follow-up. Occasionally you can do a hormonal profile. A younger lady presents, you should always check the size, the progression, the propensity, and the washout. And in this case, it was washing out very fast, but there was a sinister feature of a lipid issue, so it is likely to be atypical adenoma. So what about a pheochromocytoma? It is definitely showing a delayed washout, and there is also cystic and hemorrhagic areas. So it is always important, and increased vascularity because of the blood vessel issue, and high intensity on the T2 weighted MRI. So we should always try to do the full panel of investigation, including a 24-hour metanephrin. 3% adrenal incidentalomas prove out to be a pheochromocytoma. And usually you should go for plasma when only the pretest possibility is high. Usually routine 24-hour examination is preferred in our center. Is highly sensitive but less specific. Cushing syndrome, subclinical Cushing syndrome has to be observed in a metabolic syndrome profile. We should rule out by a 1 mg overnight dexamethasone suppression test. Most prefer to keep a cutoff of 5 rather than the traditionally thought 1.8 for identifying this. Italian study group with a large patient cohort had shown that other tests also can be done along with it. That is a supranormal 24-hour urinary cortisol, disturbed adrenal rhythm, and CRS stimulation test, and DHEAS test. These are the spectrum of the Cushing syndrome. Whereas primary hyperaldosteronism, very small, only less than 1%. Those majority do not have hypokalemia. It's only hypertension often. We should go for a PRA, PSA, and PRA, PA, that is plasma aldosterone. And it is only 2.5 also in the Western series also. So coming to the summary of my talk, so you can see that whenever you have a condition with adrenal incidentoma, the choice is up to us, whether to take a surprise, you go for evaluation, ignore it as well, go for a surgery early, or go for a follow-up. Because guidelines are very clear, we should go for a traditional teaching also. This is what the guidelines from the radiological counterparts say. Incidental lesion more than 1 centimeter, size is more than 4 means definitely rule out malignancy. ACC is what we are worried about. So I told you the features of ACC which we saw. Lipid sensitive imaging, negative or positive. If it is lipid sensitive, it is a positive adenoma. It is no contrast meant, it's a cyst, then you go to follow up. CT washout, as I told you, values. Some patients we go for biopsy, I will tell you in my next slide. And some functional imaging is required in some benign conditions if it is having a higher values of metabolics. So one patient we had gone for a FNE biopsy when I was in my Amrita times. So it was relatively safe. Ultrasound biopsy is also known to take up, but in our patient we done a CT guided biopsy. So it is done only when you exclude the pheochromocytoma, and when you want to distinguish carcinoma from metastasis. It cannot distinguish carcinoma from the adenoma. It is useful very useful in granulomatous conditions. It is also known to, because in known primary FNS does not add much value. Remember that it has got side effects like liver and adrenal hematoma, abdominal pain. So whenever you are seeing a patient with adrenal adenoma or something suspicious, don't go for FNAC unless you are finding it likely to have a granulomatous lesion. So next slide, yeah. So just one case we saw in our practice, 60-year-old male, a chronic smoker, comes with diabetes and came with chronic abdominal pain for 6 months duration, appetite loss, 10 kg weight loss over 6 months, evaluated by gastro department, found to have a GI malignancy suspicion, but they found to have a renal mass, adrenal mass. And when we went for a test, the cortisol baseline itself 16.3. ONDST is, as I told you, is not suppressed. LDDST is not suppressed. You go for 24-hour urinary, it is negative. And norepinephrine is borderline actually, but 3 times or more is significant. DHEAS also is normal. So this patient, because of the multiple issues, peripheral smear was also checked, and they did a trephine bone biopsy. They found it is a B-cell lymphoma infiltrating the bone marrow with a low labeling index. It is a non-Hodgkin lymphoma, a primary adrenal lymphoma. It is CD20 positive with atypical lymphoid cells. So less than 5% can also present in this way. So this is a stage 4 B-cell lymphoma, non-Hodgkin lymphoma, suspected adrenal lymphoma with diabetes also. So lesson in this case is that, though it is very small in nature, both adrenal glands can be involved. It can have features of increased LDH, beta-2 microglobulin, ferritin also. So we should always think about this condition when you are seeing a case with bilateral adrenal disease. And FDG PET can be a benefit to locate extrarenal locations also. And it's very good prognosis with rituximab, R-CHOP followed by SCT. So adrenal malignancy usually are very rare, unilateral, diameter more than 4 centimeter, calcification can occur, CT attenuation more than HU10-20, hyperintensity liver, and 2 to 5% can be primary adrenal cortical, and less than 3% can metastasize to adrenals. Evidence of local invasion can also be picked up. Size more than 4 centimeters is having a 90% sensitivity for our ACC, but less specificity. That is why we should go for functional testing. So this is how we do it. Adrenal metastasis tends again to be bilateral. CT shows higher contrast. Primary can be from the lung, liver, lung, colon, breast, anywhere from the pancreas, liver, stomach. As you see, it is having FDG avidity also. So last, about the bilateral incidentelloma, it can be a part of a macronodal adrenal hyperplasia or PMH. Then you have got CH-like presentations, TART syndrome can occur. You can have metastasis presentation, infiltrated disease. Rule out any adrenal dysfunction also. Recently, we had a case report also of adrenal myelolipoma presenting an 11-year-old child with abdominal pain from Calcutta only. Recently, I saw this and very good publication showing that even early we can diagnose them, and there are tuberous sclerosis-like presentation also was there. And this is important because flowchart, because this is the last consensus flowchart from the European consensus. Adrenal incidentelloma assessment parallelly, functionally, and malignancy. And if you've established a definite diagnosis, discuss in a multidisciplinary team, find out a cause. If it is good, go for investigations or not. If it is adenoma with autonomous secretion, go for a Cushing syndrome workup and treatment. If it is clinically evident excess, you should go for surgery if required. Independent mass, less than 4 centimeter or not progressing, less than 0.5 centimeter per 4 years increase, you should just leave it like that, only required in follow-up. So there are some dilemmas which all of us face. We don't know what is the optimum frequency of follow-up. We don't know the duration of follow-up. Actually, this presentation I had seen in Dr. Nilanjan Sengupta sir's talk when in ICCON Trivandrum time. Sir is also here. Thank you, sir, for coming. So this topic, this slide shows you whether cost effectiveness is required, because whenever you have a lesion in adrenal incidentelloma, you should know whether it is cost effective or not, whether every 6 monthly, 12 monthly, there is no consensus regarding this. Hormonal evaluation should be done at least for 4 years when the initiation is negative also. Again, there is doubtful efficacy or yield and effectiveness. Most often, the adrenal incidentelloma that don't increase, they also can be non-malignant. They may be natural progressing only. And some patients with abnormal adrenal functions may not be present at initially, but can resurface during the follow-up. So there is no consensus on how we can follow up either functional, hormonal, or biologically or radiologically issues. So last 2 slides for the summary of my talk. As I have told you, non-functional lesions, adrenal incidentelloma are more common, 85%, less than 15% are functional lesions. Size should not influence the decision making. Imaging phenotype, as I had told you, is very important. Age group is also mandatory to be checked. Less than 60 is better usually. Coexisting conditions are also to be ruled out. If it is more than 5 centimeter benign phenotype in a very elderly person, it can benefit from only observation. And this is the latest talk from the European consensus. We show that it is a variety of presentation of adrenal incidentelloma. It should not be only adenoma. It can be myelolipoma, adrenal cyst, ganglioneuroma, metastasis. So we should always rule out other conditions. So summarizing this talk together, variety of pathologies can affect the adrenals. Increasing imaging, it's a gift of the imaging, we can say, because 4 to 10% can be because of increased imaging. Adrenal gland, because of the vascularity, can be favored site of metastasis. Imaging can definitely benefit from the benign or malignancy. Always keep in mind the clinical biochemical features, and it is always not possible to distinguish functional from non-functional every time. So you should not ignore this, evaluate correctly, and always remember that we are always going the team approach. Pheochromocytomas can be silent. It rules biochemical evaluation. Subclinical Cushing's can be a diagnostic challenge and therapeutic dilemma also. Bilateral mass, as I had told you, can be granulomatous lesions as well. And some infiltrative conditions, as I had showed you, adrenal hyperfunction can definitely be kept in mind. So one full issue of pulse dedicated to incidentalomas all over the body was there, like thyroid, liver, so many conditions. Adrenal incidentoloma also figures this. And I have a fortune of meeting Michael Young also, in the very last SECON also in Crescendo. And he told me that, he quoted this scientist quote from Charles Mayo, the famous Mayo Clinic person: worrying about incidentoloma is actually useless, senseless, and worthless. Any other condition also in life, because whether you win or lose, sometimes we take it to our heart. So sometimes we always die from overwork or thinking about it more than doubt only. Sometimes doubtful is also bad. We should always do proper workup and methodical workup to diagnose them. So I thank you for listening to me. Any questions, I'm always welcome. I always welcome you to the annual conference, which is happening next week also. In anybody interested to join us in Calicut, welcome. And also SECON happening in Vizag in the next few months. So anybody interested, I am also EC member. Anybody can just reach out to me. Thank you very much.
Thank you. Am I allowed to ask a question?
Yes, please. Yes, please.
Thanks, Mohan, for acknowledging me. Well, you said rightly, probably the gist is that when it's an adrenal incidentoloma, generally we need not have to bother much because they turn out to be innocuous lesions. My question, though I arrived late, in how many proportion of cases in different series does bilateral adrenal mass present as incidentoloma, and whether these are that innocuous?
Yeah, that's what. The bilateral adrenal masses can sometimes present. Case series are telling it's very less number only, but often in KEM series, I had asked Nalini Shah madam and Anurag sir and all, they find it is more common in the R population size, but outside I think around 10% or less only. And usually they have got infiltrative conditions also involved, and some people can be benign also. It's a mixed bag only, and it is only innocuous. It does not have any significance for
but
sometimes it
maybe
can.
Sometimes metastasis
sometimes
also.
Can be.
We had an experience of adrenal incidentoloma actually that turned out to be bilateral adrenal metastasis.
Yes, sir. So it's always good to evaluate every hormone whenever DHEAs or other hormones also. Thank you, sir. Nirman, hi.
Hi, thanks for the beautiful talk. So I have a question that, this is a question maybe rather from many of the physicians, that the patients may be hypertensive and the patients can have on this beta blockers, ARBs, and many other, this kind of molecules. So when we assess that an incidentoloma hormonal assay particularly, this epinephrine, norepinephrine, and this aldosterone. So is there any, we have to stop this thing, any regulation for it?
Yeah, so that's a good question. Beta blockers, usually we say that can have problem when we test for the adrenal mass, but usually with a low dose beta blocker, we don't have any issue. And spironolactone is the only drug which was thought to be having a problem, but when Michael Young sir talked, he told in some reports, if you are suspecting, then only you stop. Otherwise, it's fair enough to continue. But generally, if you have given so many medicines, you can convert to the other groups. And when you go for a surgery, you should always alpha block, then only beta block. So before you go for any investigation like that, keep the normal medicines, whatever there. But I think nowadays, most of the guidelines are saying we can use most of the medicines correctly. And beta blockers and spironolactone is the only thing which we are sometimes suspending sometimes.
Choice of test for detecting FeO.
Yes, sir. So choice of test for FeO, usually I mentioned, it is usually 24-hour metanephrine we do, that is urinary metanephrine and normetanephrine. That is a good sensitivity factor, but sometimes it cannot pick up. Plasma is beneficial because it is single shot only, and it should be done in the supine position usually. And usually we have got a lab assay which we take, because our own lab only we should do, because sending them outstation can have, because preservatives required for the urinary test, and for the blood it is very simple to do. A fractionated test can be done. So it's usually plasma metanephrine is done free metanephrine, and urinary is fractionated metanephrine. That's what we in Amrita we used to do. And it is that if you have got good evidence in your own hospital setup, both are good in your way, but urinary metanephrine has got a good effect because it can secrete over the entire day. You can get a complete value. But other side, only one value can be seen. So you should repeat the sometimes plasma if you are in doubt. And urinary metanephrine usually picks up ideally better, because experience varies. I am comfortable with the urinary metanephrine. And imaging test, usually we do the non-contrast CT initially, wash out. As I had told you, it can delayed wash out sometimes, but it often gives out. And sometimes it can have cystic imaging, hemorrhagic picture also. That can present also. And some features can be, malignant fever also can present with a small metastasis bilaterally also. That can also be there. So we always do a CT or MRI, then sometimes only go for the higher imaging also.
Then whatever you do in an admitted patient.
Admitted patient, yeah.
In a external lab.
Yes, that's very good, sir. Because some people, emotional failures can be variations, infections can be there. So whenever patients are admitted, you take them into consideration and keep them under your observation, then only do that. If a patient is walking in and doing it, you tell them, well, it's good, but sometimes some values can be erroneous. We should do a follow-up and check that. Some labs have got problems, sir.
No, some lab do it without admitting.
Without admitting, yes.
What about it?
Yes. That's also there. That also there. We are also happy with not admitting, because endocrine evaluation can be an OPD also. But if we have got a patient with panic episodes, we don't know when they secrete. Cyclic Cushing's also we tell admit and do those tests. So endocrine evaluation should be done as a team. If we are required only admission, if they do admission, we should do in a timely manner only. We should not do early itself. Thank you, sir.
Thank you. Thank you, Dr. Mohan.
Thank you very much, everybody.
Thank you. Thank you so much. A big round of applause for Dr. Mohan for his talk on adrenal incidentoloma. We now quickly move on to the second talk on approach to the patient with Dr. Saptarshi Bhattacharya. Can I have his CV, please? Dr. Saptarshi. Yeah, Dr. Saptarshi Bhattacharya is from Delhi, senior consultant at Indraprasth Apollo Hospitals, Delhi. He recently was also elected as the executive committee member of Endocrine Society of India, to be taken up over the course of time, and he'll be taking us through exogenous Cushing syndrome.
Thank you, everyone, and a very good morning to all of you who are here. Special thanks to Crescendo team for inviting me back to my home city once again. So we just listened to Mohan about one aspect of adrenal, a very common aspect of adrenal problem, which is an adrenal incidentoloma. I think this is even more relevant in especially Indian condition, that exogenous Cushing syndrome, a area not discussed very commonly, but very, very relevant. We see all these patients so commonly and how we actually approach them. So obviously we know that the endogenous Cushing syndrome is an enigmatic condition, so it can be ACTH dependent, ACTH independent. So we will not talk about that, and we will talk about exogenous Cushing syndrome, which is by far more common than endogenous Cushing syndrome, and it can be iatrogenic. So if somebody is having nephrotic syndrome, requires say a high dose of glucocorticoids, so it's expected that that person will develop some sort of Cushingoid features and related manifestations. On the other hand, you get a lot of factitious exposure from alternative medicine, exposure from unknown sources, where the person doesn't know that he or she is taking steroid and comes to you with florid features of Cushing syndrome. So whenever the symptoms are usually quite apparent, so the person has a gain in weight, loss in muscle mass, stria. So all these some features of protein catabolism. So all these features are there. And when you get such a person, so when you are approaching such a case, first of all, establish a diagnosis. Cushing syndrome, endogenous or exogenous, has multiple comorbidities. So even for an exogenous Cushing syndrome, you need to be sure that you are not missing out on the complications and comorbidities. So you need to screen for it properly. And if it's a situation where the exposure was accidental and the person did not know that he or she was taking steroids from some alternative medicine, which is a very common scenario. We all have faced so many of these cases. You should have an appropriate tapering strategy for the steroid as well. So the bulk of the diagnosis will be related to history, which can be expected, where you know that the person is receiving steroids, or it can be occult, the person doesn't know and still getting steroids. Obviously, the physical findings will add to it, and you will have some labs to, first of all, confirm the diagnosis and also to screen for complications. So these are the commonly prescribed steroids in our practice. So hydrocortisone it's not that commonly used as a glucocorticoid as an immunosuppressant, but prednisolone, methylprednisolone, dexamethasone, betamethasone. So these are very commonly used, and actually most of the alternative ingredients where you don't know somebody is getting some Ayurvedic puria and all, so they have usually dexamethasone or betamethasone, which is very potent. They are required in small quantities. The person will be happy he is taking only a small churn or a powder, but he will actually be taking steroids. So these are the potent molecules, and they don't get picked up in the cortisol assays as well. And these are the comparative properties of glucocorticoid, mineralocorticoid, their duration of action. I am not going to go into the details of it. You all know most of the part, but this usually will be the cause for an exogenous Cushing syndrome, and the manifestation can vary from a distribution in adiposity where central obesity, abdominal fat deposition occurs. There can be fat pad, buffalo hump. So all these are there. There are changes in the skin like atrophy, stria, musculoskeletal changes, proximal muscle myopathy, muscle catabolism related changes, osteoporosis, metabolic changes, hypertension, as well as dysglycemia. Reproductive changes can occur in females as well partly in males, and you have long-term complications like CVS. Hematologic complications are there, infection is very common, and you also need to be aware about the thrombogenicity aspect as well. So if you are looking into the exogenous versus endogenous Cushing, so there are some distinctive features. So features of protein catabolism are more prevalent in exogenous Cushing. Hypertension is less common. Studies suggest 20% in exogenous versus 75% in endogenous. Characteristically, if you are getting steroids like betamethasone or dexamethasone, so there will not be features of androgen excess. So androgen excess occurs due to, say, if you are thinking of Cushing's disease or a pituitary dependent cause of ACTH dependent cause of Cushing syndrome. So you will have ACTH will cause some stimulation of adrenal androgen secretion as well. So that features will be there, but in case of exogenous Cushing syndrome, you won't have that. Pancreatitis, osteoporosis, glaucoma, posterior subcapsular cataract, and avascular necrosis of femoral head. These are all more common in exogenous Cushing syndrome as compared to endogenous. So if you look into the hyperpigmentation, ACTH is primarily responsible for it. So if you the left hand side is the one, there is you see the knuckles, there is no hyperpigmentation, so that will be most likely related to exogenous. If you look into the right hand side, so it is an endogenous, you can see the associated knuckle hyperpigmentation. So this is a comparison of the skin lesions of endogenous versus exogenous. If you look into it, exogenous actually has more stria. The last part is a comparison, P3 is a comparison between endogenous and exogenous. So you see they have more stria. They have hirsutism is, as we said, the androgen features will be more in endogenous, so that is more common in endogenous. If you look into hypertrichosis, so you need to differentiate between hirsutism and hypertrichosis. So this is hypertrichosis will be more of vellus hairs, not androgen dependent hairs. So they are actually more common in exogenous Cushing. So endogenous Cushing more of androgen dependent hair growth, exogenous Cushing more of androgen independent hair growth in the form of hypertrichosis. Hyperpigmentation more common in endogenous, and fungal infection also are actually more common in exogenous forms of Cushing. So there are some manifestations which are dose related, some are dose independent. So there is almost a linear rising trend with increasing dose in the Cushing or dose of glucocorticoids. Ecchymosis, leg edema, mycosis, skin parchment like skin, shortness of breath, and sleep disturbance. So almost a linear rise with exogenous Cushing. Threshold pattern, so one manifestation which can occur with very low dose of steroid also is actually posterior subcapsular cataract. So even with exposure to less than 5 mg per day, there can be this side effect. Others like glaucoma, depression, listlessness, increase in blood pressure, they occur around 7.5 mg per day. Epistaxis and weight gain, they occur with around 5 mg per day. So, and if you are looking into exogenous Cushing, so this is where area you really need to be clinically sound. So you will have features of cortisol excess, glucocorticoid excess, but if the person suddenly stops the steroid or glucocorticoid, he or she will have features of adrenal insufficiency as well. So you need to be careful about both these aspects of clinical features. So you will have, we all know the classic clinical features of Cushing syndrome, but if the person is suddenly off steroid, actually can even land up with an adrenal crisis of hypotension, nausea, vomiting, severe fatigue, fever, impaired consciousness, so can land up actually with a coma also. And obviously you have a whole lot of manifestations starting from fatigue, weakness, dizziness. Anorexia is a very, very common manifestation. So if the person is suddenly off the steroid, so you need to be dealing with both the aspects of, so physically the person might be having features of Cushing syndrome, but symptom-wise, if the steroid has been taken off, might actually also be having features of adrenal insufficiency. And so where we came, so it can be, so Cushing syndrome can actually develop because of therapeutic use. You know the person will require steroid, so then also there can be Cushing syndrome. Many of our cases, as we see and we need to be very, very aware, are on alternative medicines and they are actually taking steroids. Drug abuse has been a common cause. So many of these gyms, they use this very, very strange cocktails, and so most of the anabolic steroids, they don't have too much of glucocorticoid property, but even so glucocorticoid has its own short-term use, has an exercise enhancing properties also, so even they abuse glucocorticoids also. So it's not very unusual that some of these young men who are going to gym, they have Cushingoid features also. And this is one area where you need to be careful. So there are some drug interaction. Normally you won't have Cushing syndrome with a certain type of, say, inhaled steroids, but some drug interactions can actually make them predisposed to that. So you need to be careful about that. So if you are looking into steroids, so actually all form of steroid exposure, starting from oral glucocorticoids, inhaled glucocorticoids, IV or IM glucocorticoids, topical glucocorticoids, and even intra-articular glucocorticoids, they can all cause exogenous Cushing syndrome. So initial part, long-term exposure to exogenous glucocorticoid, they can lead to atrophy of pituitary corticotroph cells, but very prolonged exposure can actually lead to the atrophy of the zona fasciculata and zona reticularis of the adrenal gland, adrenal cortex. So in that case, that person is going to take a very, very long time to recover from that. So might require physiological dose of glucocorticoid replacement for a very long duration, even 1.5 to 2 years. So that is also possible if you have a situation like an adrenocortical atrophy. So there is no golden rule, okay, if 3 months is a time where you need to give steroid, then you can taper off. So it all depends on the previous exposure to and the degree and the duration of glucocorticoids, which will guide us about how much time the person is going to take to get it off. So these are the common therapeutic uses of glucocorticoids. So we all know it and many of us are using it. So if the person is having these conditions, you are expected that it's expected that they might have Cushingoid features or exogenous Cushing syndrome. So this is one area where we really need to be careful. And in our residency days, so we have a case of Cushing syndrome admitted. So when we are residents, we take history, it never comes up. When the consultant comes and asks something, they always pick it up. So that used to happen many times. So, but again, you really, really need to be careful about this unintended exposure. So another area is gym, steroid abuse for athletic purposes. You again, very, very cause for concern. So one area where you actually need to be careful is the drug interactions. So CYP3A4 inhibitors, they inhibit the metabolism of many of the glucocorticoids. So if a person is getting two of the bulk major group of drug interactions will be protease inhibitors and antifungals. So if somebody is receiving protease inhibitors like say indinavir or lopinavir or nelfinavir, so it can be because of hepatitis infection, it can be because of AIDS treatment, so you really need to be careful. Antifungal treatment like voriconazole, itraconazole, ketoconazole and posaconazole, they also can strongly inhibit CYP3A4 inhibitors. And I have not added in the slide, there are also genetic variations of CYP3A4 metabolism. So there are some genetic traits which changes, which predispose to their higher metabolizers of glucocorticoids. So they are somewhat resistant to the features of developing Cushing-related manifestations. There are others who have variations which make the enzymes less active, so even with smaller dose they might develop Cushing syndrome. So there can be individual variation also in Cushing syndrome related manifestations. So one area where you need to be careful, so if somebody is on say methylprednisolone, fluticasone, budesonide and triamcinolone, they are predominantly inhibited, metabolized by CYP3A4 pathway. So if somebody is on these molecules, so somebody is taking fluticasone or budesonide as inhalers and is also having a say fungal infection in the chest, or maybe so in that case you need to actually think of alternative glucocorticoids like prednisolone, beclomethasone or flunisonide. So normally with inhaled steroids we tend to think that the person won't develop exogenous Cushing. The prevalence rate of adrenal insufficiency with inhaled steroid is around 7%. With topical steroids, it is around 2%. So if you give a occlusive dressing with topical steroid, the chance of Cushing syndrome related manifestation is more. If there is more of inflamed skin where glucocorticoid absorption can take place, the chance of Cushing syndrome is more. So this is something which we really need to be careful. So very commonly used, some respiratory complaint, fungal infection is on inhaled inhaled steroids as well as antifungals. You really need to choose from prednisolone, beclomethasone, flunoside rather than the one shown in the top. So a very case scenario just to discuss. So we have a 41-year gentleman, generalized body ache off and on, has been on alternative medication. You see classic features, partial relief in symptoms with whenever he is taking this alternative medicine. So what test to order? So normally we do not get so if you look into guidelines, they say that basal cortisol has got no significance. You either need to do an ONDST for if you are suspecting Cushing syndrome. If you are suspecting adrenal insufficiency, you need to do a stimulation test, ACT corticotrophin stimulation test. But this is one area actually where a basal cortisol can be helpful. So if you have a serum cortisol which is actually low, so most of the exogenous Cushing syndrome will not be because of hydrocortisone overuse. So if somebody is having an occult exposure, it will be either because of dexamethasone or betamethasone or the potent steroids they usually do, and they will have a suppressed value of less than 3 microgram per deciliter. So florid Cushing syndrome, and you get a low cortisol below 3, it's less than 3 microgram per deciliter, you can get an ACTH also at the same time. So that will also be suppressed. So that is almost suggestive of Cushing syndrome. Again, there is data from PGI Chandigarh. So they said that 8 AM cortisol less than 3.6, it's more or less suggestive of exogenous Cushing syndrome. And if you have a 8 AM cortisol less than 7.7, so it more or less rules out endogenous Cushing syndrome. And if you want to go for more advanced tests, so that is not usually available in many of the laboratories on a commercial basis. So obviously there is urinary or blood spectrometry which can detect the finer nitty-gritties of glucocorticoid exposure. So once somebody has a glucocorticoid exposure, so these are the long-term management plan. So you know that somebody is going to require long-term glucocorticoids because of say some pharmacological reason. So you need to get some baseline investigation. You need to look into the bone health periodically. So for BMD, at initiation and 1 year post glucocorticoid, if it's stable, assess every 2 to 3 years, estimate the fracture risk by FRAX. you need to look into dyslipidemia, hyperglycemia, even blood pressure monitoring. You need to be careful about the eye also. That is also very important. Myopia can occur if you have features which can increase the intraocular pressure. You need to be more careful. Both glaucoma and cataract can occur with glucocorticoid exposure. Hypercoagulability, infectious disease, nephrolithiasis, neuropsychiatric manifestations again are all very common. Children, apart from bone health, you also need to look into the linear growth. That can also get curtailed. And we had this case that a young boy coming to the emergency admitted with pulmonary embolism after a DVT was actually was going to the gym, pushing out features, had actually exogenous Cushing syndrome, cortisol was suppressed, and because of the exogenous Cushing syndrome developed DVT and pulmonary embolism. So anything can happen because of this. This is a trajectory of recovery of HPA axis. If you are looking into the ACTH part, so that will recover first, followed by CRH, followed by cortisol, followed by androgen recovery. And again, there are some factors increasing the risk of AI. So if you are going for daily administration for more than 2 to 4 weeks, it can cause Cushing syndrome. Even 2 to 3 weeks of exposure is enough. So there is, again, I said, can be individual variation because of genetic reasons. So if you are, as I said, all types of steroid exposure can actually cause Cushing syndrome. And inhaled, if you are looking into inhaled formulation, which we usually think is safe, fluticasone is the one which is most notorious. And you need to have a plan for HPA axis recovery. So try to slowly shift if it's a huge exposure. So keep on decrementally reducing the dose. And once you reach a physiological dose of about, I'll take just 1 more minute, 5 mg of prednisolone or 20 mg of hydrocortisone, you can actually get a serum cortisol at 8 a.m. and you should not be giving steroids for last 24 hours, and try to assess whether the recovery of axis has taken place. So if it's less than 3 to 5, though then recovery has not taken place, 5 to 10 you can do a stimulation test to assess, more than 10 you can stop the steroid. So this is how, you can actually understand that the adrenal axis has recovered or not, but you need to bring it down to prednisolone 5 mg or hydrocortisone 20 mg, no exposure to glucocorticoid for last 24 hours, and you can do a cortisol. So points to note during tapering, so you really need to be careful about adrenal insufficiency. So the best guide is the symptoms, you need to be careful about that. And very, very important is patient education. So if you are telling the patient that the glucocorticoid, if it's in the process of getting tapered, so you also need to counsel about stress doses, when to increase, if the person is going for surgery, whether how it has to be modified. So there are some safe steroid strategy. This is the last slide. So if you are giving single dose in the morning rather than splitting it, alternate day if possible will help. Intermittent dosing, so some of the dermatologists give on Saturday, Sunday, that also helps. Lowest dose possible, and whenever possible, start steroid sparing agent. Always give, not done in our practice, but treatment card should be for all steroid users. For lifestyle changes, adverse effects to be monitored regularly. Infection has to be, so you avoid contact with infection. They have high predisposition to infection. And education and about sick day rules and discontinuation. So you go to any pharma shop, acha apni to steroid nichen ki korchen bondo kore den. So that should not be the case, because the person can actually land up in an emergency if he suddenly stops glucocorticoid. Thank you once again for your patient listening, and thank you once again to Crescendo team for inviting me back to my home city. I hope we all get justice in the coming days, and look forward to meeting you again very soon. Thank you.
Thank you, Dr. Saptarshi. If there are any questions regarding this extremely common topic of exogenous Cushing, I would like to. Dr. Mohan has a question, I think.
Yeah, just a small issue. What about this long-term patients? Because you told tertiary, because if you have any patient requiring how many years time it should take longest time?
So it can be 1.5 to 2 years if actually there is adrenocortical atrophy. So it can be very, very, very long. So they say that initial tapering you can do at a rapid rate. So if you are giving prednisolone maybe at 2.5 mg or 5 mg every week, or 3 to 4 days hydrocortisone, you can taper by 2.5 to 5 mg every week. So once you reach near the physiological dose, that is the time you need to be careful. If you have a difficulty in reducing the dose of glucocorticoids and the person is, and clinical features are the best judge. So if the person is having problem, so prednisolone dose should be reduced 1 mg or so every 2 to 3 weeks for patients who are having this problem. Hydrocortisone, if you are trying to taper, should be reduced by 2.5 mg per week, so or even slower. So it can take even up to 1.5 to 2 years with adrenocortical atrophy.
Some people gym also use exogenous anabolic steroids also. They also have the same problem.
So anabolic steroids per se, they don't have that much of glucocorticoid property. So some sort of additional glucocorticoid should be there. So they use this all strange concoction. So they will be taking like 4 times the dose of physiological replacement of testosterone. So you all don't know what is happening. They will teach you endocrinology. Okay, I have this. I'll take this dose of testosterone, then I'll have a HCG recovery, then we'll have clomiphene. So you will also get mad once you listen to them. So, but again, so this is something which we do face very, very often in our practice.
Sir, I have one patient where I could not taper exogenous Cushing's due to exogenous steroid Ayurveda medicines. The patient starts complaining when the hydrocortisone dose is tapered below 5 because she needs minimum 5. And she's stable on that. Her sugar, everything is there, and she is there for 2.5 years and more. So I can't stop. When I stop after 7 or 10 days, she starts complaining she is having some problem. Generally,
so again, so that is most probably I said it can take up to 2 years. So even there it can be in strange cases it can be even longer. So all related to that. So you really need to continue with as low a dose as possible, which is not giving you symptoms. You can do a cortisol estimation also. So last dose of hydrocortisone should be given in the morning prior, no evening dose of hydrocortisone. If you can get a cortisol level done. If it is more than 10, it's very unlikely that she will develop symptoms on stopping hydrocortisone. 5 to 10 is the range, as I already showed, that you can consider a low dose also you can do with 1 microgram, usually not done in there. Otherwise, if you do a typical 250 microgram corticotropin stimulation, so that the cutoff we all know is around 18 or 20 according to most studies. So, those are guides to assess whether you can take off this hydrocortisone.
No, just reacting to him, it's not the question of just adrenal insufficiency, but the mood elevating effect and the
Right.
feel good factor
Right.
of glucocorticoids. You have to, unless you explain, the moment you try to taper down or stop it, they have that feeling of depressed, like
Right.
feeling low, feverish. So we have to explain that why that should not be done.
Right,
So
right, right.
rather than an objective adrenal insufficiency, that also is a factor.
Right.
So after what duration of therapy with steroid, tapering should be done?
So again, so there is huge individual variation. So this can happen even after 2 to 3 weeks of exposure. So anything more than 7.5 mg, 2 to 3 weeks of exposure can actually cause. But usually, what we see is that if the person is given a short course of steroids less than 3 weeks, most of the cases you can stop straight away. Depends on the dose also, and depends on the clinical features also, and depends on individual variations also. There is actually, as I told, genetic susceptibility also to the dependence of metabolism of glucocorticoids. So that can also not always in our hand to estimate that or understand that, but it will, if a person develops symptoms even after say 4 weeks, then you might taper. But usually for practical purpose, if you're not using very high doses of say more than 20-30 mg of prednisolone, and for say 1 month, in practically it doesn't make much of a difference, but anything more than 3-4 weeks, more than 20-30 mg, it should ideally be tapered. And another reason is that you also need to understand why you are giving glucocorticoids. So there are 2 aspects of it. So one is obviously the chance of adrenal insufficiency, and if you do a too rapid tapering, so and if you are giving for an inflammatory condition, so there can be rebound of that also. So that is also another guide. So you need to balance both for to be sure how rapid you can do the tapering or whether you need tapering or not.
Thank you, Dr. Saptarshi. That was a wonderful discussion.
Thank you, thank you.
And I thank both the speakers for our approach to the patient session and close that session and quickly move on to guide to the practicing clinicians. There is a slight change in schedule. We will have Dr. Sachin Mittal from Chandigarh, who will be taking us through anti-obesity medicines. Dr. Sachin Mittal is founder of Sweet Diabetes Foundation, We Care at Home Health Services, Best Resident Award, DM Endocrinology, and lots of awards and presentations. Dr. Sachin Mittal for anti-obesity agents.
Good morning, everyone. At the outside, I would like to thank the organizers of Crescendo 2024 for the kind invitation and also congratulate them for the grand hosting of the academic event. The topic which we are going to be discussing today is in an area where there is a dire need, while at the same time, there is a relative lack of options, especially in our country, even though a lot of work is currently underway all over the world, and the future does indeed look much more promising than the past. We know that the prevalence of obesity is huge. The numbers have increased exponentially over the last couple of decades, and the numbers have increased exponentially in our country as well. Traditionally, it was not really considered a disease. You all know that, people were always considered like more healthy, slightly healthy category, or even, common language, khate pite ghar ke log, right? And it's only later on, over a period of time, we realized that probably obesity is the actual pandemic of the century, and obesity is the mother of all diseases, with ramifications in terms of development of all metabolic diseases in the long run. And over a period of time, there has been a shift of thinking with trying to destigmatize the whole thing, and the terminology has been moved to an adiposity-based chronic disease, or ABCD. The anti-obesity drugs, most of them have not had great outcomes in the past, and there has been a checkered history, and there have been more failures than success stories with the drugs which came earlier. And also, very, very important to remember is that most of the drugs that are now coming or are going to be coming in future, they will have a very big barrier in terms of cost sensitivity, in terms of price barrier, which probably might make it unaffordable for a large population which needs it. So this is what I meant when I said that there have been more failures than success stories. You can see over here that number of molecules which came from sibutramine with chances of myocardial infarction, stroke, to rimonabant with depression and suicidal tendencies, and other agents. There has been a lot of complications. So what currently therapy options do we have when it comes to pharmacological management of obesity? So you have an option called orlistat, which is there for close to 1.5–2 decades. It is, acting at the gastric lipases, causes almost 1/3 of the fat which we ingest passes through the GIT undigested, and as a result of which it translates into a weight loss, right? And then there are other options like phentermine topiramate, which basically works on the sympathetic nervous system as well as at the GABA receptor, and then there is naltrexone bupropion, which basically is a mu opioid receptor agonist, and also it actually basically has an unknown mechanism of action but works centrally. Then you have GLP-1 analogs like liraglutide 3 milligrams, semaglutide 2.4 milligram, both injectables, which have been approved overseas for the management of obesity, though not currently available in the country. And there is one molecule which has for a specific set of indications called setmelanotide, which basically kind of in patients with the MC4R receptor pathway activity is not established, so cases with POMC deficiency, PCSK1 deficiency, and leptin-4 receptor deficiency, where this is approved for those specific cases age 6 years or more, and it does lead to a remarkable weight loss, almost to the tune of 25% in those cases. But which are those cases where you will suspect that probably this child may be having a disease, obesity, which may be a genetic syndrome, which may be, requiring a therapy like that. So when you have a child with obesity, especially morbid obesity in the first decade of life, family history of consanguinity, family history of young onset obesity, dysmorphism like macrocephaly, visual defects, hearing defects, hyperphagia, and developmental delay. When you have the pointers, when you think there is something beyond in this child, that is when probably you can go on evaluating in those patients. So orlistat, as I said, that probably blocks the GI lipases, 1/3 of fat goes through undigested and translates into weight loss. How much weight loss? Alongside lifestyle modification, compared to placebo, you have, if you give it for a period of 4 years in a dose of 120 milligram 3 times a day, this translates into roughly about 6 kilos of weight loss over a span of 4 years, right? So that's the roughly, and the GI side effects are obviously expected, like cramping, GI discomfort, urge to defecate, as well as passing of repeated oily stools. Phentermine topiramate, again not available in our country. Central action, activates the sympathetic nervous system as well as augments the activity of GABA receptor, approved for close to 12-13 years by US FDA now. How much is the weight loss? After 1 year of therapy with phentermine topiramate at the highest possible dose, translates into roughly 10% of body weight loss in people with obesity. Naltrexone bupropion, again a central mechanism of action, and again after 1 year of therapy, the weight loss is roughly to the tune of about 5-ish odd percent. So to put it in a context, the therapies that we discussed, like orlistat, phentermine topiramate, naltrexone bupropion, mostly are targeting somewhere about say 6 to 8% of weight loss, and with phentermine topiramate in highest doses touching up to 10% of body weight loss. Then comes the GLP-1 analog. Specifically, I'm talking about liraglutide 3 milligrams, semaglutide in the dose of 2.4 milligrams weekly injectable, and tirzepatide, that is a dual analogs. So we know that GLP-1 analogs, how they work. All of us have used GLP-1 analogs quite a lot in our practice. We know that they have a central action through which they decrease the appetite, decrease the cravings. They have a peripheral action. There is a decrease in gastric emptying. There is an increase in insulin sensitivity, and many other factors. So the first GLP-1 analog approved per se for obesity without diabetes was liraglutide 3 milligrams once a day. So this basically, how much was the percentage of weight loss across different phase 3A trials? So there was roughly about 6% of body weight loss with liraglutide 3 milligrams once a day, right? So this led to the approval, but clearly much more was needed. This molecule, liraglutide 3 milligram injectable daily, or also known by the name as Crescendo, never came into the country, never was approved for weight management in our country. Then came the next molecule, which is semaglutide. Semaglutide, we know, has quite a lot of structural analogy with human GLP-1 analog. We have all used the oral version quite a lot. That is the oral semaglutide, which is available for approval as for diabetes, not for obesity per se, in doses of 3, 7, and 14 milligrams, also known as Rybelsus, commonly known as. So injectable semaglutide, as for a weight per se without diabetes, was tried in a set of trials called STEP trials. Step 1, 3, 4, and 5 were only for weight and did not have patients with diabetes. Step 6 and 7 basically included patients with diabetes, but specifically had a lot of Asian population. Step 2 had diabesity, basically weight management in type 2 diabetes mellitus. And step 8 trial was the one where it was head-on versus liraglutide 3 milligrams, right? The one where you see the yellow bar also. The yellow bar is the weight loss you see with 3 milligram. So most important thing is two parameters. What is the quantum of weight loss? How much percentage of patients in the trial are able to achieve that quantum of weight loss, right? So you'll always have a variation. You'll always have somebody losing a disproportionately higher amount of weight, somebody losing disproportionately lower amount of weight, right? And you will always get the variation. So on an average, if you look at a figure of 15% weight loss, which leads to a lot of metabolic improvements in the long run, the amount on semaglutide 2.4 milligram, the data shows that the literature was varying from about say 35% odd to nearly almost about say 60%. So you can see roughly the figure is over there. And when you compare it versus liraglutide 3 milligrams, about 12% of patients in that step 8 trial had 15% of weight loss with liraglutide 3 milligram, compared to almost 55% of patients with semaglutide 2.4 milligram once a week, right? So what kind of an adverse effects you can expect? Well, all the adverse effects that you see in a GLP-1 analog, the pooled data from step set of studies is similar. About 20 to 30% of patients on an average do have some GI side effects like nausea, vomiting, diarrhea, etc. But thankfully, majority of those patients, the side effects were not severe enough, right? So semaglutide, 1 milligram injectable once a week, or oral 3, 7, and 14 milligram for diabetes. Oral 3, 7, and 14, as I highlighted earlier, available for diabetes in our country. 2.4 milligram once weekly semaglutide for obesity per se, not available in our country, but it is said that probably we should soon be getting it. We are hearing about it for almost like 1 year now, but probably next 1 year or so, you should be getting oral injectable semaglutide for 2.4 milligram once a week. What beyond that? What next? Is that kind of a nadir? Is that kind of the maximum you can achieve with injectable semaglutide, that the amount of weight loss? So there is a study undergoing with injectable semaglutide to 7.42 milligrams. So the actual dose approved currently is 2.4 milligram. This is a step study which started in January of 2023. It is scheduled to finish in October of 2024 with about 1,400 participants. And it's looking at this one question, that if you increase the dose up to 7.2 milligram weekly, do you get more number of patients achieving 15% weight loss? Are you able to touch that category of 20 to 25% weight loss on a more consistent basis with 7.2 milligram oral injectable semaglutide once a week? So this is what probably in next few months we should be getting the data. And similarly, oral semaglutide 25 and 50 milligram in the OASIS set of studies has been studied per se for obesity. Interesting thing to understand is that 50 milligram oral semaglutide daily had efficacy in terms of total body weight reduction of close to 17%. And the percentage of patients who were able to achieve more than 15% weight loss was similar as per injectable 2.4 milligram once weekly semaglutide as it was with oral semaglutide 50 milligram daily, right? So that's why, so that is another interesting thing to understand. So in oral semaglutide 50 milligram, almost half of the patients were able to achieve more than 15% of body weight loss, and about 1/3 of patients actually were able to achieve a body weight loss of close to 20% also. So semaglutide के बारे में बहुत डिस्कस कर लिया. Semaglutide हम सब ने यूज करा हुआ है, and आजकल तो obesity में बहुत कुछ आ रहा है. तो नया क्या हो रहा है? What new is happening? So lot of other developments are happening. So there are many oral GLP-1 analogs which are currently in the pipeline, right? So this is one molecule which has produced wonderful results in phase 2, already undergoing phase 3 by the ACHIEVE set of trials in patients with type 2 diabetes, for the ATTAIN set of trials in patients with obesity without diabetes. And the name is orforglipron, right? So you think of this name and see, why is it so different? अभी तक तो सारे टाइड आए थे, लीराग्लुटाइड, सीमाग्लुटाइड, tirzepatide, exenatide. अब ये ग्लिप्रोन कहाँ से आ गया? How do you get that? So the interesting thing is that this is a oral non-peptide GLP-1RA. So when oral semaglutide came, they promoted as peptide in a pill, right? This is an oral non-peptide GLP-1RA, and it does not have the restriction of dosing conditions that you have with oral semaglutide. So it is a different molecule. I tried to find out what is the structure. The structure, as it was said in the publication, it's a proprietary structure not disclosed. So we don't really know what exactly is this, but it does have good results in phase 2. And similar molecule, actually 2 molecules have been tried by Pfizer for the similar thing. Danuglipron, oral GLP-1, again a big study undergoing for this particular purpose. And then they tried another one called lotiglipron, which was withdrawn because of liver toxicity. So these are exciting future developments, but they're some way off. What is something which is more closer to us? What is something which can probably come more nearer in the future? That is tirzepatide, right? So tirzepatide, it is a dual GLP as well as GIP agonist, the GIP-GLP, right? A weekly injectable studied in both diabetes and obesity. So what you have with dual agonists? You have with GLP-1 analog, everybody knows, increased satiety, decreased food intake, higher nausea, decreased body weight, and alongside other actions like decreased gastric emptying. When you have a chronic GIP agonism, these actions are kind of accentuated except nausea, right? So nausea actually in tirzepatide data is lesser than with standalone GLP-1 analogs, and then you have additional advantage in terms of higher insulin sensitivity, higher lipid buffering capacity, and better metabolic outcomes like decrease in hyperglycemia as well as decrease in triglycerides over a period of time. What is the percentage weight loss with tirzepatide, right? So with tirzepatide, you have 2 set of data, SURPASS trials, SURPASS 1 to 5 with diabetes, and SURMOUNT trial with obesity without diabetes. SURPASS 2, they had the comparator, which was actually semaglutide injectable 1 milligram once a week, right? With tirzepatide, with dose of 15 milligram once a week, you have weight loss reaching up to 21%, right? That is among the highest which is in the molecules currently available. So when you look at the future, what you have basically is GLP as a kind of a backbone, right? And then the other therapies are kind of piggybacking on it, kind of adding on to it. You have a GIP agonist which is adding on to it, tirzepatide we discussed. There are a number of others which are then some of the mechanisms of actions are still not completely understood. Then you have glucagon agonist added to it, right? So then in glucagon agonist you have number of molecules which are under development like survodutide, pemvidutide, number of other molecules which are available. And then you have a triple agonist, GIP, GLP, as well as a glucagon agonist. And then you have some other combinations that are being tried like amylin agonist alongside GLP-1 or PYY agonist alongside GLP-1, etc. So in a nutshell, what you get when you have those additional agonists added, you get an additional action. And you get a better safety profile, you get a better tolerability profile, you have a lesser GI side effects, you have an increased energy expenditure, you have a decreased appetite, you have a decreased craving, which is further accentuated when you have these molecules which are added onto it, right? So for instance, with a glucagon, one of the thoughts was, does it lead to a higher glucose level? But it doesn't. When you have a combination of a glucagon agonist as well as a GLP-1 agonist, it doesn't lead to hyperglycemia actually. On the other hand, there is higher lipid oxidation, higher energy expenditure, translating into better weight loss, translating into better resolution of MASLD, etc. Similarly with the myelin, GIP, etc. So the dual agonist, the theory is that when you are clubbing two mechanisms, it leads to better appetite suppression, better control of parameters, lesser side effect profile. So with GLP as well as glucagon, the two molecules which deserve mention is cotadutide as well as survodutide. Look at the amount of weight loss with survodutide to the tune of almost 18% of weight loss, which is currently already gone into the phase 3. This molecule actually showed nearly 25% patients which withdraw because of GI side effects. So this needs more titrating. So lastly, we have a triple agonist, that is retatrutide, right? This molecule has shown a very good data in terms of weight loss, almost with the highest dose reaching up to 24% of body weight loss, equivalent to some of the metabolic surgeries, right? And some combination injectables that are under development. This is a combination of cagrilintide, which is an amylin analog, plus semaglutide, both once weekly injectable. Very good set of data with very good set of weight loss, plus 15% in majority of patients' weight loss, right? So you're having two molecules separately. Why not club them into one molecule? So this is what is happening. You have a molecule which is a single molecule, not a combination injectable, with oral as well as subcutaneous, which is formulation being tried, GLP as well as a myelin receptor agonist, right? Again, wonderful set of data in initial studies. So going away from this incretin, twin cretins, tricretins, etc., one very interesting, there are a lot of other pipeline molecules which I'm not going to discuss over here, but one very interesting is this particular molecule which is being tried by Novartis. It's a monoclonal antibody which inhibits myostatin, which basically has a negative regulation on muscle mass. So as a result of which, when you are inhibiting myostatin, as a result of which, you have a fat mass going down almost to the tune of 21%, but the muscle mass going up to the tune of 4%. Right? So it's an interesting thing which is being tried. So overall, if I want to put the crux as to how much percentage of weight loss with different molecules, you just look at this. Even although these are all different set of patients, so not strictly comparable, but the highest amount of percentage weight loss you get over there with retatrutide to the tune of 25%, followed by tirzepatide to the tune of 21%, followed by survodutide to the tune of 18%. And then you have the SEMA or SEMA derivatives like oral semaglutide as well as CagriSema to the tune of 17%. More importantly, how much number of patients are able to achieve at least 15% body weight loss? So you, again, the highest number over there is with retatrutide, almost 80+% patients, followed by tirzepatide with close to 78% patients who are able to achieve at least 15% body weight loss, followed by survodutide. So a lot of pipeline molecules are available. So 5 C's you need to remember: coverage, availability. Well, they will become available over a period of time, but affordability will remain a challenge. And over a period of time, over a period of time, we will have lots and lots of options. Contraindications we need to remember, especially with GLP-1 analogs as a base, pancreatitis, medullary thyroid carcinomas, familial histories, men's, etc. Comorbidities like diabetes and GLP-1 RAs obviously help. SGLT2 inhibitors, not per se for weight, but yes, in this setting we can use. Cravings, obviously, GLP-1 RAs, genetic, you think of a molecule, which you think of the combination and then think of its combinations, again, so lack of pharmacotherapy options has been a challenge. GLP-1 RAs have a huge potential. We need to determine whether the molecules will be able to bridge the gap up to surgery. Obesity actually is the pandemic of the century, and medical energy balance is not such a simple thing as thought of earlier. It is not to be stigmatized. Gut-based molecules are the future, and there is a comprehensive multidisciplinary management which is needed. So to conclude, the gap between diets and bariatric surgery that is currently tried to be filled by medical therapy. So thank you so much. If there are any, for your kind listening, if there are any questions, I'll be more than happy to take any questions. I'll hand over the stage to the.
Yeah, I have a question.
Are there any questions?
Yeah.
Yes, please.
As long as the combinations are not yet available, how effective would be off-label use of bupropion alone or topiramate alone?
So this question I had asked actually a couple of people. I have never tried it. Most of the people say that it doesn't really work.
Is there any data of use of this individual drug and for different uses? For example, when bupropion is used for anxiety, when topiramate is used for migraine, how are they losing their body weight? Is there a trial? And that way you can understand whether it will be effective. You need not give the drug for that particular purpose, but you can always follow them up.
So there is no particular set of data with this. There is a particular set of data when they have a phentermine separately and they have a combination of phentermine topiramate. So combination gives about 10-ish% in the highest doses, and separately that's about 5-ish%, right? So, and the sympathetic side effects that are there in this set of therapy.
Sir, if I may also ask.
Yes, sir, please.
So we have a current situation where the GLP-1 analogs available to us, be it for management of diabetes or obesity, there is often scarcity conditions. So in that scenario, do you have any advice regarding interconversion of GLP-1 analogs being used? If one's not available, how to switch to another one?
So you have to basically, just use your clinical judgment. There will not be a guideline in that. So like for instance, right now, I don't know what is the status like in Kolkata, but in Chandigarh where I practice, there has been a situation where last 3-4 weeks, there has been a shortage of dulaglutide, right? That injectable dulaglutide, right? So initially, those who were on 1.5 milligram, I once tried putting one of the patients on 14 milligram semaglutide, but the molecules are not same, right? There is a difference. So now what I've seen after doing that is that I put the patient who is on 1.5 milligram weekly of dulaglutide to 7 milligrams of oral semaglutide for a span of about 20 days, right? So then if the patient is feeling all right, I go on to 14 milligrams, right? That's what, but the approval is for diabetes, not for obesity per se.
Right.
And the dose for obesity, which has been tried in OASIS trial, was 50 milligrams, and it did work wonderfully well, almost equivalent to 2.4 milligram once weekly injectable semaglutide. Even higher than, because with injectable once weekly semaglutide, the weight loss was about 15.1% mean weight loss, and with oral semaglutide 50 milligram, it reached up to 17.2%.
Right, sir. Thank you. Thank you so much, sir. Any other questions for sir?
Thank you. Thank you so much.
Thank you. Thank you, sir. Can we have the introductory slides for the next speaker up, please? Calling Dr. Lakshmi Kopale, ma'am, for the next session on hypertriglyceridemia, another important problem for us clinicians. And the stage is yours, ma'am. Can we have the slides up, please?
Good morning, everyone. At the outset, let me thank the organizers for giving me this opportunity to speak today. Today, we are going to discuss about hypertriglyceridemia. Relatively boring topic, but pretty important topic when it comes to clinical scenario. And almost we see multiple cases every day in our OPD which require our attention to be paid towards high triglyceride levels. So today I'll be dealing this topic toward in these categories, and let's start with a quiz. Which component of the diet predominantly influences fasting hypertriglyceridemia? You can raise your hands. Is it A, B, fats, C, protein, D, carbohydrate and fat? Many people have said carbohydrate. Let's see the answers in the end, and some have said carbohydrate and fat. So the second question is, what is the most common cause of hypertriglyceridemia? Is it familial hypertriglyceridemia, dis-beta lipoproteinemia, diabetes mellitus, or CKD? Answer is C. So let us see in the end. The treatment options for hypertriglyceridemia in first trimester of pregnancy are all except A, insulin, B, fibrates, C, omega-3 fatty acids, D, heparin. So someone said fibrates, B. So let's see the answers as we go through the session. So thank you so much for participating in that. So what is the basic question that we need to ask ourselves about hypertriglyceridemia? Why should we know about it? Because it increases the risk of cardiovascular disease, it increases the risk of pancreatitis, and most commonly it is because of some other cause which increases the cardiovascular risk. So it's important to identify that secondary cause. That is why we need to know about hypertriglyceridemia. And what other thing that we need to know? We need to know that in both the genders, with the increase in age, triglyceride levels increase. So how is this triglyceride going in blood? It is going in with like chylomicrons as well as VLDL. So when we are saying hypertriglyceridemia, there must be a scheme in which we need to identify and then go about treating the particular patient if we have to. So how do we do it? Firstly, we have to confirm whether it is really present or not. For that confirmation, a fasting sample is essential. And evaluation of the magnitude becomes very important, and for this various associations have given a lot of classifications which tell us about the severity of triglyceride level rise. And then, as we said, determination of the cause is important, and secondary is more important than primary, and secondary confers a lot of cardiovascular risk. So ruling out of the secondary cause and treating it appropriately when present is very important. So moving on, as we said, the definition and magnitude of hypertriglyceridemia is very important. There are many associations which have given this. The most complex of this, and which we often follow, is Endocrine Society guideline, wherein less than 150 triglyceride level is considered normal, and mild, moderate, severe and very severe are likewise. And ADA has a very simple classification. 175 to 499 is moderate, above 500 and above is severe. So these are the classifications. And why do we have to know about triglyceride level? Why do we have to treat? 2018 ACC guidelines say that we need to treat hypertriglyceridemia because of the risk of the pancreatitis that it causes. But then we need to understand that the level of triglyceride at which pancreatitis occurs and the level at which the cardiovascular disease occurs, the cardiovascular limit is much, much lower. And having said that, it is important to understand that it is not merely the triglyceride level. It is the associated thing which is present along with the triglyceride level which is conferring this excess cardiovascular risk. So identifying clinical and metabolic evaluation of such a patient is very, very essential, and we should just not ignore a high triglyceride level. So moving on, what are the important practice points to remember? Firstly, confirming a fasting level in a fasting sample is important, and in routine lipid panel, we know that LDL is always calculated. Most common method is Friedewald formula. And when is this Friedewald formula applicable? When triglyceride is less than 400, only then it is applicable. If triglyceride is more than 400 and you are you want to know the LDL level, what will you do? You do it by beta quantification, or it is said that Sampson-Ennis equation gives a much better level than the Friedewald formula, even when the triglyceride level is just above 150. So these are the other methods in which we can calculate LDL in the presence of hypertriglyceridemia. So let us understand high triglyceride levels with respect to a case. This is a 40-year-old male, a senior executive in IT industry. Definitely a lot of stress is present, strong family history of diabetes, relatively normal BMI, and no signs of insulin resistance was present. Minimal anterior abdominal obesity was present, and he underwent a routine master health check. So what did we find in master health check? The triglyceride level was 682. So we went on because it's a master health check. We had the good luck of seeing all the tests everywhere. So we looked at the thyroid profile, normal, TSH was 1.4. And then we looked at the sugars. Fasting was 312 and HbA1c was 11.9. No symptoms of diabetes at all. So we look at our algorithm in a disciplined manner. So was it a fasting sample? Yes, it was a fasting sample, 682 triglyceride. So evaluation and magnitude, we remember that according to Endocrine Society guideline, it is 682 is moderate hypertriglyceridemia and it is severe according to ADA. So we put it as moderately severe hypertriglyceridemia according to Endocrine Society. So our diagnosis was type 2 diabetes and secondary moderately severe hypertriglyceridemia. So ADA 2024, what does it say? Because we all follow most of the ADA guidelines, it divides into two easy categories, less than 500, more than 500. And less than 500, we need to look for secondary causes, secondary causes, secondary causes. That's what ADA tells us. And then we need to consider medical therapy. It's not an absolute must, but we need to consider therapy for treatment of hypertriglyceridemia, and treatment of secondary cause also is important. So fasting triglyceride level, when it is 175, you have to address the lifestyle. You have to look at all the risk factors which are present. And additionally, which we often miss, is the medications with regards to triglyceride level. There are certain medications which increase triglyceride level. Is the patient taking that? That should not be missed, especially when it is between 175 to 499. So moving on to our case, our patient vehemently reduced insulin and anything to do with his cholesterol levels. So we put him on oral anti-diabetic medications, and within 3 months, and emphasized on lifestyle measures. Within 3 months, that was April, and this was in July, we found that with adequate lifestyle and OADs, fasting glucose came up to 117 and glycated hemoglobin came to 6.3%, well-controlled blood sugar levels. But because the levels were more than 682, we told the patient to undergo a lipid profile within 1 month itself, wherein when we see the lipid profile here, we see that the triglyceride has come down to 113 within a matter of 4 weeks with adequate, appropriate glycemic control. So the take-home messages from this case are two important things. Firstly, look for the secondary cause, address and treat them adequately. We did not do anything other than address these factors. And second thing is, the most common cause is secondary cause, diabetes mellitus, please keep it in mind, and obesity is the other one. We have to think of it when we look at high triglyceride level in an adult. So moving on to the case 2. This is a 26-year-old admitted with pain, abdomen, vomiting, breathlessness of 1 day duration, diagnosed to have diabetes in January of 2022. He is a known case of severe hypertriglyceridemia, diagnosed at the age of 3 years. Father also has the same history. He had 25 episodes of pancreatitis since 2012. Those are all his files which he came with. 25 episodes and admissions for pancreatitis. So we put a diagnostic algorithm with him, obtaining of a fasting sample and all those things. When we took his fasting sample was milky white. Triglyceride level was 4000 milligram per deciliter. Very, very high triglyceride level. So when we looked at other parameters, we found that the pH was reduced in ABG. Acidosis was present. Amylase and lipase levels were increased. Total cholesterol was 22,000, total counts were 22,400. So the picture was pointing towards DKA. So we put in a diagnosis of primary hypertriglyceridemia with recurrent pancreatitis and secondary diabetes who presented with DKA. So we did treatment with IV fluids, insulin infusion, potassium correction, IV antibiotics, stabilized the patient and discharged on basal bolus regimen, pancreatic enzyme supplementation, vitamin D replacement, fenofibrate, rosuvastatin, niacin and omega-3 fatty acids. When we did this, his triglyceride levels were controlled. We would say around controlled because they were around 300 to 400. So it is important to understand that hypertriglyceridemia is one of the most important causes of pancreatitis. 10% of the cases are because of this. So it's not easy when you're looking at some level, you cannot just leave it aside, but you have to take it seriously and treat this particular person. It is probably because the plasma viscosity increases, this happens. We exactly don't know the mechanism behind it. This triglyceride definitely of this magnitude can impact the pancreas. So you have to be very careful when treating such patients. So moving on to understand the cause of hypertriglyceridemia. time and again we've been telling again and again that our triglyceride levels are high mostly because of some other cause. It is not primarily affected. So what are the secondary causes? So I hope the slide is visible. Obesity, diabetes, hypothyroidism, all these are what we see every day in our OPD. And so many patients on estrogens, SERMs, glucocorticoids, all these medications also we see in our OPD routinely. So it is important to keep these things in mind and understand that everyday cases also we come across hypertriglyceridemia and it needs to be addressed and we should not ignore it. So when we are talking about secondary again and again, there must be something which is causing abnormality in the triglyceride metabolism. So those are the primary hypertriglyceridemias which are incredibly rare. But then when we come across one of a patient, we need to address the situation. So we need to understand the basic common varieties, considering the rarity of it. These are the three commoner varieties. Of them also, the most common is the multifactorial chylomicronemia syndrome. So when it comes to FCS, that is familial chylomicronemia syndrome, it is rare presence, early failure to thrive, all those things are present. And when it comes to multifactorial, because it's multifactorial, it is polygenic, it occurs late, usually the risk of ASCVD will be present. And partial lipodystrophy syndromes, we all know that based on the lipodystrophy, we can classify into Donegan or Cobbling variety. So going back to the drugs, it's very important that we understand the common drugs. Alcohol, how often do we see it as a medication? We don't. It's just seen as a habit. But then if a person is taking considerable amount of alcohol every day, definitely it is going to increase triglyceride levels. And also many people have, especially people coming from villages, they have a notion that they can't take sugar for diabetes and they take honey. And they take lot of honey thinking honey is very, very, very good. So increased intake of honey, more than 90 grams per day, can also cause hypertriglyceridemia. So beta blockers, diuretics, oral estrogen, SERMs, all these things cause hypertriglyceridemia and we need to keep them in mind while evaluating. So moving on to case 3. This is a case from a colleague and not my personal case. This is a 28-year-old primary gravida, 29 weeks period of gestation, presented with acute onset epigastric pain, nausea for 24 hours. Definitely, she is a case of pancreatitis, lipase is 505, total cholesterol was 1651. When triglycerides were done, they were more than 3000. So no family history was present, unlike our case 2. So abdominal ultrasound also showed probably it's a pancreatitis was present. So she was treated with gemfibrocil 600 milligrams twice a day, icosapentethol 2 grams orally twice a day, and subcutaneous heparin, insulin, and still serum triglyceride level remained 3425 after 1 week of treatment also. So they initiated plasmapheresis for her. So triglyceride decreased to 721 and we were happy seeing a 3-digit number for this particular patient. In fact, my colleague was telling they were relieved to see a 3-digit number though it was 721. So on day 6 of the hospital again, triglyceride level rose to 1245. So second plasmapheresis was done and TG came down to 770, which again rose the next day to 1365. Relentlessly triglyceride has been rising again and again in this particular woman. So third plasmapheresis was done. And after this again it was stable for around 4 to 5 days and then again it rose to 1347. So triglyceride here in this patient liked to be only in 4-digit numbers. So what they started was they started twice weekly preventive plasmapheresis, total 8 sessions were done, and at 36 weeks she was delivered uneventful and the baby and the mother were all right. So 1 month later her lipid profile while on the same medications was done, it dramatically improved. Total cholesterol from 1600s came to 233 and triglyceride was 304 while on the same regimen. So what must have happened? We put a diagnosis of 29 weeks period of gestation, hypertriglyceridemia resistant to treatment and pancreatitis as the diagnosis. So what do you think was the cause? Progesterone, estrogen, human placental lactogen and the cortisol that rise during pregnancy increase plasma lipids and especially so in this susceptible woman have caused such a very high level of triglyceride. So we need to remember that when we are treating a pregnant woman, we need to balance the nutrition versus nutrition excess. So treatment with all these medications is okay, but remember fibrates cause teratogenicity and are contraindicated in first trimester. Our patient presented at 29 weeks, so she was started on gemfibrocil. So moving on, the take-home messages from case 3 are all these hormones are impacted. Low-fat diet and nutritional support with omega-3 and medium-chain triglycerides is important. Challenge is to carefully balance fetal nutrition needs and the needs of the mother. That's a very, very difficult thing, easier said than done. So what are the treatment tenets in general? Forget about pregnancy, forget about other things. When we are looking at hypertriglyceridemia, what are the basic things? You need to know that risk factor modification, including tight glycemic control, has to be done. Patient selection, what are we doing for that particular patient is very important. And indications for lipid lowering therapy have to be seen. And pharmacology of lipid lowering drugs should be known. Having said that, Interheart study says that decrease the risk factors, 90% decrease is there in the cardiovascular event and myocardial infarction. That's what it said. And ACC, AHC also recommend lifestyle measures as a first prong. Diet, physical activity, weight management. ADA also says it is DASH diet and change the lifestyle is what ADA also tells us. And we have seen that more than 500 what we need to do, and when it is moderately severe also we know what to do. So coming back, we see these are the drugs which are present: fibrates, omega-3 fatty acids, nicotinic acid, and mipomersin and lomitapide. These are the medications which are available currently to treat hypertriglyceridemia. Mipomersin and lomitapide will not be dealing with at all today because of their prohibitive costs. About mipomersin costs about 19.5 lakhs per month to treat hypertriglyceridemia. I think we have better ways of doing it. Maybe lifestyle is the most and cheapest and most effective method. So coming to fibrates, we know how they act. They lower 30 to 50% and they also change HDL to marginally. And fibrates adverse effects, we need to understand about GI effects, pruritus, gallstones risk, all these things are on the higher side, so we need to keep that in mind. And we never combine fibrates with statins, and that is not recommended actually. So coming to omega-3 fatty acids, these are fish derived. We give about 3 to 4 grams is effective. Somehow omega-3 fatty acids do not affect HDL at all. They impact only triglyceride levels and they have minimal effect on this. And coming to niacin about 2 grams. Niacin is one of the most effective drugs in changing HDL levels, and it also impacts the triglyceride level. But pregnancy is a very big contraindication for niacin, though we had given in this patient. Baseline transaminases need to be checked because increase in transaminases level and hepatotoxicity can occur within 6 months of niacin use, especially on the higher side of the doses. So discontinue temporarily if transaminase rise occurs, and look for flushing and other side effects, pruritus, so that you identify that niacin is causing hepatotoxicity. Meanwhile, let's go back to what we have to do. First thing, confirmation, evaluation of the magnitude, determination of the cause, and ruling of out of the secondary causes are the basic things for hypertriglyceridemia treatment. So let us know the answers for our quiz, shall we? So the first answer is carbohydrate is correct. It's not carbohydrate and fat, but it is predominantly only by simple carbohydrate and the carbohydrate level in the diet. And second is, which is the most common cause, diabetes mellitus, again, that's correct. And third, the treatment options for hypertriglyceridemia in first trimester of pregnancy are all except fibrates, because fibrates cause teratogenicity. That is why we do not give fibrates. So this is the answer. Thank you so much for your patient hearing.
Thank you, ma'am, for that excellent elucidative lecture on hypertriglyceridemia and all the updates on it. So the session is now open for questions to the audience. Do we have any questions for madam?
Yeah, may I have a question? Dr. Pramanik here. Ma'am, you didn't mention anything about the saroglitazar, because in diabetic dyslipidemia with high triglyceride, there are lots of data on saroglitazar. Your take on it?
Yes, saroglitazar is preferred, especially so when we have a case and there's a fatty liver and effects are also seen. So saroglitazar can be considered, but often the patient comes back with a non-compliance history. Mainly in my patients, it is the cost is been issue for my patients. But it is good in glycemic control because it has both PPR alpha and gamma effects. It is theoretically good. Practically also we are seeing good in good levels after starting it. But unfortunately, patients are discontinuing for various reasons.
Thank you for that excellent talk. See, we usually link triglycerides and HDL together, one going up, one going down. But in our day-to-day practice, we get to see a lot of isolated cases of HDL lowering. So how important, how seriously do we take that, and what can we do at all about it?
If I understand the question properly, isolated low HDL levels.
Yes, exactly.
Isolated low HDL levels reflect physical activity, and if a patient or a person is coming with very less physical activity and a lot of sedentary time, HDL isolated can be on the lower side. That is indication that we need to decrease the sedentary time and improve the lifestyle measure of this particular patient.
That is the basic, but often that doesn't work. Do we have any agents to help us out?
Even though several agents have been tried, HDL has 3 components. So the functional component doesn't usually rise. It is the non-functional component which rises and shows us an increase in the HDL level. So often pharmacological agents fail in increasing the functional component, so much benefit is not seen. With certain agents which reduce triglyceride levels, we see a benefit. In fibrates also we see a benefit, but it is not the functional component which increases even there. So we should not be taking it easy when we are seeing, okay, HDL is rising. The first foremost step is in correction is to take care of the lifestyle measures and issues in the lifestyle when handling the lipid disorders.
Thank you.
First of all, I must thank you for your very good lecture. I want to know what are the vegetables and what are the fruits that may increase or decrease the triglyceride.
None of the vegetables can increase, sir, and potato is not considered a vegetable. So all the starchy vegetables are not a good thing for triglycerides. Rest of the vegetables are all right. Any fruit in moderation is all right, but should be avoiding in diabetics because blood sugars can increase. We have to give fruit which has low glycemic index like raw guava, apple, pear, kiwi, things like that should be given because hypertriglyceridemia often in our country is secondary to diabetes mellitus. We need to keep that in mind also when prescribing this.
Hello. Actually, according to the NICE 2040 guidelines, the necessity of fasting sample to assay the lipid profile has been obviated. So it is very much mandatory to take the fasting sample for triglyceride assessment.
Yes, triglyceride is directly impacted by the fasting level. 8 to 12 hours of fasting is essential to confirm the presence of a triglyceride abnormality. Because of the nutritional intake within 8 hours, that impacts the triglyceride level, and we are trying to see whether it is high or not. It is mandatory to have a fasting sample there. And NICE, when it has abolished the fasting sample, it has stated the convenience factor much more than anything else for doing this test. So that is the reason. And in Western population, LDL is much more important than triglycerides. In Southeast Asians, LDL as well as triglycerides both are important. So considering a sample for LDL when we are taking, fasting status doesn't matter. It is okay. But it is NICE also mentions that it is convenience rather than anything else in abrogating the requirement for fasting for testing lipid profile.
What has been there rationally in obviating the fasting sample is that in hyperlipidemia or hypertriglyceridemia, there is downregulation of the carrier protein. Hence, the dietary influence is not that much in those cases.
It is important for triglyceride levels, sir, but not for other lipoproteins.
So there will be no downregulation of chylomicrons in them.
But then chylomicrons are present only when we are looking at triglyceride. It is present only in the chylomicron fragment as well as VLDL. And when we are looking at LDL fragment, that does not change with diet.
Okay, thank you.
Thank you, ma'am. Thank you for all your questions.
Nice talk, as usual. Very simplistic clinical scenario for most of my juniors and PGTs. When we add ezetimibe or bempedoic acid to statin, which in any way we do add to diabetes, we find quite a considerable decrement in triglyceride level. That's one point I think we should be aware of. And secondly, what do you think? I mean, when in spite of good glycemic control, triglyceride is not coming down, do we need to put these patients on this type of combinations, or do we have to look at other niacin or other things, as you have pointed out?
A very good question, sir. Firstly, we need to understand whether all the lifestyle measures are in place or not, or is it just the medication effect? The patient is taking a statin and the LDL goals are achieved, and the patient is not doing any lifestyle measures. So it's very important, and triglyceride levels often point us towards a lack of physical activity and any attempt towards a good lifestyle. So whenever LDL is within the goals, but triglyceride is not within the goal, that is one pointer towards the lifestyle measure. Second thing is addition may be beneficial, but if we are not correcting the baseline problem, how useful would it be to add so many medications? So correcting the underlying sedentary lifestyle, diabetes and weight, if we can't do that, then increasing and adding medications will only offer temporary relief.
So right, thank you, because ultimately we have to correct the, the comorbidities associated with it. Thank you.
We are ending the question answer. Any other questions will be addressed outside.
I've got a question to ask.
Please make it the last one, sir, because we have a program to continue.
In continuation to what Dr. Dutta was asking, I have just two questions which coming to my mind. I often ask my patients to take fruits, the diabetes mellitus people. Now, the problem is, you just now said that banana is probably not advised. Is it true?
High glycemic index, sir.
Acha, is there any variety, is there any difference between the varieties of bananas? There are two or three.
Probably if a nutritionist is around in the room, they can answer this better, sir, than me.
Okay, now the last question is pakka papaya okay?
High glycemic index again, and nutritionist can answer it better than me.
Thank you. The session is closed for questions. Thank
Thank
you,
you
ma'am.
so much.
Thank you, ma'am, for that excellent lecture.
Ending this guide to the practicing clinician session, and I think our clinicians have some guide. We move on to the practice pearl session. For that, I'd like to invite on stage Dr. Vagish Iyer sir from Bangalore, who will be taking us through a diagnostic approach to a girl who is virilizing at puberty. Can I have his CV on the screen? Vagish Iyer sir. Dr. Vagish Iyer is professor and former head of the department St. John's, Bangalore, and he is the former president of Karnataka Endocrine Society. Lots of publications and contributions to book chapter, orations, and sir will take us through a girl who is virilizing at puberty. Sir.
Good morning. Thank you at the outset for a kind introduction and also inviting me for this conference. So next 15 or 20 minutes, I'll take you through a journey of a girl who is virilizing at the pubertal time. So we'll take through a case scenario. 11.5-year-old girl with noticed progressive clitoromegaly from past 6 months from the age of 11 years. Birth history uneventful just to suggest that there was no ambiguity. Normal female genitalia. Had mild psychomotor delay, not known why exactly, but did go through a schooling. Noticed pubarche and thelarche at the age of 10 years. Then currently she is 140 centimeters, about 1 SDS less than the expected, and weight is 20 kg, BMI is appropriate, blood pressure is normal, very important when we see a virilizing at this. Electrolytes are normal because CH is the most common thing what we think about, that's the reason this BP and electrolytes have been put. SMR B2, not much for the duration she has got of a puberty, 1.5 years. Axillary hairs are plus, and there is a P5. So genitalia, significant noticeable clinical finding is a clitoromegaly. No other signs of a virilization. Most of the time when we say virilization, there has to be a temporal balding, loss of hair, defeminizing things. Probably it comes with the time. In this girl, it's only a clitoromegaly, not much of other signs of virilization. No syndromic features to notice, mainly a Cushing's. So we know that virilization at puberty is a quite rare disease. We may see once in 3 months or 6 months in an institute, or it may be once a year in a private practice. It is a manifestation of a severe androgen excess. When there is a mild androgen excess, they present with a hirsutism and acne. When there is a severe androgen excess, that they present with the virilization. It can be because of a genetic disorder, because the child is coming at the age of 11.5 years. Can be an acquired because of the certain diseases which I will be mentioning. Most important genetic cause happens in both. It can be 46XX female or even a 46XY female. And it can be secondary to the drugs, misuse or inappropriate use of a drugs, most commonly a tumors, adrenal or ovarian tumors. Genetic causes are a most important thing to be considered in a child. That's why gonadal dysgenesis is the most important, where there is an aberration of sex chromosomes and also some of the genes which are involved in the gonadal development, like WT1 and also an SF1, that is the NR5A1 thing. 46XS congenital adrenal hyperplasia is the most important thing one we should consider. It can be an 21 hydroxylase deficiency or 11 hydroxylase deficiency or 3 beta HSD or even a P40 oxidoreductase deficiency. Very rarely you can encounter 46XX aromatase deficiency, and you also see a 46X5, like persons with 5-alpha reductase, 17 beta HSD3 deficiency, even a partial androgen receptor disorders can be present in a female appearing 46X5 DST. So gonadal dysgenesis is one of the rare things but needs to be considered. It is because of the incomplete testicular or ovarian differentiation. So that at puberty one of these things kicks off, mainly a testicular thing kicks off, or sometimes there may cancerous transformation which results in the virilization. Most of these children will have an ambiguity at birth, but in this patient is only she is fine till 11 years, then only she has presented. So most of these gonadal dysgenesis do have a ambiguity at birth, need not be all cases, and it can be an isolated without any other things with genetic anomalies, and there are a lot of genetic causes which you can go through. Acquired causes are very few because source of androgen in women is only 3. One is adrenal, another is ovary, and other one is a periphery, that's in the adipose tissue or in the skin. So adrenal tumors, most common is the adrenal cortical carcinoma, because androgen has to come, not only one line, it's both lines has of the adrenal needs to be working. Ovarian tumors, yes, they can present with androgen excess. Non-gonadal germ cell tumors, quite rare in the liver, lung, mediastinum, thalamus, hypothalamus and all. Exogenous sex steroids, mainly because of the misuse of the medications. So in the history we need to consider pregnancy history, is there any maternal virilization, family history of that's a CH to greater extent will be helpful. Birth weight and the gestational age at the birth, especially the small for gestational age babies do have some precocity, sometimes this can be mistaken for a virilization. Somatic development and a growth, age of adrenarche, thelarche and also menarche, and how they have progressed. Is it rapid progression or a slow progression? Because rapid progression does indicate a tumorous. Slow progression, probably we are ruling out tumor to a greater extent. That use of a drugs is a most important, including over-the-counter drugs. By examination, oxology is the most important when it comes to the height, weight, BMI, because patient is in the adolescent group. Blood pressure, especially when it comes to the 11 beta hydroxylase. Scoring is important when it comes to the FGS scoring. Look for the alopecia, especially androgenic alopecia, defeminizing things in the form of a breast atrophy in somebody established, fully gone through puberty, not in this child. Acne is also indicator, especially cystic acne. Clitoromegaly or ambiguity. Ambiguity tells the origin of the androgen excess is in utero. So if you see ambiguity, you are sure that the problem has started in utero. If there is no ambiguity, only clitoromegaly, the problem might have started in utero or even after delivery. Pubertal staging only for the clinical progression. The first set of a test when somebody comes with a hirsutism, acne or a virilization is, this is mainly based on the cost effective evaluation, but nowadays that cost effectiveness is not there. If I give a 5 tests to the patient will come with 69 tests, because he tells that for 2000 your 5 tests were there, for 3000 I have got 69 tests. So that is almost going nuts. This is just for a academic, I am telling a cost effective evaluation. Serum testosterone, if it is raised more than 2 to 3 times, ideally more than 3 times, suggest it's mainly ovarian, mainly. I am not telling absolute, mainly ovarian tumors. DHEAs, DHEA, androstenedione and a cortisol in the adrenal tumors, 17 OHP and a deoxycortisol in a CH. Most of the time we get a 17 OHP because it's commonly available and widely used. So if these things are done and you suggest there is abnormality, then we need to go for a next line of a test. So in the next line of a test, if your 17 OHP is inconclusive, so CH you are strongly suspecting, then we have to go a ACTH stimulated steroid panel. Nowadays it's available, I think we can get it done. And to differentiate the sources whether from the ovary or a adrenal, we do what is known as a 3 days or a 4 days of a dexamethasone suppression test. Basically we do a testosterone and a cortisol and give a 4 days 0.5 milligrams of dexamethasone 4 times daily for a 4 days. At the end of 4 days, that's a 5th day morning, again do a cortisol and a testosterone. If the source of the origin of testosterone is from the adrenal, both cortisol and the testosterone will be suppressed. If source is from the ovary, only cortisol gets suppressed, testosterone doesn't get suppressed. So that's how we differentiate whether it is from the ovary or from the adrenals. So FSH, LH and estradiol, they are low in pre-puberty and also in androgen excess. In 11.5 years, some pubertal thing has come. So FSH is low, LH is low, E2 is low. We know that androgen excess is coming. It is suppressing at the hypothalamo-pituitary level. If there is a high FSH and LH, we are dealing with gonad which is not functional. That is a gonadal dysgenesis. AMH is very important. If AMH is low, you know that you have got a karyotype X5, it deals with the testicular dysgenesis. If AMH is present, we know that there is some amount of a testicular tissue. So in a 46XX, if you find a high AMH, this also suggests ovotesticular DST. There is some amount of a testicular tissue which is residing in the gonads. Tumor markers are important when you are dealing with the suspected tumors like your alpha fetoprotein, beta HCG, even inhibin, CA125. We have to carry out based on what report we get. The common investigation what we carry out when they come with virilization is a ultrasound, which is cost effective, easily available, and most of the time it is a observer dependent. So nothing is coming out of a abdominal ultrasound. Sometimes you require a CT, which is again a cost effective compared to the next level of a investigation, which is MRI. So these are mainly when we are suspecting your ovarian or a adrenal tumors. If these things are inconclusive, your ultrasound, CT, MRI is not suggestive, then I think most of the time our surgeons, pediatric surgeons or our obstetrician, they go for a diagnostic laparoscopy and a biopsy from a suspected gonad. Otherwise, we need to do a catheter procedures. That's very limited to centers which have got a expertise in catheterizing the adrenal veins. So genetic test has to be carried out in a part of the workup. Nowadays it is slowly picking up. Earlier it was quite rare, now we are seeing commonly. Still the cost is on the higher side. If you work on the cost, probably one of the good things to do in the virilizing pubertal disorders, because many patients have got a genetic background for it. It also allows for a genetic counseling for a next child and also prognostication. A simple karyotype which we used to do earlier, even now has got a very good thing. You need to do a 30 cell thing, and if patient is affordable, something you get on the karyotyping, we can give a NGS. That's a whole exome or a genome sequencing approach can be done. This is a simple clinical evaluation what we can carry out. Girl comes with a virilization at the age of a puberty around 11 or 12 years. Medical history, physical examination and a bone age to carry out for a pubertal status, and also FGS scoring for the hirsutism, look for the virilization. Then carry out serum testosterone if it is more than 2 to 3 times suspect ovarian tumor, DHAS and a 17 OHP as a first line. Imaging especially for a pelvis and abdomen, for uterus and ovaries, and also adrenal glands. What is important? How it has progressed. If the progression is slow, then probably we are dealing with the CAH. That's the most common thing. 17 OHP needs to be asked. If there is a rapid progression and a telescoping of the event happens, probably we are dealing with a tumorous. It can be an ACC, that's adrenocortical tumor, or a gonadal tumor. So based on what next investigation we get, clinical profile, we can plan the second line of a investigation. At the end of the first line, when we get to know whether it's a CAH or a ACC, then we can show. Most common thing what we see in our practice is a CAH. That's why I am focusing on a CAH more. So if a karyotype is 46XX, patient 17 OHP is normal, do a ultrasound of the abdomen, Mullerian structures are seen, then it comes, probably we are dealing with the high with the Mullerian structures are there, a CAH or exposure to the exogenous androgens, and also sometimes androgen secreting tumors will be there. If Mullerian structures are absent, Mullerian subjects are absent, do a AMH levels. If AMH levels are on the higher side, probably we are dealing with the over-testicular DSDs. Very rarely it can be XX with the embedded Y line in the gonad that needs to be worked out. If 17 OHP is elevated, then probably we are dealing with the CAH. Various CAH can be differentiated with the presentation, minimal investigation, even a genetic tests. Most common CAH what we see in out of 190% of the cases is a 21 alpha hydroxylase thing, quite commonly seen, autosomal recessive, up to 1 in 15,000 live births. It has got two forms, classic form and a non-classic forms. Classic forms gets presented quite early in the life, that's why it picked up very fast, whereas non-classic form can present late, and these non-classic forms are the one which can present with some signs of a virilization or even excessive hirsutism and acne at the puberty. They can even present with the clitoromegaly. Yeah. So the problem is mainly in the conversion of 17 OHP to the 11-deoxycortisol. That's the reason everything gets shifted towards the androgen axis, and more androgen comes. Many a times 17 OHP what we get may not be in the diagnostic range, where most of the time it will be in the inconclusive or in between. That time probably we need to do a ACTH stimulated or even a actin prolongation stimulated 17 OHP. If it is more than 1000, probably we are dealing with it. If it comes less than 1000, unlikely with the CAH. 11 beta hydroxylase is the next common. Out of 100, probably 5 to 7% we see with 11 beta hydroxylase. Most important presentation, one of the clinical clues for 11 beta hydroxylase is a hypertension and a hypokalemia. Need not be there in all patients. If it is there, it helps for your diagnosis. And these females have a little higher degree of virilization compared to the 21 hydroxylase, because the crisis is rare in 11 beta hydroxylase. Diagnosis, routine 17 OHP is increased, suppressed PRA, hypokalemia will be present, and also if you are doing 7-deoxy levels, which is not commonly available earlier, now we can get it done, it will be more than 1800. The problem here is in the next step of the formation of cortisol, that is from 11-deoxy to the cortisol conversion is affected. That's why there is more of a deoxycortisol, the hypertension comes, hypokalemia comes, even the androgen excess comes. 3-beta HST is quite rare. Probably we have got a countable number of a patient in the past 20 years from our institute, and there is conversion from the delta 5 to delta 4, and here person presents with varying degrees of virilization because of the peripheral conversion of a DHEA to the active androgens. So we need to give a delta 5 17 hydroxyprognenolone. If it is above 100, it is diagnostic. Earlier we used to take even a ratio of a delta 5 to delta 4 for a diagnosis. 46XS aromatase deficiency most of the time gets picked up during newborn period, and by and large won't be a problem and quite rare, so we need not remember it in detail. P450 oxidoreductase deficiency, I think very common, we said nearly 1.5 decades back, but now we say it's quite rare. There is a maternal virilization. The virilization doesn't progress after a birth, so unlikely we suspect at the age of 11 years, but most of the time if there is a skeletal malformation, we can make a diagnosis of Antley-Brixner syndrome. That is quite catching. 46XY DST disorders, these are the one more next category of virilization at the puberty we should know. 46XY, born like a female looking genitalia, reared as a female. Around the age of a puberty, suddenly there is a virilization. A woman becomes a man, earlier voice to what we used to say, or even a penis at 12 syndrome. 5 alpha reductase is the one classical examination wherein born as a female, around puberty they present as a male. Next will be an 17 beta HSD3 deficiency, where the conversion of androgen into the testosterone is a defective, whereas in a DHD is a conversion to testosterone to DHD is a problem. And all things can be done by a stimulated measurement of androstenedione, testosterone and a DHDN. So most of this patient will have some amount of a reassignment to the from female to male in 50% of cases. In some conditions it doesn't happen because of the societal stigma. PAS is a varying degree of a defect. Based on the degree of a defect, they present with a virilization at puberty. So the treatment most of the time depends on the etiology, whether it's adrenal, ovarian, what we are looking at to, it's in CAH and all. Acquired causes, very easy, identify the drug. If you find any tumor, you can remove it, including adrenal or ovarian. Genetic causes, yes, we need to do a gonadectomy based on whatever investigation we get, and after 2 to 3 months of a treatment, we need to start them on the hormone replacement therapy. CAH, 46XX CAH, treatment is to rear as a female and treat with the steroids, whether it's hydrocortisone or a fludrocortisone. And 46XY DST, most of the time we need to decide based on the degree of a virilization. So back to our case, I think the first line investigation in our case showed elevated testosterone with a normal 17-hydroxyprogesterone and a DHAs. So suspecting the source of the testosterone is from the ovary, from the gonads, and the second line showed there is elevated LH and FSH. This suggests that the gonad is not functional or a dysgenic. AMH was low. Ultrasound revealed prepubertal status of the uterus and the gonads, no visible tumors on the ultrasound. Bone age was corresponding, even for a workup for a Cushing's, and the CAH was negative. ACTH stimulation, dexamethasone suppression relieved. There is no adrenal source, it's more of a ovarian source. And karyotyping showed 45 XO, like a Turner picture, but from where the testosterone coming, there has to be an Y line. So the Y line to identify, I think FISH was done, and FISH showed there was Y line in the gonadal tissue. And laparoscopy showed both right and left. Whenever you suspect an source of a androgen and a FISH showing a Y line, we need to take out both the gonads. Otherwise, it will transform to gonadoblastoma in the future. And histopathology confirmed the same. The right has a streak gonads with few granulosa cell, whereas left showed dysgenic testicular tissue, suggesting the source of a testosterone is from the left gonad. So patient became better after a surgery. After 2 to 3 months of a surgery, hormone replacement therapy was started. This is my last slide, only 1 minute I take. To conclude, virilization at puberty can be a manifestation of both genetic and acquired, more of a genetic, less of acquired. Rapidity in onset of a symptoms determines the etiology. Slow onset, probably we are dealing with the CAH and other causes. Rapid, probably with the gonadal or ovarian tumors. Genetic causes can be seen in both with 46XX and the XY DSDs. Most common, we should remember a CAH and 21-hydroxylase deficiency. Early diagnosis and a prompt treatment is the most important. Otherwise, sometimes many things are not reversible. If a voice change happens, the reversibility is very less. I think. Thank you for your patient hearing.
Thank you, sir, for that extremely difficult topic you took us through. If there are any questions, I think Shubhadeep has a question over there.
One question to you. The case you had shown, excellent case. I was just want to know what was the height of that patient, because usually in gonadal dysgenesis the height is taller, but in Turner the height is shorter. So what is in your
140 centimeters.
It does look so, okay. And one comment I had to mention that we have seen 2 patients with PCOS presenting at puberty with severe level of hyperandrogenemia, and they had few signs of virilization. So I think we can make that as a differential as well.
Yeah, yes, in fact, it's very important. I wanted to cover it. Request by my ex-stripper is not to speak on that. That's why I didn't speak on that.
Okay, thank you.
If there are no further questions, I'd request Vagish sir, thank you for the topic, and a big round of applause for Vagish Iyer sir.
Thank you.
Moving on to the next session on Practice Pearls, we have Dr. Shreya Sharma from Dehradun. who will be taking us through PCOS guidelines into clinical practice. Dr. Shreya. Can we have the CV slide of Dr. Shreya Sharma? Dr. Shreya Sharma is a consultant at Max Super Specialty Hospital, Dehradun. She is a DM endocrinology from AIMS Delhi, recipient of multiple awards. In fact, she was one of the participants at the TISA award that we were doing in Delhi last year, and she's here with PCOS. Dr. Shreya.
Good afternoon, everyone. And I'd like to thank the organizers of this conference for giving me the opportunity to be here and speak in front of you. And I'll be speaking on state of overall resistance to the glucose metabolic effects of insulin. Hence, PCOS is not just a problem of infertility and cosmetic annoyance, but is also a long-term health risk. And we do have a reproductive phenotype of PCOS, but insulin resistance lies at its core, and therefore the metabolic phenotype is very important. And hence, calling PCOS as metabolic reproductive syndrome would be far more appropriate. Because we are not just talking about oligoanovulation or hyperandrogenism or endometrial hyperplasia here. We are also talking about obesity, dyslipidemia, glucose intolerance, OSA, MAFLD, infertility, and depression and anxiety. And all of these factors add up to the increased cardiovascular risk. So the goals of treatment in a patient with PCOS would be the amelioration of hyperinsulinism, reduction of hyperandrogenism, endometrial protection, fertility, and cardiovascular risk reduction. And I'm going to be speaking about these two ladies who we have named Betty and Veronica. And I know the Betty that we see in Archie's comics is very thin and fit, but here I'm going to take this liberty. And so Betty is a 25-year-old female with a BMI of 32. She's an IT professional. She has had oligomenorrhea since menarche at 14 years and past history of occipital use on and off. She has somewhat increased facial hair and a family history of diabetes. Veronica, on the other hand, is 21 years old, BMI of 22. She's a sports teacher, oligomenorrhea for the last 5 years with increased facial and body hair and refractory acne and family history of diabetes. Let's look at the diagnostic criteria of PCOS. And among these three criteria that we know of, the Rotterdam criteria is the most widely accepted, which takes in at least 2 out of 3 criteria, that is chronic oligoanovulation, hyperandrogenism, and polycystic ovarian morphology into account. And we do have to exclude the secondary causes like thyroid dysfunction, hyperprolactinemia, NCCH, adrenal or ovarian tumors, Cushing's syndrome, and acromegaly before labeling anybody as PCOS. And we must know the definition of menstrual irregularity. We do not label the menstrual irregularity in the first year post-menarche, as this is part of the pivotal transition. Going from 1 to 3 years post-menarche, anything less than 21 or more than 45 days is irregular. More than 3 years post-menarche to perimenopause, less than 21 or more than 35 days or less than 8 cycles per year would be abnormal. More than 1 year post-menarche, anything more than 90 days for any one cycle again is abnormal. And also primary amenorrhea by age of 15 years or primary amenorrhea after 3 years of breast development is abnormal. And we also have to consider that ovulatory dysfunction can still occur with regular cycles. So we can consider documenting a mid-luteal serum progesterone for ovulation. Now looking at the PCOS phenotypes, these are A, B, C, D. So the phenotype A would be the classic PCOS, which would incorporate all of the 3 criteria. Phenotype B would fulfill the essential INS criteria, that is ovulatory dysfunction and hyperandrogenism. The phenotype C would be the ovulatory PCOS, where there's just hyperandrogenism and PCO morphology. And the phenotype D would be the non-hyperandrogenic PCOS. And it is known that phenotype A and B are more severe and have greater cardiometabolic risk. So going on to the evaluation and management of hyperandrogenism. Clinical hyperandrogenism is majorly evaluated through the assessment of hirsutism, which is excessive terminal hair in the androgen-dependent areas, thick, coarse, and it is generally pigmented. And we also have to take into account patient-important hirsutism, that is unwanted sexual hair growth of any degree that causes sufficient distress to seek additional treatment. And this is assessed by modified Ferriman-Galloway score, in which 9 androgen-sensitive zones are scored from 0 to 4, total score being 36, and score more than 8 would define hirsutism. But recent evidence suggests lower cutoffs and ethnic-specific cutoffs to define hirsutism. So there are certain fallacies of the MFG score, that is, there is ethnic variation. The patient-important areas may get missed out. It again misses important areas like sideburns. It is a very subjective assessment, and patient may often undergo cosmetic removal prior to the clinic visit. Again, acne that is persistent or late onset, inflammatory and unresponsive to topical therapy requires assessment. And androgenetic alopecia is rarely seen, where there's centrifugal expansion in the mid-scalp with preservation of the frontal hairline. But these two features are relatively weak predictors of biochemical hyperandrogenism when hirsutism is not present. So biochemically, in most adolescents, androgen levels will reach adult ranges at 12 to 15 years of age. If on hormonal contraception, we need to withdraw the drugs for at least 3 months before biochemical assessment. Direct immunoassays are highly inaccurate, so we need to have high quality assays like LCMS-MS for total testosterone, equilibrium dialysis for free testosterone, and the free androgen index can be calculated using the total testosterone and the SHBG levels. This has to be done during the day 2 to day 5 of the menstrual cycles, or at any time if suspected anovulatory cycles, but we don't have very clear cutoffs for these values. Total testosterone more than 55 nanograms per deciliter, free testosterone more than 9 picograms per ml, or free androgen index more than 4.5 is usually accepted, and there is no role of repeated androgen testing for monitoring. So going back to Betty and Veronica, the MFG score in Betty was 4, and in Veronica it was 9. And then a total testosterone was done, which was 58 nanograms per deciliter for Betty, and it was 71 nanograms per deciliter for Veronica. So both the levels were on the higher end. Looking at imaging, so imaging, that is ultrasound of the ovaries and uterus, is not required in those with irregular menstrual cycles and hyperandrogenism. The features that we must be seeing on the ultrasound are the follicle number per ovary, that has to be more than 20 in at least one ovary. Follicle number per section more than 10 in at least one ovary, or ovarian volume more than 10 for at least one ovary. The transvaginal approach is most accurate, but many times the transvaginal approach cannot be taken in the sexually inactive individuals, and it is not recommended in adolescents that we do imaging, at least up to 8 years post-menarche. So going back to the two ladies, now that we have a total testosterone and we've evaluated the MFG, a transabdominal ultrasound was done for Betty, and here there was improper visualization due to fat. And in Veronica, do you think that there is a need for imaging? We said we don't need imaging when we have hirsutism, which is clear-cut, and we have a total testosterone, which is elevated. We didn't need it, but for the sake of completion, it was done. And the ultrasound showed a ovarian volume of 16 cc bilaterally, PCO morphology. Now, talking about anti-Mullerian hormone, the anti-Mullerian hormone is increased in patients with PCOS. It correlates with the antral follicle count. Again, not required in patients who have clear-cut irregular menstrual cycles and hyperandrogenism. So either AMH or USG should be used for diagnosis, not both together, because then we tend to overdiagnose. Again, the cutoffs for AMH are not very clear. There's a lack of consensus on specific cutoffs for AMH and PCOS. The cutoffs which have been used in different studies and different institutes range from 3.2 to 7 nanograms per ml, and the levels are affected by age, BMI, and hormonal treatment as well. So here in Betty's case, we did do an AMH, and it was 8 nanograms per ml, which is elevated. So the diagnostic algorithm in a nutshell is, if we have irregular cycles and clinical hyperandrogenism, we just exclude other causes and we arrive at a diagnosis. We need not do further tests. If there is no clinical hyperandrogenism, we test for biochemical hyperandrogenism. If we achieve that, we have a diagnosis after excluding other causes. But if only one of the two is present, irregular cycles or hyperandrogenism, in adolescents, as we said, ultrasound or AMH is not indicated. You consider them at risk of PCOS and reassess later. And in adults, ultrasound for PCOM or AMH can be done and then exclude other causes. Going on to the management of hyperandrogenism, apart from lifestyle measures, it would be the local measures like depilation, epilation, and laser therapy, along with effloornithine cream. And for systemic measures, it would be OC pills and anti-androgens. So in terms of pharmacotherapy, the first line agent is combined OC pill for oligomenorrhea, hirsutism, or acne. And the estrogen and the progesterone component in the OC pill, they lead to FSH and LH suppression and decrease in ovarian steroidogenesis, along with increase in the SHBG and decrease in free androgen. But there is no specific recommended preparation or superiority of one OC pill over another, and a preference is advocated for lower dose preparations and those with fewer side effects in terms of thromboembolic risk majorly. And the progestin-only oral contraceptive may be considered for endometrial protection in patients who only need menstrual regularity, who do not need treatment for the hirsutism or hyperandrogenism. And talking about the anti-androgens, we will speak about spironolactone, finasteride, and flutamide. So spironolactone is the most commonly used androgen blocker for the treatment of hirsutism in a dose of 50 to 100 milligrams per day. 6 months of treatment reduces the MFG score by around 38%, but can lead to menstrual irregularity, postural hypertension, hyperkalemia, and can lead to undervirilization of the male fetus. So contraception is advocated. Flutamide is a potent androgen receptor blocker, but the side effect, it is hepatotoxic, so not recommended per se for hirsutism. Bicalutamide is a new player. It has a high affinity for androgen receptor, most potent non-steroidal anti-androgen with a long elimination half-life and 25 to 50 milligrams per day dose, but insufficient clinical data at this time to support its use in PCOS women. Finasteride inhibits phi-alpha reductase type 2 activity, inhibits T to DHT conversion. The dose being 2.5 to 5 milligrams per day. Again, liver toxicity limits its use and it's teratogenic. Dutasteride is a new player which will inhibit both the type 1 and type 2 enzymes. Again, not sufficient clinical data to support its use, so not very commonly used. Eflornithine is a cream which is topical preparation FDA approved for treatment of unwanted facial hair in women. Works well in combination with direct hair removal methods like laser. Irreversibly inhibits ornithine decarboxylase, which catalyzes the rate-limiting step for follicular polyamine synthesis. Noticeable results will still take 6 to 8 weeks, and once you discontinue the topical application, the hair may return to pre-treatment levels after 6 weeks. Combination therapy can be used in terms of OCP and metformin, considered for the management of metabolic features and most beneficial in the high metabolic risk groups. When we use OCP and anti-androgen, it would be for the treatment of hirsutism or hyperandrogenism after 6 months or more of OCP and cosmetic therapy have failed to improve symptoms, or where there is androgen-related alopecia. So laser and light therapies for hair reduction are advocated for reducing facial hirsutism, and greater number of laser treatment sessions may be required in PCOS than in idiopathic hirsutism. Addition of OC pills with or without anti-androgens to laser treatment gives greater hair reduction and maintenance, and this we do see in clinical practice. Monitoring of therapy is done by seeing the clinical signs of hyperandrogenism resolving. The effect on acne expected to be maximal in 1 to 2 months. On hair growth may not be evident for 6 months, and maximum effect requires 9 to 12 months, so we have to counsel our patients accordingly, otherwise they may get impatient. Trial of at least 6 months before making changes in dose, switching to a new medication or adding medication. Going on to insulin resistance, assessment is done by visual assessment of acanthosis nigricans and skin tags. The 75-gram OGTT is the most accurate test to assess the glycemic status in PCOS regardless of BMI. If an OGTT cannot be performed, fasting plasma glucose or glycated hemoglobin could be considered, but with lower efficacy. Insulin assays are of limited clinical relevance and are not recommended in routine care. This is something we really have to stop doing, probably we do see a lot of insulin assays being done, but they are really not very relevant. We do not have cutoffs. And assess for cardiovascular risk factors in terms of hypertension, dyslipidemia, MFLD, OSA at baseline, and follow-up. And as we said, regardless of BMI, do the OGTT. It's not dependent on the BMI. So in Betty and Veronica, we did the anthropometry, the waist circumference, OGTT, lipid profile, BP and LFT, and we asked for symptoms of OSA. And also we have to do a psychosexual assessment and management. It's very important in all PCOS women. So in terms of when we improve insulin sensitivity, we also not only improve the glucose tolerance, we also see a decrease in the circulating androgen levels and increase in the ovulation rates. So we target a modest loss of 5 to 10% of total body weight over 6 months. Advise sustainable healthy eating, low energy diets tailored to individual preferences and goals. 60 minutes of moderate to vigorous intensity physical activity per day, and advice for reduction of psychosocial stressors. And we also have to screen and manage the psychosocial issues that arise very often in PCOS women. That is the quality of life, anxiety and depression related to any hirsutism or acne they may be having, psychosexual function, body image disorder, eating disorders. And if we focus on the management of psychological issues, that can improve the adherence to PCOS management. In terms of insulin sensitizers, metformin is very commonly used. A bigonite, which is majorly used in overweight or obese adolescents with PCOS, primarily for the metabolic features, in 1 to 2 grams per day in 2 divided doses. Myoinositol is another vitamin B complex, which is a second messenger in insulin signaling pathway, dose being 2 to 4 grams per day. There is a potential for improvement of metabolic measures and menstrual irregularity, but limited clinical benefits in ovulation, hirsutism, or weight, and currently is considered experimental therapy. Again, pioglitazone has been used infrequently, but it is a good agent to ameliorate the insulin resistance and menstrual irregularity. There's no role majorly in the hyperandrogenism or weight management. In any adolescent, at least 12 years of age and adults, the FDA has approved GLP-1 analogs and lipase inhibitor orlistat for weight reduction in obese PCOS. It does help in management. And the barriers to this therapy are the cost of long-term therapy, concerns over safety, modest efficacy, and they also work only for as long as they are taken. Again, bariatric surgery can be advocated, and I think some speakers have spoken about this before, so I won't be going into this, but then amelioration of insulin resistance, hyperandrogenism, hypertension, menstrual irregularity, and ovulatory dysfunction are seen with bariatric surgery, and there's a rapid return of fertility after surgery, so need for contraception is to be explained prior to the surgery. So going to Betty and Veronica again, we see that Betty has a deranged OGTT, and she has high BP, high triglycerides and LDL, and also metabolism-associated fatty liver disease. On the other hand, Veronica has a normal OGTT and normal lipids and BP at this time. And we started lifestyle modifications, metformin, and we were considering GLP-1 RA for Betty. And in Veronica, lifestyle measures, OC pills and spironolactone were started for the hyperandrogenism and menstrual irregularity. And now talking about pregnancy with PCOS, it is the commonest cause for anovulatory infertility, confers high risk for higher gestational weight gain, miscarriage, gestational diabetes, hypertension, IUGR, preterm delivery, cesarean section, and ART failure. So we need to do periodic screening of BP, OGTT, and lifestyle interventions pre-conception. So now that if these two ladies were hypothetically planning conception, we need to stop GLP-1 RA in Betty. Definitely we cannot be giving it at this time. And the lifestyle modification, metformin and inositol can be continued. She did not have spontaneous conception in the first 12 months of trying for fertility. Veronica, again, the lifestyle modification continues. The OC pill and spironolactone was stopped. Preconceptional OGTT, BP and TSH were done in both the ladies, and no spontaneous conception again in 12 months in Veronica. So talking about metformin use in pregnancy, healthcare professionals should be aware that metformin in pregnant women with PCOS has not been shown to prevent gestational diabetes, late miscarriages, hypertension, preeclampsia or macrosomia, but it could be considered in some circumstances like risk of preterm birth to reduce preterm delivery and limit excess gestational weight gain in pregnant women with PCOS. But we do not know the consequences of metformin exposure on long-term offspring health. That's unclear, and we should be counseling the patients likewise. Now talking about ovulation induction in infertile PCOS women, what is the flow chart? So initially it is definitely lifestyle, and then the first line therapy being scheduled intercourse with letrozole or clomiphene citrate, letrozole being the first line therapy, and add-on can be metformin if there is insulin resistance or IGT, plus or minus inositol, and maximum of 6 cycles trial can be given. If not, then go to the second line therapy, that is ovarian drilling versus intrauterine insemination with gonadotropins, and this again maximum of 6 cycles, and if this does not work, then third line therapy would be IVF with a GnRH antagonist protocol. So in our cases, here we saw that GLP-1 RA had been stopped, but the metformin had been continued in Betty. We gave letrozole, there was no response after 6 cycles. And for Veronica, letrozole was also given for ovulation induction, but she conceived in 3 cycles. So going on from there, as Betty had failed with letrozole, gonadotropin therapy was tried, and she conceived after 2 cycles of IVF. Metformin was continued in her in the first trimester. And for Veronica, she was 3 months pregnant, and we were screening her for early GDM, because that is a high likelihood in patients with PCOS. So the take-home message would be diagnostic criteria of PCOS are ever evolving. Multiple phenotypes of PCOS are recognized, and they have to be managed differently, as we saw in the case of Betty and Veronica. And the lean PCOS phenotype has a high risk of underdiagnosis. Standardization of clinical markers of hyperandrogenism is still needed. USG criteria, we should remember, is for PCO morphology and not disease. So everybody having ultrasound showing PCO polycystic ovaries does not mean the patient has PCOS, which is what we really very commonly see the patient saying, I have PCOS. It's not the case. Insulin resistance should be diagnosed early and optimally treated. A diagnosis of PCOS could be considered as enduring or lifelong. Management options are based on the predominant complaints of the patients and long-term health risks. Early diagnosis provides us an opportunity to ensure lifestyle management, which is the cornerstone of management ultimately. Management of clinical features and comorbidities is vital to the health and self-esteem of PCOS patients. Thank you.
Thank you, Dr. Shreya. A big round of applause for Dr. Shreya Sharma for taking us through PCOS. I believe there must be questions regarding this extremely common and contentious topic. If there are any questions for Dr. Shreya. Yes.
Good afternoon, ma'am. Thank you for the wonderful lecture. I wanted to ask ma'am, like it is very common to see subclinical hypothyroidism in patients of PCOS. So what does the guidelines recommend? Do we need to treat that specifically in the patients with a higher BMI?
Thank you for the question, sir. Very relevant question actually, because subclinical hypothyroidism, many times what we see is, we do know that majority of patients with PCOS are obese. Although we do get lean PCOS very commonly, but majority are obese and they have metabolic dysregulation. So when there is obesity, there is thereby a mild elevation of TSH. So when there is a TSH due to the obesity per se, we do not treat that. So if it is just a mild elevation from, going up from 5 to 8 or so, we do not treat that. We can always wait and repeat it after 3 months or so. We can also get the TPO and TG antibodies done and look for a family history of goiter. If there is any concomitant feature which directs us towards treatment, we may take that direction. But majorly it's the obesity which leads to the TSH elevation and not vice versa. So there's no guideline saying such, but this is generally known, and ATA speaks about obesity leading to high TSH levels. So in PCOS it would be the same. But of course if it's a TSH above 10 in any general population guidelines also, we tend to, we went towards treatment. And of course we also look at the antibody levels and the family history and any presence of goiter. And if the patient is planning to conceive, for example, there it becomes a very different matter. There we have to keep the TSH below 3 or 4. So there we would definitely bend towards treatment, but that would be a specific indication. It would not be in all the patients of PCOS, definitely.
One other question, ma'am. Is there any role of metformin in lowering down the TSH levels in these patients?
Metformin could lead to, not really, sir, no direct correlation as such, but if it leads to weight loss, if an obese patient is there and they are going for weight loss and they're also using metformin, the TSH may come down on its own, but no direct correlation, I think, as far as I know.
Right. Thank you.
Thank you, Dr. Shreya, for that wonderful talk on PCOS. We'd like to close this session on practice pearls and quickly move on. A big round of applause for both our speakers. Moving on to the evidence-based management session, which are our pre-run sessions. Our first talk will be by Dr. Vanishri Ganakumar from Belgavi. Can we have Dr. Vanishri's CV? She'll be taking us through another difficult topic in endocrinology, thyroid eye disease. Dr. Vanishri presently is assistant professor at JNM College, Belgavi, and also has her institute DVDEC in Belgavi. She has her achievements in terms of presentations, endocrine hawk eye, and publications. She'll be taking us through thyroid eye disease. Dr. Vanishri.
Thank you so much, sir. A very good morning to everyone. Today we'll be talking about evidence-based management of thyroid eye disease. At the outset, I would like to thank Endocrine Society of Bengal to have me here. And this is one of the topics that is always a challenge in day-to-day clinical practice. And it's very fortunate for me to actually be given this topic, and we can go into the depths of this. So basically, thyroid eye disease is something that is quite under-recognized, and we don't really realize the burden that it carries in Graves' disease patients. So when put into numbers, it affects almost 40% of Graves' disease patients and is the most common extrathyroidal manifestation of Graves' disease. So around 90% of these are hyperthyroid, but then almost 10% of the patients might not be hyperthyroid. So 5% might be euthyroid and 5% might be hypothyroid. So basically, absence of hyperthyroidism does not exclude thyroid-associated orbitopathy. Majority of the cases, fortunately for us clinicians, are mild. However, 6% can be moderate to severe, and around 0.6% can be side-threatening. So before we go into the management per se, I would just like to revise how, what is the pathogenesis of thyroid-associated eye disease. So at the center of it all is the fibroblast that is present in the orbit. So these can be derived from the bone marrow, or these can be residential fibroblasts. So there is increased infiltration of inflammatory cells and as well as lymphocytes into the orbit in Graves' disease, and these result in expression of cytokines, which can result in the inflammatory pathology. Additionally, the fibroblast, which is the central cell in the pathogenesis, also expresses thyrotropin receptor, which is then triggered by the TSH stimulating immunoglobulins to result in downstream manifestations. It has also been seen that IGF-1 receptor also plays a central role in pathogenesis. So there is crosstalk between the two of them to result in further consequences. Now when the fibroblast is triggered, it results in differentiation of this into myofibroblasts or adipocytes. Additionally, it can also result in secretion of hyaluronate and other glycosaminoglycans and other inflammatory molecules and cytokines. So all of this eventually result in muscle edema and other inflammatory features. It can result in orbital fat expansion, eventually resulting in the cosmetic clinical consequences that we see, that is expansion of the orbital tissue, proptosis, and in rare cases, optic nerve compression, for which we should be wary of. Now, this is how usually the course of Graves' orbitopathy progresses. So initially, there is an active phase lasting for around 3 to 6 months, and then there is a plateau phase followed by a static phase for a total duration of around 12 to 18 months. Now, why is it important to understand this phases so that we can time the therapies appropriately? For example, if the patient is in the active phase of the disease, that is when the immunosuppressive therapies will act. So when we give immunosuppressives at this point, that results in decreased activity as well as decreased severity. So this is where we modify the course of the disease. However, if we time the immunosuppressive therapy, once the activity has waned off, there is no relevant clinical benefits. Now, when the activity has waned off, that is the timing where rehabilitative surgery comes into effect. Now, let us go into the topic per se, that is evidence-based approach to thyroid eye disease. Now, as clinicians, we must, our role is first of all in diagnosing Graves' disease accurately. It has to be differentiated from thyroiditis and other causes of hyperthyroidism. So in this case, measurement of serum TSH receptor antibodies definitely helps, especially in cases where there is no clear-cut diagnosis. Now, secondly, we must screen for Graves' orbitopathy in all patients with Graves' disease, for which we should use specific tools. We'll be discussing them subsequently. And we should ideally provide educational materials for all patients to alert them about the risk of Graves' orbitopathy. What I would like to highlight here is that while 40% of the patients do have concurrent thyrotoxicosis and orbitopathy, orbitopathy can precede as well as succeed the development of thyrotoxicosis, and hence the importance of frequent follow-up. Then we discuss about the management. Now, whenever a patient walks into the OPD, we have to screen for orbitopathy in all patients. So when we assess the eye, we are looking at 3 important things. So one is activity, severity, and the impact it is having on the quality of life. So when we talk about activity, we classify it into active disease and inactive disease. When we talk about severity, we classify into mild, moderate to severe, and sight-threatening disease. And when it comes to quality of life, we have several validated questionnaires. Now, activity and severity, it's quite confusing at the onset. So basically, activity denotes the presence of inflammation, and it is mediated by the cytokines. And hence, immunotherapy helps in targeting the activity. So this manifests usually as pain, redness, and edema. Now, what about severity? So severity is all the soft tissue changes that occur as a consequence of activity. So these result in functional and cosmetic defects due to changes in muscles, adipose tissue, and connective tissue, and other anatomical issues. So these usually result in proptosis, lid malposition, and exposure keratopathy. So again, it's important to differentiate this because the treatment is different. Now, let's see when a patient walks into the OPD, how do we assess activity? So for with this, we use an objective scale called as the CAS score, where there are 7 items. So there are 2 pain criteria, 2 swelling criteria, 2 redness, and then inflammation of caruncle or plica. So these are scored 0 or 1, and a score of 3 or more than 3 is suggestive of activity. And on follow-up, we measure 3 additional criteria, that is proptosis, ocular excursion, and visual acuity. So I'll just be showing some clinical photographs. So here we see conjunctival and eyelid erythema. So conjunctival erythema should be the first thing to be seen because any eye manipulation can result in some redness of the eye. So these should be graded according to the severity of the conjunctival erythema. So here we see the erythema of the tarsal plate and preseptal erythema as well. So each of these will score 1 each. The other thing we see is eyelid swelling and chemosis. So eyelid swelling can affect both the upper eyelid and the lower eyelid. So it can present as sharp borders like in this photograph, or it can be like a rounded border in severe cases. And chemosis is conjunctival swelling, which should again be graded as 0 or 1. Now the other seventh criteria is the inflammation of the plica or the caruncle. So any redness of these is denoted as 1. So out of the 7 criteria, 3 or more than 3 is considered as active disease. Now the other aspect of the disease is the severity. That is, how much is it actually affecting the patient. So in this case, we classify it into sight threatening, moderate to severe, and mild. So let's discuss what is sight threatening. So any patient with dysthymorrhapia. So if any of these features are present, then it comes under moderate to severe orbitopathy. And if none of these are present, if the thresholds are not exceeding these cutoffs, then we classify it as mild Graves orbitopathy. So let's see this patient. She was a known case of 50-year-old female, Graves disease, on antithyroid medications, euthyroid currently. She had features of some eye symptoms and was on long 2 mm, which is definitely more than the upper limit, 3 mm more than the upper limit. Then lid retraction was more than 2 mm and moderate soft tissue involvement. So it comes under moderate to severe severity score. So this is active Graves orbitopathy, and severity is moderate to severe. So this is where we'll make treatment decisions based on these 2 parameters. The third parameter that needs to be seen is how much is it actually affecting the patient. So objectively, there might not be many signs and symptoms, but if the patient is bothered by it, then there is a lower threshold for treatment. So which patient should we be alert for in our OPD for development of thyroid eye disease? Any male patient with advancing age, any history of smoking or tobacco intake, patients with unstable thyroid function, fluctuating TFTs, elevated TRAB antibody titers, known diabetic patients, history of radioactive iodine use, progressive symptoms and signs, and history of orbital ache and diplopia. So all of these patients should alert us to the presence or worsening of thyroid eye disease. Now let's say we have a patient of Graves disease with mild thyroid eye disease, and we are planning for radioactive iodine. How do we go about? Radioactive iodine is a well-known risk factor for developing thyroid eye disease. So in that case, some patients require glucocorticoid prophylaxis. So we consider GC prophylaxis in patients at high risk, that is smokers, severe or unstable hyperthyroidism, and high TRAB antibody titers. And how do we do it? We give steroids at the dose of 0.3 to 0.5 mg per kg, and then we taper and withdraw it after 3 months. We can even use lower doses in patients at low risk. What is important here is any hypothyroidism should be avoided at all costs, as even hypothyroidism has been known to exaggerate the orbital manifestations. Now, what about orbital imaging? Do we do a CT or MRI in all? Basically, it's not mandatory. It's a clinical diagnosis primarily. But however, in any case where there is diagnostic confusion, we can go ahead with it. For example, if the patient is euthyroid, or if the patient has asymmetric disease, or any alert red flag features like ptosis, atypical strabismus, severe pain, or if the patient has sight-threatening GO, or we are planning for orbital or strabismus surgery. So this is how it usually looks on MRI. So the typical pattern of enlargement is muscle belly enlargement with sparing of the tendons. So this is called as tendon sparing, or the Coca-Cola bottle sign, and it most commonly affects the inferior rectus, medial rectus, and the superior recti. And we also can calculate something called as a Barrett's index on the coronal sections. So this gives us an index of the muscle thickening. Now, any patient with a dysthyroid optic neuropathy due to swelling of the muscles at the orbital apex, corneal breakdown, or globe subluxation should receive immediate ophthalmology referral. We should engage our ophthalmology colleagues as early as possible in these cases, and in other cases also they might require an ophthal opinion. Now coming to the management per se, there are certain indices we use to determine how effective is the management. So we use the improvement in CAS, the improvement in eye motility, soft tissue changes, lid aperture, and exophthalmos as the indices of changes. Now, in all measures, in all patients, these are the blanket measures that have to be advised in all the patients. Smoking is one of the major reasons for exacerbation as well as worse outcomes. So smoking cessation has to be re-emphasized. We have to treat thyroid dysfunction. Both hyper and hypothyroidism are detrimental for orbitopathy. Any dry eyes and corneal exposure, we can use CMC or hyaluronate artificial tears. Eyelid taping can be done for lag of thalamus. Head and elevation can be tried for edema, and photophobia, we can use dark glasses, etc. Now, if left untreated, there is 10 to 59% chances of spontaneous disease inactivation in these patients. But we do want to intervene with the activity because, like we saw in the Rundle's curve, if we use immunomodulators at this point, we can decrease the severity and the subsequent consequences. Now, let's say we have classified a patient as mild Graves' orbitopathy. In that case, we will employ all the measures that we just discussed, and there is role of selenium supplementation for 6 months in these patients. Now, selenium has antioxidant and immunomodulatory effects on orbital inflammation, and in one particular trial, 100 microgram of selenium selenite twice daily was compared to placebo, and it was associated with improvement in activity, quality of life, as well as slowed progression. So this can be more effective in selenium deficient areas, but we have to weigh it against the possible risks of prostate and rare side effects of prostate and squamous cell cancers and type 2 diabetes that have been reported rarely. Now, coming to immunomodulatory therapy, we have seen that it's a hyperinflammatory milieu in the orbit. So multiple cells can be targeted in order to arrest this inflammation. For example, we can use glucocorticoids to act at multiple levels of the inflammatory cycle. We can use IL-6 inhibitors like tocilizumab. We can use B-cell depleters like rituximab. We can use IGF-1 receptor monoclonal antibody teprotumab, etc. So among all these agents, the ones which have shown some evidence are glucocorticoids, mycophenolate mofetil, rituximab, teprotumab, tocilizumab, and radiotherapy. So more often than not, we end up using glucocorticoids, which are the first line established line of management for Graves' orbitopathy. How do they fare when it comes to management? So efficacy wise, it has been seen that IV glucocorticoids are better than oral glucocorticoids. Almost 60 to 80% efficacy for IV and around 50% efficacy for oral. When it comes to eye motility, there is marginal benefit, and when it comes to proptosis and diplopia, there is negligible benefit. So the major things that parameters that glucocorticoids improve are the activity. However, it has to be weighed against the adverse effects, that is hyperglycemia, accelerated hypertension, Cushing's, increased IOP, and psychiatric manifestations. And it has been seen that at a cumulative dose of more than 8 grams, there is severe hepatotoxicity and liver failure can occur. The other agent that has been proposed for first line management is mycophenolate, but it has shown inconsistent results. When it comes to efficacy, CAS has improved versus IV glucocorticoids, and in fact, a combination of MMF plus IV glucocorticoids has fared better than IV alone in post hoc analysis of a RCT. According to the guidelines, the first line agent is still IV steroids. So before we give IV steroids, we have to do certain workup. We have to do a complete hemogram, see the WBC count, LFT, viral markers, and ECG and echo. And any recent viral hepatitis, hepatic dysfunction, cardiovascular morbidity, and psychiatric disorders are contraindications for using pulse steroids. Now, diabetes and BP should be well controlled. Now, how do we give steroids? We give it as weekly cycles. So we have 500 mg of methylprednisolone per week for 6 weeks, with or without in combination with mycophenolate mofetil. And then if response is there, then we decrease the dose to 250 mg per week for 6 more weeks. So usually we determine the response after 6 weeks of therapy. And then if no response is there, then we go on to second line treatment. Now, in certain selected patients who have more severe manifestations, we can use higher doses like 750 mg per week initially for 6 weeks, and then followed by 500 mg per week for 6 more weeks. So this is usually the standard protocol that we follow at the outset of the disease. Now, let's go back to our case. So, this patient, as we saw, had moderate to severe disease with active disease. So, she received 12 doses of IV methylprednisolone. So, her CAS activity came down to 1. Her visual acuity improved. Her proptosis improved. The ocular excursion also improved. So, basically, there was improvement in the composite index after receiving the 12 doses of IV methylprednisolone. Now, the other exciting molecule that has come up in this area is teprotumumab, which is the IGF-1 receptor monoclonal antibody. As we saw in the pathogenesis, IGF-1 receptor actually plays one of the central roles in the pathogenesis of Graves' orbitopathy. So it is usually given as IV in 8 doses, and these are spaced 3 weeks apart. So initial is 10 mg per kg followed by 7 subsequent doses of 20 mg per kg. So it has been seen that around 70% have improvement in CAS. But what is more exciting is the effect on proptosis. So proptosis is one of the important, most concerning things for a patient. So we saw that steroids were not very encouraging when it comes to proptosis, but teprotumumab actually resulted in a mean proptosis reduction of 2.5 to 3 mm, and more than 2 mm reduction was seen in 80% and more than 4 mm reduction in 40%. And additionally, it also had encouraging results on diplopia. So this is where the new agent offers a step above the previously established agents. However, it does have some safety concerns. Hyperglycemia is seen in around 10% of the patients, and some other side effects include muscle cramps, alopecia, hearing impairment in around 10% of the patients, etc. So these need to be weighed against the possible benefits. So these are the photographs that are put out by the investigating group. So these are, this is at the baseline before receiving the teprotumumab, and after receiving teprotumumab, we can see that the activity has reduced and the proptosis also has significantly reduced, and this is also reflected in the MRI of the patient. So this is how it is being pushed forward currently as a novel agent for management of thyroid eye disease. So as second line treatments, if the patient has not responded to the initial steroid therapy, then we can go for second dose of steroid cycle. We can give prednisolone with steroid sparing agents like cyclosporin or azathioprine. We can give teprotumumab, rituximab and tocilizumab. So rituximab basically helps in shorter duration of patients' disease. Tocilizumab for improved proptosis, and orbital therapy is more useful in patients with progressive diplopia. So statins also have been seen to have beneficial effect in hypercholesterolemic patients. So basically we have to personalize the management of the Graves' orbitopathy. When we need disease inactivation, glucocorticoids are the way to go. When proptosis and eye diplopia are the major problems, then teprotumumab probably is better. And when there is failure of these, then we can go for rituximab and tocilizumab. Site-threatening orbitopathy, again steroids are the major drugs to be used, and here we use it as 0.5 to 1 gram repeated on 3 consecutive days or alternate days. One important thing is here we assess the response 1 week after therapy. We should not wait beyond 1 week, and if there is no response, we go ahead with surgery. So surgeries usually are orbital decompression for increased dysthyroid optic neuropathy and other lid procedures. So to summarize, Graves' orbitopathy or thyroid-associated eye disease has a substantial burden affecting nearly 40% of the patients, and our job as clinicians is to recognize this early, and we have to do a threefold assessment: assess the activity, in which case we give immunomodulators; assess the severity, they might need surgical procedures for these, and also the impact on the quality of life. And these patients will require appropriate endocrinology and ophthalmology referral in a timely manner. And the medical therapy has now progressed beyond glucocorticoids. We can personalize it more to address the concerns that are plaguing the patient more specifically. Thank you all for patient listening. Any queries are welcome, and we can discuss this later as well.
Thank you, Dr. Vanishri. I think Ravida has a question.
So, madam, thank you for your nice deliberation. Do you use mycophenolate with steroid? Are you doing any study or like those things?
Sir, we have used it in a couple of patients. There is no formal study that I am doing right now. But then it has been used as a combination therapy with IV steroids, and it has actually resulted in better visual outcomes when it comes to activity.
What about azathioprine as a steroid sparing agent?
Sir, it has been used mostly as second line therapy, not as primary therapy. Primary is usually IV glucocorticoids. Only when there is lack of response, then we can transition to oral plus azathioprine or oral plus cyclosporin. But now we have actually got better agents. We have rituximab and tocilizumab and other agents available. So.
And burnt out disease with severe proptosis, what do you do? Radiation or like those things? What is the current guidelines?
Sir, if we have to wait for the activity to come down, so if it is burnt out in that case, surgery is the way to go. Most of the time, we have to take ophthalmology. An experienced orbital surgeon is very important. Orbital surgeon is important, and radiotherapy can be done. It is more effective in patients with restricted mobility. So when
active disease also.
Yes, both of them, sir.
Thank you.
Thank you.
I think that should be the last question because we are running late.
My question, two questions. Burnt out disease without any major disability. Is there any chance of recurrence of the disease subsequently, especially with smoking, number one? And number two, is TSH receptor antibody comes down to normal level after disease has got burnt out, and it is a prognostic marker for the disease.
Yes, sir. So for the first question, usually it is a monophasic kind of disease. So once the activity is burnt out, it is less likely to recur again. But if if it is completely burnt out, then it usually does not recur. So, but then around 15 to 30% can have recurrence later on based on the TRAB titer. So TRAB is the major driver for this pathogenesis.
Especially with the smoking.
Yes.
They start smoking.
Yes.
And second one, TSH receptor antibody.
Yes, sir, that has a direct correlation with the pathogenesis. So, TRAB antibody titers more than 5 to 10 times, more than 5 to 10 actually is associated with an elevated risk, and we usually monitor TRAB to decide whether to stop antithyroid medication or not in patients of Graves' disease.
Thank you, Dr. Vanishri, for that elaborate discussion on thyroid eye diseases. A big round of applause.
Thank you.
We move on to the second session on our evidence-based management section, and I'd request on stage Dr. Umesh Garg from Agra, a very beloved senior and another social media butterfly from the endocrine community. Dr. Umesh Garg will take us through a very contentious issue in endocrinology, whether to treat subclinical hypothyroidism and how, when, not, etc. Dr. Umesh is currently consultant and head of the department at Pushpanjali Hospital, Agra. A number of publications and book chapters. Dr. Umesh, over to you. Thank you.
Thank you, Pankaj. So, from the rheotic, we will go what is evidence-based and what are the probable evidences. So this is the outline, just a basic introduction, what subclinical hypothyroidism and its natural course, what is the effect of subclinical hypothyroidism, what is the impact of levothyroxine treatment in subclinical hypothyroidism, what are the evidences, what are the confusions, and what are the guidelines. Thereafter, summary and take-home message. Just subclinical hypothyroidism. First thing is confusion. It is not subclinical, it is actually a biochemical diagnosis. It is defined as TSH concentration more than upper limit normal with normal free T4. Some also include total T4, but it is the primarily. It may or may not have a symptom. So there is nothing like subclinical. That's why it is considered as a misnomer. There are multiple terms which has been used in the literature: mild thyroid failure, early thyroid failure, compensated hypothyroidism, preclinical hypothyroidism, decreased thyroid reserve. Various studies has used various with different perspective. Incidence, depending upon population and all these, 3% to 15%. It is much higher in older age group, females, in the area where iodine status is suboptimal. Regarding incidence, in post-perimenopausal women, it is around 10%, and it rises up to 20% when age is more than 75%. Whenever we are going to make a diagnosis of subclinical hypothyroidism, it need to be reconfirmed, because we see in the natural course, it need to be reconfirmed within 2 to 3 months before we put a label of subclinical hypothyroidism. In the past, most of the studies has shown that up to 75% of cases are having TSH less than 10. Probably it has figured newer studies less than 90, almost 90% have a TSH less than 10. So if we see this categorically graph, it has 3 implications. Everybody know this is a HPT axis set point. Everybody has there is a log linear relation. So whenever there is a mild perturbation in free T4, TSH rises above the normal. However, there are few people for the same log linear relation who might have for the same TSH elevation. You can see on the left side, there will be decrease in free T4. Even between them, the most important is we should understand that the free T4 range is for any individual is far narrower than the population range. That is the catch. And everybody knows there is a log linear relation. But older people, females, and those who have a TPO antibody positive has a more stronger log linear relation than those without. So in the past, there is a stratification of subclinical hypothyroidism. It does have its impact when we are dealing with the patient. There are 2 schemas, mild, moderate, severe, upper limit normal to 6, 6 to 10, and more than 10 is severe. Many people believe, why to mild and moderate? Mild and severe. Grade 1, upper limit normal to 10, more than 10, grade 2. This is important because most of the evidence which are actually seen for effect as well as treatment is with the only grade 2 or severe. While others, it's a contentious and we have to be adjustable or personalized for those cases. So what are the causes? We have to look where it is truly a subclinical hypothyroidism, means where there is a derangement with the thyroid failure. Most common causes, Hashimoto disease. Second most common now is radioactive iodine ablation in the Western countries, or maybe a surgical thyroid lobectomy. There may be thyroid-containing drugs, radiotherapy, lithium carbonate, tyrosine kinase inhibitor, immune checkpoint inhibitor, interferon alpha, and there is inadequate thyroid treatment that can present biochemically as a subclinical with intrinsic thyroid failure. But there are 2 different classes. One is transient. One should always recognize that there is a transient rise. That's why we need to reconfirm the biochemical diagnosis of subclinical hypothyroidism before embarking upon. Recovery from NTI, from thyroiditis, there is a slight rise in winter time, and whenever you are withdrawing, you have somebody has given the levothyroxine and you thyroid you withdraw, there is a slight. There is another TSH rise without any thyroid failure, which is not transient. Drugs, physiological in old age, SA interference, rheumatoid arthritis, heterophile antibodies, macro-TSH, obesity, adrenal insufficiency, TSH resistance, CSHoma, they can present with TSH elevation, but they don't have a thyroid failure. So what is the natural course? We need to understand why we need to treat it. There is a progression of subclinical hypothyroidism to overt hypothyroidism, ranges from 2% to 6% per year, depending upon multiple features, which are TSH, TPO antibody, gender, thyroid reserve or free T4 level. For example, in WICAM follow-up studies, almost TPO positive have a double the rate of overt conversion to overt, that is 4.3% in compared to 2.6. If we see what is the most important factor which denote or increase the risk to conversion of overt hypothyroidism is, it is the TSH. So in same study, when TSH was more than 10 to 15, has a 10 times more risk of conversion to overt hypothyroidism in comparison to grade 1. So it is the most important. What are the composite? If we see various features, whether is there any Cox relationship? When TSH is less than 7, almost half normalized to euthyroid biochemically in 2 years, but if TSH is more than 10, only 7% normalized to euthyroid level. If we go to 5 year, the TSH less than 10 whole group, 60%, but those who are having severe hypothyroidism grade 2, almost 40% develop overt hypothyroidism over next 32 months, while if it is even severe, 15 to 20, the risk of converting to overt hypothyroidism is almost 85 to 86%. So there was a study from Hubler which has looked on 3 aspects: TPO level, positivity, negativity, what is TSH level, and thyroid reserve. They checked the thyroid reserve by means of oral TRH stimulation test when they used 40 milligram of oral TRH after overnight and rechecked total T3 at baseline and 3 hours. So the normal response is increment more than 0.5 nanomole per liter. They have found that it is the TSH which is the most important. If we see when TSH is more than 12, even in the TPO negative with normal thyroid reserve, the odd ratio Cox proportional hazard ratio was 10.3 times. While everything in higher side, that is only 15 times. So all other factors increases risk by 1.5 times when we look that TSH is higher side. So what are the effects of subclinical hypothyroidism? We will look. Mostly the treatment which is recommended is based on cardiovascular. Unfortunately, those symptoms are either non-specific, mild. As we already discussed, it might or might not have a symptoms. So subclinical hypothyroidism does have a rarely symptoms except in the severe grade or grade 2. Most important is cardiovascular abnormality, which has been discussed. There has been mechanism, direct as well as indirect. Indirect, we do have an inflammation, lipid parameters, vascular diastolic dysfunction. Recently, in cardiomyocytes, we have seen existence of TSH receptor, which TSH bind and downregulate the sarcoplasmic reticulum calcium ATPase and inhibit protein kinase and phospholamban signaling pathway. So that's why it causes diastolic dysfunction as well as systolic. In various studies, subclinical hypothyroidism is also associated with carotid media intima thickness. However, there are few studies which has put some controversies, particularly a thyroid studies collaboration with more than 50,000. There was no association with these cases. But if we sub-analyze this, whenever there is a severe or grade 2 subclinical hypothyroidism, there was even with the thyroid study collaboration, there was an increased risk of all cardiovascular risk. Yes, for grade moderate, where 7 to 10, there was only increased risk of fatal stroke even with the thyroid. There is some ongoing conflicting evidence for dementia. They are not consistent. MASLD not consistent. In female, this is not my topic, but it has been proved that it is associated with female infertility, abortion, gestational hypertension, as well as preeclampsia. So what is the levothyroxine treatment, evidence, confusion, and guidelines? That is the main point. The fundamental question is, whenever a patient of subclinical hypothyroidism is present, whether some patient require treatment or all patients require treatment. And what are the consideration points we need to think before planning for treatment, and how to follow, which patient requires just follow-up, and what are the evidence and guidelines. If we see in clinical, subclinical hypothyroidism, there is no large control, randomized control. There are only observational and epidemiological cohort studies. Till date, the largest trial was TRUST trial, which was performed only on 737, which was not powered enough to comment upon cardiovascular risk. That's why the goal was shifted to quality of life and the symptoms. There are observational studies, particularly from the UK, which has shown that the levothyroxine treatment is associated with reduction. few opposition points. There are latest two RCTs. One is Trust and second is Institute of Evidence-Based Medicine. They doesn't show the benefit from levothyroxine treatment, but that is not the whole story. Why? Because whenever we are seeing Trust, we analyze the Trust trial, patients are more than 65, mean TSH was 6.8, and the reduction of TSH with levothyroxine was only 2. So what you are going to expect when most of the symptoms and disorder with seen more than 7 or 10? That's why it is not applicable in most of the population. Similarly, for Institute of Evidence of Medicine was not applicable. If we remove the Trust trial and meta-analysis of most RCT has been shown to be associated with reduction in the carotid intima media thickness and lipid profile. So this is the gist of subclinical hypothyroidism, what are the clinical outcomes and what are the results. Treatment has been associated with benefits strong and stronger, particularly when more than 10 with the cardiovascular symptoms and disorders as well as the symptoms. While for others, there is symptom is weak, evidence is weak, particularly when TSH is grade 1 subclinical hypothyroidism, that is less than 10. There is some evidence for CSD, CHF also when TSH is more than 10. So what are the factors we need to consider for treatment as well as observation? Mild TSH, anti-TPO antibody negative, TSH less than 7, non-pregnant age out, no heart disease, lipid profile normal, or elderly doesn't require any treatment. But there are consideration factors which require treatment. If there is a goiter, history of radioactive iodine ablation, lobectomy, hemithyroidectomy, TPO positive, TSH 7 to 10, 10 to more than 10, everybody knows that has to be treated, metabolic syndrome, MASLD, age you can consider. So what are the guidelines? ATA says more than 10, treat. Less than 10, don't treat, but consider to treat if there are compelling indications. ETA has come with the age cutoff. 70, more than 10, less than 70, treat, otherwise don't treat. The most recent guidelines were Korean Thyroid Association, which were published last year. This has to be with the evidence that if TSH is more than 10 and is less than 70, treat, else not to treat. But one point has to be noticed that in Korean guidelines, their upper limit of normal, which they have derived for their population, upper limit of TSH is 6.8. So we need to population-specific TSH. So pregnancy in the ATA just has a change its cutoff for TSH, pregnancy-specific. But we have to understand two words, treat and consider. Those who are having TSH more than 10, treat. If TSH less than 10 but upper limit normal or TPO positive, treat. Remaining is consider. However, the latest ACOG guidelines, which were published 3 years later than the ATA, they only consider treatment when FT4 is low. Means that is clinically as well as classically clinical hypothyroidism, overt hypothyroidism, not the subclinical. ACOG does not endorse treatment. So what we can understand? We have to treat the patient, not the number. We have to treat what is clinically significant subclinical hypothyroidism. This is my chart which I adapted from NEJM, published by Robin Peters in 2017. If TSH, we need to first reconfirm. TSH more than 10, age less than 17, green light, treat. Rest, if more than 10 but age more than 70, yellow, wait and watch, or you can consider treatment. Most of time it is not required, but you can consider for trial of 3 to 6 months if symptoms are present or there is an anti-TPO antibody present or on follow-up TSH is rising. On the TSH less than 10, usually no treatment recommended, but you can consider a trial for 3 to 6 months. That is trial, and it has to be re-examined on follow-up. That If there are symptoms resolved within 3 to 6 months, you can continue, otherwise there is no need. Similarly, for 7 to 10, you can consider trial for symptoms or MASLD, cardiac risk factor or TPO antibody. What should be the dose? If we go by the books and the ATA guideline, they say in adult less than 65, go with the full dose, 1.6 microgram per kg. But there is a footnote on one study, even in the ATA guideline, that has used levothyroxine based upon TSH level less than 825 microgram, 8 to 1250, and more than 1275, which has least adjustment requirement. While others, even Williams says 1.6 microgram per kg. But most of the independent authors, even in the NEJM guidelines, practice guidelines by BMJ, by Beckinger, they recommend 50 to 75 microgram depending upon weight based. Whenever we are treating subclinical, in the clinical overt hypothyroidism, you need to follow up at 3 months. In subclinical, TSH should be repeated 6 to 8 weeks, and even 6 to 8 weeks after each modification. Why early follow-up is needed? Because in UK survey, even with the levothyroxine treatment of subclinical hypothyroidism, almost 10% does have a TSH more than 10 after being treated. There is another facet, over-aggressive. 6% goes to suppressed TSH less than 0.1. So we have to balance our approach. So my summary and home take-home message, subclinical hypothyroidism is biochemical diagnosis. It is not a subclinical or a clinical diagnosis. It's a misnomer. It need to be reconfirmed. If TSH is less than 15, you can repeat at 2 to 3 months. If TSH is more than 15, in subclinical, repeat within 2 weeks. Depending upon symptoms, comorbid conditions, TPO antibody, age, compromised thyroid tissue mass, goiter, TSH trajectory, these points has to be considered whenever you are treating TSH less than 10. For more than 10, less than 70 age, treat. Follow-up is need to be done at 3 to 6 months. This is summary based upon if TSH more than 10, treat. For normal to 10, you have to consider in young based upon TPO antibody and comorbid. For 65, rarely required individualized treatment. What are the individualization and factors? Symptoms, TPO antibody, thyrotropin level, pregnancy plan, MASLD. What are the future directions? Unfortunately, as I said and mentioned in Werner and Ingvar, there is no large RCT. Largest was trust trial with 737, 349 in 1 hour. We need a large scale RCT, particularly which have enough power for CVD and metabolic endpoint. In Graves' disease, we do have a score, great score, which predict treatment, response, and future risk. But we don't have a composite score. Hubler was one which was published in 2002. That is the multiple prognostic risk factor for risk of overt. So we need a composite score. So whom are going to have a overt or other complication where treatment will be beneficial? Just like Korean guidelines, we need a population-specific TSH guidance. Today is a World Gratitude Day, so I pay my gratitude to my teachers, Dr. S.K. Mathur, Dr. Balram Sharma sir, and my colleagues from Team Endo Brigade. And this on Day of Gratitude, I am standing with solidarity with justice, and I take a bow to all of you for their, and with salute for your support in this fight. Thank you.
On that honorable note, I thank Dr. Garg sir for that excellent lecture. The session is now open for questions, if any. Do we have any questions from the audience? So, sir, if I may, just one question. Does an increasing anti-TPO titer, if we monitor it, does it have any role? That's an important message for our physician friends. And thank you, sir. And another question, in older patients above the 70 years of age in whom you are thinking about starting on
levothyroxine in a case of subclinical hypothyroidism,
would you
monitor regular cardiac
and maybe bone monitoring regarding those parameters are usually affected? Thank you, sir.
Yeah. One small query.
If PSH becomes 7 to 10, how frequent and how long to follow up if persistently between 7?
As I said, initial follow-up should be at 2 to 3 months to reconfirm. If it has come to normal, follow up at 1 year. If it is increases to more than 10, treat. If it is in the range of 7 to 10, repeat at 3 to 6 months.
Okay. Yes, Dr. Umesh, one small question. Dyslipidemia, no? This dyslipidemia debate was there.
Yeah, dyslipidemia, whenever we are looking at the effect of thyroid treatment on CVD outcome, yes, it reduces and it has a strong evidence for correlation to, I have one slide which total cholesterol, LDL, but there is no strong correlation with HDL, one. Second, though we have a direct evidence that it reduces a lipid profile, but whether it contributes to reduction in CVD, there is no hard evidence till date.
I think that addresses all the burning questions of the audience. Thank you, Dr. Garg, sir, for that excellent lecture. We are now dispersing for lunch. It is being served on the ground floor, and we come back at 2 o'clock for the next session on difficult diabetes. Thank you, everyone.
Yes.
Good afternoon, everyone, and welcome back to this immediate post-lunch session of the annual conference of the Endocrine Society of Bengal, Crescendo 2024, at this magnificent venue, Dhanodhan Auditorium, nestled in Kolkata. Taking a break from endocrinology, core endocrinology, we move into diabetes
and some really difficult and ignored aspects of diabetes and its complication managements. The first session in this category will be the GI motility disorders in diabetes, very neglected. And for this, we have none other than Dr. Sunil Kota from Barhampur neighborhood, Odisha, who will take us through GI motility disorders in diabetes. Dr. Kota is consultant endocrinologist at Southern Barhampur, Odisha, has all these credentials to his credit, and he will take us through GI motility disorders. Dr. Kota.
Hello. Yes. Thank you so much, Dr. Pankaj, for those kind words. Very good afternoon, everyone. Thanks to ESB for inviting me over here and asking me to talk about this gastrointestinal motility disorders in diabetes. And if you look at the statistics, if you speak about non-specific discomfort, it would be found in around 70% of people. And if you speak about
specific gastrointestinal symptoms, it would be found in around 25% of people. It is generally pan-enteric, but the most common segment that is involved is esophagus, which is found in around 60% of the cases. So with this brief preamble, I am going to take you through the presentation proper through these points mentioned in the slide. First of all, briefly about the physiology and the epidemiology. So the gastric emptying is a mechanical process of transit of digested food from the stomach to the intestine, and it involves a number of neurohumoral factors. There is this fundus which acts as a reservoir and relaxes to accommodate food, and it acts as a pressure pump as well. The body antrum, which mixes food content with 3 peristaltic waves per minute, and then there is this pylorus, which filters digested food particles of 1 to 2 millimeter of size, and it has 2 phases. First of all, digestive, and second one is the interdigestive phase, where the peristaltic waves push the food further below. And there are a number of factors which stimulate gastric motility, like the ghrelin and the mutilin, and there are a number of ones which also oppose this motility, which are cholecystokinin, GLP-1, amylin, peptide YY, and leptin. And the gut motor function is controlled neurally. There is parasympathetic sympathetic control through the vagus nerve. The afferents arise from the enteric nervous system. Through nucleus tractus solitarius, they move on to dorsal motor nucleus, from which the efferents are laid onto the myonteric plexus. Then there is sympathetic nervous system acts through the celiac ganglion, and there is also myonteric plexus, which are involved in 3 basic processes. First of all, the propulsion, emptying, and the retropulsion. And the predominant cell which is important in normal gastric motility is the interstitial cells of Kajal, which act as a pacemaker for gastrointestinal motility, and they are found in different layers of gastrointestinal tract. They can be submucosal, smooth muscle, deep muscular plexus, myonteric, and intramuscular, and they have been involved in the pathogenesis of gastroparesis. If you talk about the prevalence data, way back we have data to suggest that the cumulative incidence after 10 years of diagnosis is around 5.2% in type 1 diabetes and 1% only in type 2 diabetes. But looking at the sheer number of type 2 diabetes patients that we come across, the numbers would definitely be very high in our clinical practice. And with the advent of usage of these oral drugs like the GLP-1 receptor analogs, yes, the gastroparesis has shot up. This is a recent one in 2023, which talks about the prevalence of 37.8 women in 1 lakh persons versus 9.6 in men. And even if there is no gastroparesis, it is stated that the gastric emptying is lower in women than men. And talking about the pathophysiology and the risk factors, the gastroparesis, the predominant one, which is defined as the delayed gastric emptying in the absence of mechanical obstruction. And there are a number of factors which promote its development. First of all, the hyperglycemia causes acute changes in the gastric motility. It is stated if the blood sugar is increased by 2 folds or reduced by half, it will give rise to reduced or increased gastric emptying. And the altered gastric motility does contribute to poor proglycemic control, giving rise to a vicious cycle between them. It is stated that the hyperglycemia is associated with pyloric contraction,
impaired antral relaxation, giving rise to delayed gastric emptying. On top of that, if you have vagal dysfunction, which impairs the gastric accommodation and motility, it is stated that there is a state of pyloric relaxation and impaired antral contractility, giving rise to dyssynchrony between the pylorus and the antrum. And there is also this loss of expression of neural nitric oxide synthesis in the matrix plexus. So we have excitatory neurons which secrete acetylcholine and substance P, and we also have inhibitory neurons in the matrix plexus which secretes the vasoactive intestinal polypeptide, ATP, and the nitric oxide. So imbalance can also give rise to this dyssynchrony. And the Kajal cells, which are predominantly responsible for slow peristaltic waves, responsible for this gastric emptying, they are also facing some sort of abnormality due to the oxidative stress and chronic inflammation. Slide looks very busy, but then I'm going to highlight few of the points attributed to its pathophysiology. There is reduced insulin and IGF-1 signaling, giving rise to loss of smooth muscles in the neurons. There is diabetic microvascular disease, giving rise to ischemia, hypoxia, and oxidative stress. Apart from that, there is mitochondrial dysfunction, AGE formation, endothelial dysfunction, autoimmunity, and microbial dysbiosis. All of these give rise to formation of peroxynitrite production. Apart from that, the intestinal epithelial cells have a loss of function kind of changes, wherein there is defective glucose transport and there is defective fluid transport, giving rise to blood glucose changes and also fluid loss. Apart from that, there is stated that the type 2 macrophages, which are protective for the neurons and the smooth muscles, are also lost in here. And the risk factors which are associated with GI dysmotility are older age, longer duration of diabetes, female gender, obesity, higher HbA1c level, coexistent peripheral neuropathy, autonomic neuropathy, low socioeconomic status, presence of microvascular complications, associated depression, and we need to remember the medications which are being used. Metformin, acarbose, incretin-based therapy, and also the orlistat, which is not very uncommon to be used. And if you look at the clinical features, you have this manifestations depending on the segment of the gastrointestinal tract involved. Either it can be esophagus, the stomach, or the intestine. I will be briefly telling you about the involvement of these different organs, giving rise to different kinds of symptoms. Esophagus, it is the highest affected, the prevalence of esophageal dysmotility is highest to the tune of 63% cases, and acute hyperglycemia can give rise to the esophageal sphincter dysfunction and giving rise to height and dysphagia. The predominant symptoms are gastroesophageal reflux and dysphagia, and there can be reflux disorders which are more prevalent, which are mostly asymptomatic but can sometimes present with heartburn, regurgitation, or cough. Sometimes there is odynophagia as well, where there is a painful swelling process due to co-associated candidiasis, and it is more common in women, whites, smokers, obese people, and those having peripheral or autonomic neuropathy. Stomach, approximately 40% of patients with type 1 diabetes and 10 to 20% patients with type 2 diabetes will go on to have gastroparesis, and the most common symptom in around 40 to 50% people would be nausea and vomiting, typically seen 30 to 60 minutes after food intake, but then it can also happen 6 to 8 hours after food.
Symptoms like postprandial fullness, early satiety, bloating, upper abdominal pain, and distension. In 50% of the cases, these are chronic and lingering ones, but in 10% of cases, these can be cyclically occurring. And there is one interesting finding where it is said that the idiopathic gastroparesis people would go on to have more of abdominal pain, whereas the diabetic gastroparesis people would be having more of vomiting and early satiety. And there is this gradation as well. The grade 1 is where the person can be managed with control reduction of body weight, and the nutrition can be managed with simple diet. Grade 2, where the patient would be having symptoms which can be managed with a combination of antiemetics and prokinetics, and the nutrition can be managed with bit of modification of diet. Grade 3 is the severe variety where they do not respond to medications. They are refractory varieties requiring some sort of interventions, or the surgical procedures requiring frequent medical admissions or frequent outpatient visits, and they are dependent on enteral or parenteral nutrition. And the complications can be manifold: esophagitis, the malurivetia, the malnutrition, volume depletion, electrolyte disturbances, bezo formation, and there can be also hyperglycemic emergencies. Intestine, it can be associated with constipation, diarrhea, pain and blotting. Constipation is more common in 25% of cases vis-a-vis diarrhea, which is only present in 5% of cases. It is painless, chronic and watery. And it is seen that patients having diarrhea more frequently would be taking metformin, and patients having constipation would most probably be having some sort of subtle renal dysfunction or coexistent hypothyroidism. Then the two most distinctive findings are nocturnal diarrhea and fecal incontinence, which is very disabling, and it is found in around 7 to 15% of people. And sometimes the slow intestinal transit, which may predispose to SIBO, the small intestinal bacterial overgrowth, giving rise to production of hydrogen and methane, and which can also give rise to diarrhea and foul-smelling flatus as well. Large intestine, it can be associated with constipation because of the impaired gastrocolic reflex and delayed colonic transit. There can be ischemic colitis, there can be obstipation, and not very common finding, that is megasigmoid, which is a state of colonic dilatation and is associated with acute intestinal pseudo-obstruction. Now coming to the diagnostic aspect, so the algorithm is very clear. First of all, you have to, based on the symptomatology that the patient is presenting with, you have to pinpoint which particular organ is predominantly affected. Yes, we understand that the symptoms are non-specific, but there are pointers to suggest which organs are affected, and there are a number of evaluation scales proposed by a number of societies. First one is the PAGI-SIMS index, which is to assess the upper gastrointestinal symptoms, the GCSI, which is specific for gastroparesis symptoms, the GSRS, which is to evaluate the broader gastrointestinal symptoms. So the slide again looks busy. There are a number of questions to the tune of 20 questions in total, having scores between 1 to 5, and if you sum them all up, if it is 1 to 11, it is mild degree, moderate degrees 12 to 22, and severe degrees that of 23 to 33 points. Similarly, this looks a bit more easier, but the PAGI-SIM is the one which is most studied across. This is the gastroparesis cardinal symptom index, depending on, based on the severity of 3 different symptoms. There are a number of other scoring systems like PARC-SIM and PARC quality of life. There is this ANMS, the American Neurogastroenterology and Motility Society, GCSI-DD, which is to assess the response of gastroparesis to treatment. It also has been created and validated. And once you have seen for the symptoms and for the severity, you have to go for the subsequent steps of investigation, preferably again depending on the which organ or which segment of the gastrointestinal tract is involved. First of all, the esophagus, there is endoscopy to evaluate the mucosal complications and candidiasis. To look at the esophageal motility disorders, we have conventional and high resolution manometry. There is this pH monitoring through the wireless pH capsule to evaluate the gastroesophageal reflux, and there are timed barium in esophagogram as well. Scintigraphy for the gastric emptying, it is the gold standard. It uses radiological procedure, and the values are, you have to look at the 2-hour retention. If it is more than 60%, it is 100% sensitive and 20% specific. And the 4-hour retention, if it is more than 10%, it is 100% sensitive and 70% specific. To enhance the specificity, you can add this test, that is the hydrogen breath test, which is done for 4 hours, 6 to 8 hours after the intake of the food. You have to take the sample once in every 30 to 45 minutes, and it has a sensitivity of 89% and specificity of 80%, which is more than that of the scintigraphy. We have a number of others like wireless motility capsule, EGG, electrogastrogram. Yes, they also have been doing it, which shows there is increased frequency of antral dysrhythmia. There are a number of intestinal diagnostic tests as well, the jejunal aspiration, the anorectal manometry, the transit studies, and the rectal barostat. So just to complete the list. And GI function testing is generally not recommended, only done in very specific situations if the investigations are non-contributory or the treatment that you are giving is not giving adequate relief to the patient. And apart from that, we have to rule out a number of other things which can also be associated with motility disorders like the autoimmunity markers, complete blood count, complete metabolic panel, rheumatoid factor, ESR, thyroid levels, urine analysis, abdominal imaging, and a number of other tests as well. So to talk about management, again, the ANMS says, first of all, you need to pinpoint the symptom which is mostly damaging to the patient or is disturbing to the patient, and you have to find the cause by ruling out other coexisting morbidities, and a multidisciplinary approach, obviously gastro, endo, nutrition and others would be important, and we need to give relief from the symptoms, and also glycemic control is very essential in these patients. It becomes tricky thanks to a number of factors which comes along with it. Nutritionally, these are very, very important points. The number of points I would be mentioning is huge, but yes, it is very important to communicate to the patient. Eat smaller and more frequent meals. Eat slowly. Avoid the supine position for at least the first hour after a meal. Sleep with the head elevated 6 to 8 inches from the bed to minimize reflux. Lose weight and avoid tight cloths. Avoid meals in the later parts of the day. Avoid fats and fibers. And avoid chewing gums that increase the air swallowing. Avoid caffeine, alcohol, tobacco, and stress. And there are some foods which are associated with reduction of lower esophageal sphincter pressure, like peppermint, chocolate, fat, and caffeine. They all have to be avoided. Glycemic control, yes. A subset study of the DCCT and EDIC tells us that there is a weak correlation between the HbA1c and gastric emptying. But then there are some studies to suggest that the gastric retention at 4 hours is significantly higher if the HbA1c is high. So definitely the control is very important. There is a study called Glumit DG, which looks at insulin infusion pump and its impact on assessment of the gastric emptying studies, and it shows wonderful results because oral drug absorption would be erratic, the pharmacokinetics would go haywire, and there are a number of drugs which does impair the motility as well. So insulin therapy, for basal therapy it is absolutely good, but for bolus again it becomes a bit tricky. Double bolus using the insulin infusion pump would be definitely important, and we need to avoid the medications that delay the gastric emptying. And a number of other factors like hypothyroidism, helminthiasis, and other organic causes which can give rise to gastric motility disorders have to be taken care of. To talk about treatment, we have the antiemetics, predominantly the ondansetron or the diaminohydrinate, and preferably a combination of antiemetic and a prokinetic drug would be useful. The D2 receptor antagonist, metoclopramide and domperidone, and metoclopramide is approved for up to 3 months. And there is motilin receptor agonist, erythromycin and azithromycin, 5-HT4 receptor agonist, prucalopride, and also the lubiprostone, which is a chloride channel activator. These are the drugs which are currently available. And these are the drugs which are in the pipeline: the D2, D3 antagonist, TAC numbered molecule 906, metopimazine, deuterated domperidone, and there are motilin receptor agonist camcinal, 5-HT4 receptor agonist valucetra, ghrelin receptor agonist relamorelin. A number of molecules are there in the picture. Then there is this interventional kind of thing where the endoscopically we have to inject the botulinum toxin into the pylorus, which can inhibit the neuromuscular transmission in pylorus. It improves gastric emptying, but the symptom alleviation is not that much. To take care of that, we have this gastric electrical stimulation, which is known as the GES. So either it is done alone or along with the pyloric surgery, which can be pyloromyotomy or a pyloroplasty, which would be giving us better results. The GES has 2 components. One of them is gastric pacing, which improves the gastric emptying, and also there is neurostimulation, which controls the nausea and vomiting. And in refractory cases, we have a number of other procedures like gastrostomy, gastrectomy, and when I was talking to one of my gastro friend, he said the G-POEM along, that is the per oral endoscopic myotomy with pyloromyotomy, is one such procedure which is done not so uncommonly. In the future directions, you can actually imagine the usage of stem cell therapy to regenerate the damaged neurons and the interstitial cells of Cajal. There can be targeted drug delivery to improve efficacy and reduce side effects. Of course, gene therapy is one such to complete the list. And chronic diarrhea is important. We need to take care of the hydration. We need to identify and avoid the trigger foods. Pharmacological therapy, there is usage of clonidine, the octreotide. We have diphenoxylate, loperamide. Antibiotics obviously would also be handy. And management of constipation, dietary fiber has to be increased. Hydration has to be increased. But then if you look at the RCTs, they are equivocal in talking about their beneficial impact as far as constipation is concerned. Laxatives, the bulk forming laxatives are the most important ones. Of course, you can actually go for osmotic or stimulant kinds of laxative if the bulk forming laxative is not giving you adequate result. So to summarize, yes, we have a number of etiologies, the fluctuation in blood sugar giving rise to gastric dysmotility giving rise to fluctuating blood sugar. So this is a vicious cycle. Vagal innervation, vagal dysfunction, you have loss of excitotoxic and inhibitory fiber control. There are a number of factors, especially the longer duration of diabetes, older age, female gender, and number of coexisting microvascular complications, some drugs which have to be taken care of. We need to identify the symptoms, and proper diagnostic workup is essential based on pinpointing the symptom which is the most disturbing one. Nutritional modification is very important. Exercise, unfortunately, has not been associated with improvement in as far as gastric motility parameters are concerned. Glycemic control is crucial, followed by symptom management, and drugs, a combination of antiemetic, prokinetic, and interventions. We have talked about a few: the botulinum toxin, the gastric electrical spacing, pyloromyotomy. These are some of the strategies that we look forward to. Thank you all for the patient listening in Jai Jagannath.
Thank you, Dr. Kota. I think there is a question over there.
Yes, sir. It's not audible.
You're not audible, I think. Try speaking again, sir. Try speaking into the mic. Yes.
Often we get patients who complain that after each meal, they run to the toilet. After each meal. Now, there I found that romesetron works very well. So, how long can we use it?
Duration, actually, as far as the articles that I have gone through, I have not found any particular duration of treatment. They have not even advised maximum cap for such duration as long as the symptom is bothersome. Yes, definitely. But then on top of the medication, it is also advised to specifically counsel about the particular nutritional aspect, which particular food is giving them more of trouble. So proper nutritional counseling along with continuation of medication as long as the symptoms are there.
Sir, diarrhea in diabetics, which medicine, which antibiotic we prescribe?
So preferably nowadays I think rifaximin is the one which is predominantly being prescribed. Any other experience from the seniors that would be really helpful for me as well?
In such case, prebiotic, probiotic?
Yeah, yes, prebiotic, probiotic is definitely essential, but when we talk about the antibiotics, rifaximin is one such which we look forward to, but then anything else that is being used, sir, maybe?
I believe in that case, Dr. Kota, the choice of antibiotics may not be important because most of these are not infective in nature.
Yes.
And as you said, rifaximin, which will maybe clear some local bacteria, along with an anti-motility agent sometimes is required because these diarrheas are very, very fulminant at times and do not respond to any antibiotics or even rifaximin.
Just to add, I mean, regarding the treatment for gastroparesis, it is said that if you have a size of the food particles less than 2 millimeters, they can exit the stomach. So the larger ones are the ones which are having all these problems. So one of the ways to reduce this problem is eat small, finer ones, food particles, that will exit the stomach. That's one thing which has been actually found. And regarding insulin usage, you spoke on insulin infusions or the pumps. Hardly we get 4 or 5 patients I have who are using pumps. So what they say is if you are using the human insulins, regular ones, you take it with the food. Normally we say wait for half an hour. So you take it with the food. Suppose you want to give an analog insulin, after the patient has completed the eating, then you give the analog insulin. See, we can't just eat only carbohydrate food. We tend to eat even fatty meals also. So in such circumstances, you would split the dose into 2, give a small dose of regular insulin, give a small dose of the analog insulin. One will work for the fatty meal and another one will work for the carbs. So you can do this is another way of dealing with this condition.
Oh, thank you, sir.
How long can you use rifaximin?
We generally use it for, then again, if you talk about guidelines, I'm not very sure about the answer. We generally use it for 5 to 10 days.
See, as it is already stated that predominantly we don't end up finding an infective cause. So to take care of the bacterial overgrowth or whatever it is, the rifaximin or short course would be helpful. But then again, sticking to other kinds of diarrheal or antidiarrheal therapy, that would be really useful.
Whether it's rifaximin or any other, those are for short durations of treatment, 2 days, 3 days, 5 or 7 days.
Lifestyle measures will help in the long term, and none of these drugs can be taken for a lifetime.
Yes, that's true.
Thank you, Dr. Kota, for that wonderful talk on GI motility disorders and diabetes. A big round of applause, and we move on to our second talk in the difficult section in diabetes. To deal with this, we have Dr. Saurabha Bhatt from Mangalore, and she'll be taking us through male factor infertility in diabetes. Dr. Saurabha Bhatt is Associate Professor, Department of Endocrinology at Yenepoya Medical College, Bangalore. She has a number of publications, a fitness enthusiast, and Yuva Ratna Award recently by the Endocrine Society of India. Dr. Saurabha.
Yeah, thank you for that kind introduction. So I'm very happy to be invited to Kolkata. This is where I did my DM from, that is IPGMR Kolkata. So I'm very happy and I'm grateful to the organizing team for inviting me to be a part of this Crescendo conference. So let us start. I'll be briefly talking about the male factor infertility in diabetes. Male infertility is a very, very vast topic, so covering it in detail will not be possible. A brief outline of why it may happen in diabetes. Like if a person with diabetes has infertility, so what are the things which may be the possible causes in such a patient? So what is the infertility seen in India? Infertility is defined as the inability of a couple to conceive even after 1 year of unprotected frequent sexual intercourse. There is something called barrenness amid plenty. That is, the countries, actually paradoxically, the countries which are the most populous countries, including India, are supposed to have the highest rate of infertility. So this is called barrenness among plenty. Overall, the prevalence of primary infertility in India is variable amongst the various studies that have been done, between 3.9% and 16.8%. And it was supposed to be increasing, steadily it increased from 13% to 16% in the 2000s. And primary infertility has actually reduced, but secondary infertility, the prevalence has gone up actually as per the recent data that is available from 2015-16, that is from the National Family Health Survey statistics. So what is male factor infertility? Males with sperm parameters below the WHO normal values is considered to have male infertility. So males are solely responsible for infertility in 20% of cases. We all know that when a couple comes with infertility, a part of it is exclusively due to the female, but when it's solely male in 20%, male factor contributes to another 30% to 40%, and in overall 50% of the cases, the male factor infertility plays a role. So this is what the WHO normal values look like. So I've just put the comparison between the 2010 and the latest, that is 2021, the parameters. Semen volume 1.4 ml, total sperm number, that is 39 million per ejaculate, total motility 42%, progressive motility 30%, non-progressive motility of 1%, vitality 54%, and normal forms, that is normal morphology 4%. So only a slight change in certain parameters are there. So in male infertility in diabetes can have a number of mechanisms, a number of causes. Sometimes multiple causes may be at play. So right from the hypothalamic pituitary gonadal axis, there can be defects. The testicular function and spermatogenesis may be affected. The sperm quality and function may be affected. The accessory genital organs may be affected in diabetes, and it can be also complicated with erectile dysfunction and ejaculatory dysfunction. So when we look at male infertility, we can roughly classify it as pre-testicular causes, testicular causes, and post-testicular causes. So this is an arbitrarily classification for evaluation which makes it easier, but there may be overlap and multiple factors. So in diabetes, it is inflammatory condition. There is overall inflammation in the body. So this inflammation is supposed to reduce the GnRH secretion, and it reduces LH, FSH secretion, and in turn testosterone and also spermatogenesis is affected. Similarly, the leptin and the insulin resistance, hyperinsulinemia that is there, is supposed to affect the GnRH secretion and reduce the FSH, LH secretion, and in turn cause infertility. At the testicular level, there may be impairment of spermatogenesis, that is reduced sperm count has been found due to diabetes exclusively. Altered steroidogenesis and sperm motility may be affected. There may be effect on the ingredients of the seminal plasma. DNA of the sperm, that integrity may be impaired, and there is what is known as epigenetic dysregulation, that is the methylation, the DNA methylation may be affected during spermatogenesis in these patients. The cellular and molecular changes that occur in diabetes include oxidative stress due to reactive oxidant species production from hyperglycemia and mitochondrial damage due to oxidative stress. The changes in the mitochondrial epigenetic transcriptome has been found to occur, and disruption of the endoplasmic reticulum protein folding and ER stress, that is endoplasmic reticulum stress. These are subtle mechanisms. So in type 2 diabetes, predominantly the oxidative stress and sperm DNA fragmentation has been found, and in type 1 diabetes, the mitochondrial damages were found to be predominant. So testicular dysfunction has been found in certain studies. There was a positive correlation of the metabolic factors, that is FBS, HbA1c, the insulin resistance parameters, waist circumference, BMI. So they had a positive correlation with leptin, HSCRP levels, and semen parameters as well. So in this figure, we can see that the hyperglycemia causes dysfunction of the sperm motility, that is asthenospermia is there. Also, it causes oxidative damage to the sperm itself, and also increases what is known as testicular autophagy. So overall, it causes at multiple levels testicular dysfunction. Also, testicular size has been found to be slightly reduced. What about the glucose metabolism in the sperm? So these are all the GLUT transporters which have been found in the sperm. That is right from GLUT1, we can see all the up to GLUT8, all the glucose transporters, GLUT9, from GLUT1 to GLUT9. So sperm depends on glucose for fuel to maintain basic cellular activity, motility, and fertilization. So in diabetes, there is GLUT overconsumption, and the expression of these GLUT transporters reduces, and there is impairment of sperm glucose metabolism resulting in low fertility. At the post-testicular level, erectile dysfunction is very common. This is, I think, everybody's experience. When we ask the patient, some amount of erectile dysfunction is found on history. The prevalence may be up to 3.5 times higher in patients with diabetes compared to the normal population. And albuminuria has been found to be an independent risk factor for erectile dysfunction in patients with diabetic nephropathy. Coexisting obesity, hypertension, and dyslipidemia increase the risk of erectile dysfunction. And complications of diabetes, that is cardiovascular disease, increases the risk. In fact, they say if there is erectile dysfunction, there is increased risk of cardiovascular mortality or events in these patients. Nephropathy, neuropathy, these may contribute. Comorbidities, that is hypogonadism, metabolic syndrome, depression, they may also play a role in erectile dysfunction. So what is the mechanism? One is the autonomic neuropathy. So there are damaged NANC fibers, noradrenergic, norcholinergic fibers. Endothelial dysfunction is seen in diabetes. So there is decreased nitric oxide synthase activity in the endothelial cells, and this causes the decreased inhibition of calcium release and reduced penile tumescence. Increased reactive oxygen species can be found, and impairment of the bioactivity of nitric oxide. All these factors contribute to the erectile dysfunction seen in diabetes. Ejaculatory dysfunction has also been found. That is, premature ejaculation is supposed to be very common. That is, the reported prevalence may be as high as 95%, but the true prevalence is not known. Erectile dysfunction may be contributing to ejaculatory dysfunction. The longer duration of diabetes may increase the risk. Poor glycemic control, increased hypoglycemia, glycemic variability, cardiovascular disease, chronic prostatitis, depression, anxiety and other psychological factors, and FSH-LH abnormalities may contribute to ejaculatory dysfunction and premature ejaculation. There is also a component of retrograde ejaculation in diabetes. So autonomic dysfunction leads to, in diabetes, the autonomic dysfunction leads to low pressure closure of the bladder neck during ejaculation. So there is partial or complete propulsion of the ejaculate into the bladder. Unlike premature ejaculation, where psychological factors, many other factors may play a role, for retrograde ejaculation, it's almost always organic, and the prevalence varies between 6 to 34%. Genitourinary infections in diabetes are also contributory many times to infertility. So spermatic cord, there can be abscess, funiculitis, calcification of the vas deferens. In the epididymis and testis, there may be epididymo-orchitis, emphysematous epididymo-orchitis, xanthogranulomatous orchitis, and epididymitis, and gangrene are common. In the penis, gangrene and balanitis is known. Scrotum, there can be abscess and intertrigo. So diabetes predisposes to infection of the genitourinary tract, and this may predispose the patient to infertility. So there is also a component of what is known as transgenerational epigenetic inheritance. So we all know that epigenetics means without involvement of changes in the DNA sequence per se. So diabetes affects epigenetic modifications in spermatogenesis. Methylation has been found to be abnormal in germ cells of offsprings of mothers with GDM and fathers with prediabetes. So the child may have problems. So this is transgenerational infertility, which needs further research. So at the epigenetic level. So exercise, actually we know that in diabetics, lifestyle modification is very important. So most of them and a lot of them are sedentary. So in the treatment aspect, exercise is found to improve the intratesticular spermatogenesis and semen quality, and increase testicular antioxidant defense, improves apoptosis, reduces pro-inflammatory cytokine levels, and enhances steroid producing process. So the combined aerobic and resistance training is recommended. So this is the treatment aspect, how it modifies infertility in a diabetic. So all of us mostly recommend exercise in patients. So it has a positive effect. What about insulin in the management? It has again a positive effect on the testosterone, the LH, FSH, and restores LH pulse frequency. There is regeneration to some extent of the spermatogenic tubules and testis, improvement in the autophagy disorder that is seen, that I mentioned previously, in the epididymis tissue, reduces interstitial hyperplasia and inflammation. It has a beneficial effect on copulatory behavior, ejaculatory and erectile dysfunction. So it has a positive impact. What about metformin that is commonly used in diabetes? It increases serum and testicular testosterone levels, increases Leydig cell count, improves sperm parameters, reduce sperm nuclear DNA fragmentation, and preconception paternal metformin treatment is associated with major birth defects. This is from one particular data only. This needs further study. This is from one particular article that I have found. Sulfonylureas and meglitinides. So it has a controversial effect at the sperm and testicular level and may cause reduction in sperm count, motility and viability, and increase in shape abnormalities and increased risk of ED. Again, these are small studies which have to be further validated to be translated and to make a generalization, but this is found in literature. In pioglitazone, it has antioxidant and anti-inflammatory roles. It might mediate improvements in male reproductive function. What about GLP-1 receptor analogs? There is limited data. Liraglutide is reported to interrupt sperm production to a certain extent, and they have potentially beneficial effect on the hypothalamic pituitary gonadal axis, and long-term use of dulaglutide was associated with the reduced incidence of moderate or severe ED. So they have variable effects on the different parameters. SGLT2 inhibitors, we all know, increases risk of urogenital infections and has been found to elevate spermatogenesis, elevate the impaired spermatogenesis, and improve sperm quality and ameliorate apoptosis and the overall oxidative stress in testicular tissue in animal models. And it has a potential benefit, that is reduces glucotoxicity and inflammation. This is true with most of the treatments that are available. In DPP-4 inhibitors, there is limited data. Sitagliptin showed a progressive decline in semen volume, sperm concentration and motility, and to lower testosterone. But again, all this needs further studies, but this is found to a certain extent in the literature. So these are only certain factors, but we know a lot of diabetics are hypertensive. Antihypertensive can cause worsen erectile dysfunction. So these are only some things. It's a very vast topic that I've mentioned. So how do we evaluate? First of all, we all know in infertility, evaluation is never complete unless both the partners are evaluated thoroughly. Because both may have contributory roles in up to 20 to 30% cases, and multiple factors of male infertility may be possible. So just because we find one particular cause, we must not stop there. Like we saw, infertility may be due to defects in varying levels, and a thorough history, drug history, duration of diabetes, the glycemic control, everything is important. Physical examination, the general examination, as well as local examination to rule out other local factors like a varicocele, for example, is very important. Semen analysis is the main stay of evaluation. It is the most important. So after minimum of 3 days of abstinence, 2 samples, 1 week apart at least, but optimally 1 month apart, should be analyzed. And we look at the WHO, at least 2 samples are required, and from a good lab, look at the WHO parameters, and hormone evaluation are necessary, that is the FSH, LH, total testosterone, bare minimum. And the treatment is of course individualistic, and we have to address the various factors. Due to limitation of time, I will not be able to cover that part in detail, but I have just given an overview because it is so wide. So right from each cause, we may have to evaluate at each level because multiple factors may be at play. So in individualistic, it must be the treatment addressing all the factors that are involved. So I'll summarize my the whatever I have mentioned. So diabetes as an endocrine disorder, it reduces testosterone, decrease FSH, LH, sperm motility, abnormal sperm morphology, and decrease sperm viability. As a increased oxidative stress and reactive oxygen species, it can affect the seminiferous tubules, and the oxidative stress may also cause DNA fragmentation, and neuropathy may have a role. in causing erectile dysfunction as well as ejaculatory dysfunction. Glucose lowering drugs have variable effects. Overall, by increasing the glycemic control, improving glycemic control, it may have a positive effect, but further study is required because some have found to have negative effects. So all these factors and one or many of them may have a role. So it requires an individualized approach. So I'll be concluding my talk, and these are some of the pictures I just wanted to mention. That is, the first one is the SSKM hospital, the entrance of IPGMR. That is a place, that is a Quest Mall. Like, these are memories that I have. That is where I used to stay, the left side, and that is where I used to eat during the night duties that I used to do in SSKM. That is the only veg restaurant since I'm a vegetarian. And the Bilram Mandir I used to regularly visit. So Kolkata has always brought a lot of good memories for me, and it's very close to my heart. And I really thank the organizing team for giving me this opportunity. Thank you.
Thank you, Dr. Saurabha Bhatt, for that talk on male factor infertility. If there are any questions on that, Dr. Professor Ashish Basu has a question, I think.
Thank you, Dr. Bhatt, for your nice presentation and your some sweet memories of Kolkata. You have recapitulated, so that's a wonderful thing. Now, regarding the male infertility, from the hormonal evaluation, I think that prolactin and also the thyroid function should be taken into account.
True.
And secondly, in diabetes particularly, the males may have developed some sort of severe phimosis due to recurrent melanoposthitis or fungal infection or etc. So that also to be taken into account. And again, one thing you have correctly reiterated that in the diabetic patient, there is a latest exploration of the incidence of hypogonadism, and it is basically the central hypogonadism.
Yes.
Okay. It was first established by Dr. Paresh Dendona et al. From Buffalo University in the year 2004. And in medical college, myself with Dr. Pankaj Singhania, we carried out a study in about 150 patients of type 2 diabetes, and our observation was that sort of 40% incidence of hypogonadism. So that is a very important factor not to be forgotten and not to be overlooked. So taking all these things, the male infertility sometimes, there is this psychosocial problem which is to be very much emphasized, and proper counseling has to be done. With the wife, the psychosocial matching if is not done, so that may not arouse the sexual impulse on the part of the male partner. So that is a very vital thing to be properly counseled. So these are my inputs. Thank you for your presentation.
Thank you, sir, for those thoughts on infertility and hypogonadism. I'd like to thank Dr. Saurabha Bhatt for that wonderful presentation. A big round of applause. And we quickly move on to our sessions on preventive medicine. A stitch in time saves 9. And for the first talk, we have none other than Professor Shotinath Mukhopadhyay, sir, Senior Professor, Department of Endocrinology, IPGMER, Kolkata. And sir has been one of the most instrumental and pioneering person in diabetic foot in this part of the country. Myself, including, and many of our colleagues have learned diabetic foot from sir, and it is my pleasure to introduce sir as the speaker for preventive medicine, diabetic foot ulcer. Sir, thank you.
Good afternoon. Thank you, Pankaj, for the kind words.
as I'm giving this presentation, which is supposed to last for 20 minutes, so you see as many as 40 limbs will be lost somewhere in the world due to diabetic foot ulcer. And what is most unfortunate is that the burden of this problem is not realized, and 85% of such limb losses are eminently preventable through simple foot care strategies. Now, you all know diabetic foot ulcers develop due to repetitive trauma on an insensate foot, the loss of sensation being due to diabetic neuropathy, peripheral neuropathy mainly, but autonomic neuropathy also contributes. And if you have superimposed peripheral vascular disease, then you have a foot at risk of developing foot ulcers. And given the habit of barefoot walking in our country, outdoor barefoot walking has reduced considerably, but walking barefoot indoors continues to be a habit, and that causes calluses, cracks, and fissures in the neuropathic foot, inviting infection. So infection then complicates the scenario, and you have the full-blown diabetic foot ulcer. So this cartoon shows you how the different types of neuropathies contribute. You all know about the somatosensory neuropathy. Then long-standing uncontrolled diabetes can bring about loss of small muscles of the foot, also intrinsic muscles, which is called the intrinsic minus foot, which puts the foot at a high risk of ulceration. Autonomic neuropathy contributes by way of dry skin that predisposes to calluses, and then you have an arteriovenous shunting opening up in the foot, causing tissue hypoxia, whereas when you palpate the pulse, you see that the pulse is bounding. So a classic example of warm ischemic foot. But when you measure the tissue oxygenation, you find that the foot is hypoxic. So how to prevent diabetic foot ulcer? Well, you prevent diabetes, you don't have diabetic neuropathy, so no diabetic peripheral vascular disease and no foot ulcer. But easier said than done. You really cannot prevent diabetes to a great extent globally. So what should be the next step? When you have diabetes, can you prevent neuropathy? So how do you prevent neuropathy? Does glycemic control matter? Well, studies have shown that tight glycemic control can clearly delay the onset and progression of diabetic neuropathy. But as far as type 2 diabetes is concerned, which is 95% of all cases of diabetes, there is no clear evidence that tight glycemic control can actually prevent the onset and/or halt the progression of diabetic neuropathy. There are exceptions. The long-term data from EcoPDS and again long-term follow-up data from Steno 2 multifactor intervention does show some improvement in autonomic neuropathy, but there is no clear evidence. And then you know that if you have poor glycemic control, you have a high risk of diabetic foot ulcer. But again, there is no evidence that intensive glycemic control can promote healing of diabetic foot ulcer. So in this prospective study, which is currently ongoing, Pankaj has been one of the participants in this. So we are actually looking at the impact of long-term intensive glycemic control in a randomized control manner on the rate of healing of diabetic foot ulcers. How to evaluate neuropathy at the bedside? Well, there is a simple 2-minute bedside evaluation where you can actually do a monofilament test, and you check the vibration with the tuning fork, and using the same tuning fork you can also check the heat and cold sensation, provided you have access to a bucket of warm water and another bucket of ice water. So you check for vibration perception threshold using 128 Hertz tuning fork. And when I trained in this technique called corneal confocal microscopy for neuropathy, I used to have access to that Vibra tip, which is a very pocket friendly. It's less than 10 pounds a piece, and it has a built-in battery. So you just press on the body of this Vibra tip and it generates a vibration, and you can check around 500 patients with one single Vibra tip. So it's quite cheap and very handy instrument. Temperature perception I discussed, how we can assess. Then pinprick sensation on the dorsum of the great toe, just proximal to the nail bed. Whether the patient can feel the sharp pinprick, that is normal. If he doesn't feel it, it's abnormal. When you have all those data, you can actually calculate the neuropathy disability score. So for the right and the left, so normal is 0 and abnormal is 1, so total out of 10. If the patient has a score of 3 to 5, it's mild, and severe neuropathy is 9 to 10. So that's the monofilament on your left. Again, you use a 10-gram monofilament, put enough pressure so that the filament buckles, and you ask the patient if the patient can feel the pressure. So it's a test of large fiber neuropathy. On the right, you see quantitative vibrometry, where you can actually quantify the impairment in vibration perception threshold. In the foot clinic, actually, we use this instrument. Again, this is slightly labor intensive, but actually gives you quantitative estimates of cold and hot sensation. So impairment is actually a signature for small fiber neuropathy. So once you have evaluated the neuropathy, next comes peripheral vascular disease and how it impacts on diabetic foot ulcer. Of the risk factors, you can see smoking and diabetes, they top the list. And you can see the odds of more than 4. And when you have the combo, diabetic who smokes or a smoker who becomes a diabetic, the odds of developing foot ulcers actually increases many, many folds. And it's very aptly described by WHO in a slogan that you can either have your legs or you can have your cigarette. You cannot have both. So high is the risk of smoking in the causation of peripheral vascular disease in diabetes and the subsequent foot ulceration. Chronic kidney disease affects around 1/3 of type 2 diabetics. And again, patients with renal insufficiency, they have significant atherosclerotic changes involving the foot vessels, very nicely described by David Armstrong from the University of Miami as the renal foot. So do a foot x-ray in a patient with CKD, DKD, diabetic kidney disease, and you see vascular calcification, which puts the foot at a very high risk of diabetic foot ulcers. Now coming to the evaluation of peripheral vascular disease, this is the ankle brachial index, where you calculate the ankle systolic pressure and the brachial systolic pressure, and then find out the ratio. So 0.9 to 1.3 being normal. Studies have shown good correlation between symptoms of peripheral vascular disease and the ABI values. As you can see here, if it is less than 0.5, you have this correlates with intermittent claudication. Less than 0.3, it correlates with ischemic rest pain and so on. Having said that, I must also emphasize here is that the fact that due to atherosclerotic changes plus minus vascular calcification, the vessels often become non-compressible in diabetes, and you have an ABI which is more than normal, which is more than 1.3. So what do you do in such a situation? Well, you have to fall back upon digital vessels which are usually not affected by atherosclerosis. So you measure the toe brachial index, and that's the instrument for you. Again, if it is more than 0.7, that is normal, and less than 3.3 is consistent with a critical limb ischemia. I hope the video runs. So this is, you can see Dr. Pankaj doing this automated evaluation of perivascular disease. Here you have the brachial, the ankle, and the toe systolic pressures being captured simultaneously, and you get a computer-generated report, which will come in a second. I hope it will come now. Yeah. So you have the estimates of perivascular disease in terms of your ankle brachial index and the toe brachial index. Now, here is a patient, 58 years, male, diabetic for 23 years, hypertensive smoker, presented with a dry gangrene on the left fourth toe for a month. Now, this patient was having intermittent claudication, and he complained about this to his primary care physician, but nothing much was done except that he was put on a combination of aspirin and statin. On presentation, the dorsalis pedis was absent, posterior tibial was present. So we did an ABI, and as you can see, this reflects non-compressible vessels, 1.4, 1.3, and if you look at the X-ray, you can see widespread vascular calcification, which explains why the patient had such elevated ABI in spite of having a dry gangrene and intermittent claudication. So we did the TBI next, and again you can see this is 0.4 and 0.36, whereas the cutoff for critical limb ischemia is less than 0.3. So having said that digital vessels are relatively free of atherosclerotic changes, we do come across situations where even the digital vessels are non-compressible. So your TBI is also not reduced to a great extent. What do you do then? Well, this instrument actually gives you the transcutaneous oximetry, and normal individuals have a value between 50 and 90 millimeters of mercury. Here on the right, if you see, the TCPO2 in this patient from right dorsum is 24 millimeters mercury, which is consistent with the critical limb ischemia. We did a Doppler study of the same patient, and you can see on the right the monophasic flow. On the left and on the middle, I have put some representative, Doppler pictures just to tell you that the normal flow on the left is a triphasic response. Then in the middle, you have a moderate peripheral vascular disease biphasic response. And in this patient, on the right, you can see a monophasic response consistent with critical limb ischemia. So we went forward and did a CT angiography, which is considered the gold standard for peripheral arterial disease. And here you can see complete cutoff of flow below in the infragenicular, in the posterior tibial circulation. And so eventually an angioplasty was done, and the patient is now doing well. I'll not go into the details of treatment because tomorrow morning in the same hall, Dr. Ashu Rastogi will be speaking on treatment of diabetic foot ulcers. So in our series, we found TBI to be much more sensitive than the ABI, although the specificities are comparable, and that's the paper. So we suggest that toe brachial index and not ankle brachial index is appropriate in the initial evaluation of peripheral arterial disease. Now, coming from peripheral vascular disease to the problem of infection, we all know that methicillin-resistant Staph aureus, MRSA, is a significant problem in chronic non-healing diabetic foot ulcers. So to better understand the role of MRSA, we designed this study where we actually looked at the association between nasal carriage of MRSA and foot skin MRSA in people with non-healing diabetic foot ulcer. And here you can see that people having both diabetes and foot ulcer, D plus, F plus, they had a much higher nasal carriage rate, 40%, compared to people, healthy control, having a carriage rate of 10%. And if you see the association between nasal carriage rate of 40% with the skin carriage rate of 30%, that is the dorsum of the foot with unaffected with foot ulcer. So there is a significant association, 40% nasal carriage, 30% foot skin carriage. So telling us that there might be some association between nasal carriage and the prevalence of MRSA. So that's the paper. Nasal MRSA carriage is a risk factor for development of antibiotic resistance in diabetic foot ulcers, and we did the antimicrobial assay and found significant polymicrobial resistance. And finally, this paper talks about the role of infrared dermal thermometry, which is the simple infrared thermometer that you all saw being used to check temperature during COVID. It's the same kind of thermometer, and when you check the average foot temperature and the ulcer site temperature between the affected and the unaffected feet, so you see that average temperature and ulcer temperature were raised in feet with ulcers as expected, although average temperature normalized at skin closure, that is the healing of diabetic foot ulcer, ulcer temperature, ulcer site temperature took 1 month longer. So here is a message that even after skin closure, if you find that the ulcer site temperature is elevated by more than 1 degree, you continue to offload the foot, continue to use antibiotic till the temperature difference between the ulcer site and the non-ulcer site becomes less than 1 degree. So only then you can prevent recurrence of foot ulcers. Otherwise, if you have a temperature difference, which is shown over here on the right panel, you can see 1 month after ulcer healing, the temperature difference should be less than 1 degree gradient. But at skin closure, which is at the middle, still there is a 2.2 degrees centigrade temperature increase. So telling you that you have to continue to treat this patient, otherwise there will be a recurrence. Finally, prevention of neuropathy, as you all know, is a challenge because unlike in nephropathy where you have access to microalbuminuria, in retinopathy you have access to fundus photography or even ophthalmoscopy, so you can directly see the retina. In neuropathy, you only have your vibration perception, temperature perception. By the time they become abnormal, actually it's a far advanced neuropathy and nothing seems to be working. So can we have early detection of neuropathy? Well, so corneal confocal microscopy is an instrument that actually allows you access to the corneal nerve fibers directly. So you can see the nerve fibers, you can measure their length, the branch density, and the fiber density, and quantify them in a non-invasive manner. So in this paper, you can see on the left you have your normal controls, and you can see the abundance of nerve fibers of normal length and multiple branches. Then in the middle you have diabetic neuropathy, which is negative for VPT and thermal. So your VPT is normal, thermal perception is normal. You do corneal confocal microscopy and you see you have loss of corneal nerve fibers and branch densities. On the right you see severe neuropathy with near total loss of corneal nerve fibers. So then can there be a biomarker to look at this corneal nerve degeneration, because CCM is not widely available even in teaching institutes. So we found out netrin-1, which is an axonal signaling molecule, and in this paper we actually found circulating netrin-1 levels. They are reduced and are related to corneal nerve fiber length in diabetic neuropathy. And so then we went on to see if there are regulatory microRNAs for this nectin-1 that can allow us to intervene at a much earlier stage. And here in this study, I'm running out of time, so let's hurry. So we found a significant negative correlation between microRNA 27A and serum nectin-1. So to summarize, this is the paper presented at the last ESD meeting 2 weeks ago. So the correlation between microRNA 27A and nectin-1 in people with diabetic neuropathy. I think I'll stop here and I'll be happy to take questions. Thank you for listening.
Thank you, sir, for that extremely elaborate overview on diabetic foot ulcer and the various aspects related to it. There must be some questions related to diabetic foot ulcer. If there are any. Ravida has a question, I think.
So because of the better patient foot care, is the incidence of amputation decreasing? Because you showed in the first slide that every 30 seconds some amputation is being done. But when we were student or when I was attached to DFSI, then it was said that every 5 seconds.
Yes.
Now every 30 seconds. So that's what I'm saying. The incidence is decreasing because of better awareness and better foot care and other things.
Yeah, I agree with you.
Yeah.
Thank you.
Thank you.
Thank you, Professor Sotinath, for a very eye-opener presentation and giving us newer vistas in the field of diabetic foot. As you have rightly pointed out, the mind-boggling incidence of diabetic foot, I think the teaching which you have promoted and we are also promoting, the examination of a diabetic patient should start from the feet to face. And the message to be percolated to our caregivers and the patients that you should take care of the foot as much as you take care of the face. I had the privilege to hear from Dr. Boulton, the father figure in the diabetic foot. He quoted from Winston Churchill, the British Premier, that if you commit one mistake by not knowing it, then you commit 10 mistakes by not looking into it. This is very much relevant in the treatment of diabetes. This is my input as a corollary to what you have said, that it is preventable.
Thank you for reminding us. Couldn't agree more. Thank you.
Thank you, sir, for that wonderful talk, and a big round of applause for Professor Sotinath Mukhopadhyay, sir.
Thank you so much.
Moving on to preventive medicine, moving from the feet a little up to the kidneys, diabetic kidney disease, and to deliberate on that, we have another senior professor from the southern part of the country, Professor Bantwal. Professor Ganpati Bantwal will deliberate on diabetic kidney disease. Presently, sir is professor and former head at St. John's Medical College. We all know he was past president Endocrine Society of India. We've seen ourselves become endocrinologists when he was president, and sir will tell us about diabetic kidney disease. Thank you, sir.
Yeah, thank you. Before I start, let me thank the organizers for giving me this opportunity, especially Partha Pratim. So I'll go to how do you prevent diabetic kidney disease. So why is it important to prevent diabetic kidney disease? So this is one of the microvascular complications that affects 40% of individuals with diabetes. This is a leading cause of end-stage kidney disease, said to affect 700 million people, and more often it affects the socially disadvantaged. My professor used to tell, if you get a CKD, if a poor patient gets, he can't actually bear the cost of it, so that's a problem. And the prevalence is actually increasing from 19% in 2000 to 30% in 2015. Incident end-stage kidney disease also has increased from 22% to 31%. Now, why are we concerned? Threefold higher risk of all-cause mortality, 16-year loss of life expectancy. We told if you have a CVD, 12 years, whereas if you have a CKD, 16 years. And reduced GFR and albuminuria independently predict CV morbidity. A person with DKD dies not because of end-stage kidney disease, he dies because of cardiovascular disease. And this problem worsens when the GFR is less than 45. So he first develops the CVD, and then if he has survived that, then he'll go for the ESRD. So what is the definition? Abnormalities of kidney structure or function present for more than 3 months. It requires 2 criteria documented or inferred for more than 3 months. One, you require a GFR less than 60 ml per minute, or markers of kidney damage including albuminuria, or it could be hematuria, it could be electrolyte imbalance, or in histopathology you got an abnormality, or radiologically you got an abnormality. So these are the ones. So you have this heat map also, so where you have both of them, GFR and albuminuria, and albuminuria with A1 being normal, A2 being moderately increased, that is a microalbuminuria, and A3 being severely increased. You know, the nomenclature is better off if you write A2 moderately increased rather than microalbuminuria, because patients will not know the importance of that. At A2 itself, it's significantly increased, and A3 it's still worse. So you can have very good GFR and albuminuria like the nephrotic syndromes, and this will tell us how to refer also to the patient. So if you are in these red boxes, at least 4 times a year you must do this testing, and naturally you'll have to refer them to a nephrologist also. So what is the pathophysiology? So you have 3 factors. One is a metabolic dysregulation, hemodynamic perturbations, and inflammation. So these 3 giving various proportions, that's because of genetics. So some may have predominantly metabolic dysregulation leading on to the kidney failure. Another could have just hemodynamic perturbation, and another could have inflammation itself. And how does it produce? Hyperglycemia, adiposity, dyslipidemia, increased rage. It activates all these pathways, and it can lead to reactive oxygen species development and reduced nitric oxide availability. Hemodynamic perturbation. So the main thing, hyperglycemia per se can actually lead to that. So you have less sodium to the macula densa, abnormal tubuloglomerular feedback, and that's how this SGLT2. So why do we want to know this thing is, we can develop a target for treating this or blocking these pathways. And inflammatory, now you have actually the non-steroidal mineral receptor antagonist. So insulin resistance, COX-2, prostanoids, kallikrein produces all these things. All the 3 will produce afferent arteriolar vasodilation and efferent arteriolar vasoconstriction, which ultimately leads to albuminuria and renal fibrosis. So you have non-modifiable risk factors like genetic factors, male gender, long duration of diabetes, increasing age, family history of diabetes and hypertension. This is the most important thing. Family history of CKD, very important. 80% chance of you developing CKD in them. And so you have to be very aggressive in treating these patients. Don't tell, okay, 130/90 is okay, it's fine, we'll wait for some more time. No. In them, ensure that the blood pressure is normal. Modifiable risk factors like poor glycemic control, hypertension, lipid abnormalities, smoking, metabolic syndrome, insulin resistance, advanced glycation end product, less physical activity, excessive salt intake. So I told you it's a leading cause. Diabetic kidney disease is a leading cause of end-stage disease. So you have a 3.5-fold higher risk of cardiovascular disease if the GFR is less than 60, and 6-fold higher if it is less than 15 ml per minute. So you can see here, no kidney disease, the 10-year cumulative incidence of mortality is 4.1%. Just the presence of albuminuria, almost 4-fold increase, 18%. GFR down, 24%. Both you have albuminuria and impaired GFR, 47%. So it's around 12-fold increased risk. So you can see the importance. So how do you screen? Type 1 diabetes within 5 years of diagnosis. Type 2 at the time of diagnosis. How will you screen? Spot urine albumin creatinine ratio and also measure eGFR. Because in diabetes, sometimes we find albumin creatinine ratio is normal, but the GFR is coming down. So up to around 17–18% have this type of problems. Suppose you find a positive result, confirm it, reconfirm it, because you require at least 2 out of 3 to be abnormal in a 6 months' time. So, and then start them on treatment. So what defines CKD? Persistent urine ACR more than 30 milligram per gram, or persistent EGFR less than 60, or you have other evidences of kidney damage. When to suspect other causes of CKD? One is less than 5 years in type 1 diabetes, you develop albuminuria, absence of retinopathy, this is very important, systemic illness with kidney damage, like say you have hematuria or CASA present, unexplained AKI or decline in rapidly progressing renal failure, massive albuminuria, within 2–3 years he develops nephrotic range proteinuria, start suspecting other causes, or you find RBC, WBC cast, then also you suspect. Sometimes what happens, you may have a falsely positive UACR. That could be because of patient may have CCF, control it and then check it. Exercise, intense exercise, not the usual exercise. You have fever, infection, marked hyperglycemia, control it and then check it. If the patient, if it's a female and having menstruation, then also you can have this abnormalities. Is there any other markers? Yeah, people have tried using transferrin, NGAL, KIM1. These are some of the other fatty acid binding protein, 8-hydroxydeoxyguanidine, pentosidine, etc. Still not come up. I mean, you don't have evidence base for that. Some studies showing good like that. So what are the pillars of prevention of cardiorenal risk? Lifestyle modification, diabetes education, plus glycemic management, blood pressure management, lipid management, and whenever you are using an agent, anti-diabetic drug, use an agent with cardiovascular and renal benefits. So the only proven diabetic kidney disease prevention intervention in type 2 diabetes is good blood pressure reduction, glucose reduction to A1C less than 7% and hypertension less than 130/80. Rest are all secondary prevention. So as long as possible, try to bring the blood pressure less than 130, and if the blood glucose see that less than 6.5 also is also better, of course, without resorting to hypoglycemia. What is the evidence for glycemic control? You have the DCCT. So you can see here, microalbuminuria reduced by around 55%, macro by around 40% roughly. And in the follow-up study, the DCCT EDIC, they continue to reap the benefits. New onset microalbuminuria reduced by around 40%. New onset macroalbuminuria also reduced by around 60%. So glycemia from the beginning, intensive control, you will continue to reap the benefits. What about type 2 diabetes? UKPDS, once again you can see, at the end of 9 years, 24% reduction for microalbuminuria, and 12 years, it improved furthermore, 33% reduction. Suppose you have had somebody who's having already diabetes and you treat them intensively, will it help? Yes, it can actually help. So you can see here the normo to microalbuminuria or macroalbuminuria, you get a benefit. Similarly, from normal to microalbuminuria to macro, you also get a benefit. This is in the VADT, average age was around 65 years. So what is the glycemic target you want to keep? Try to bring it below less than 7 to reduce microvascular complication. HbA1c sometimes may not be that useful in patients with CKD. Then you do glucose monitoring. So SMBGs, or you can use a CGMS when you find there are discordant. What is the evidence for BP control? The Steno trial. So here you can see that so at the end of 4 years, at the end of 8 years, so up to more than 50% improvement in the intensive arm compared to that in the conventional arm, and also they have found benefits in the follow-up treatment also. So choice of antihypertensives for prevention of diabetic kidney disease. So if you have albuminuria, ACE, ARBs are the first line treatment. No albuminuria, you can actually use any other drug, bring the blood pressure down. But if you have albuminuria, you must use ACE or ARB, and the evidences are renal, IDNT trial, etc. So if you have, so you started a patient on ACE and ARB, so then you should monitor creatinine and potassium within 2 to 4 weeks after starting or changing dose. If you have normokalemia, less than 30% increase in creatinine, increase the dose. See, one thing you must remember, just using, say, 2.5 ml of milligrams of ramipril or 20 milligram of telmisartan, no use. You must use the full dose to get the best benefit. So there was a study where they looked into this. Those who used lesser dose had lesser effects. So you must always use complete dose, the full dose, recommended dose. If you find more than a 30% increase in creatinine, look for other causes, look for volume status. You can down titrate the diuretics, stop NSAIDs. If there is hyperkalemia, consider using other drugs like add a diuretic or a potassium binder. So the limiting factor is not potassium. Even if there is potassium excess, you can actually give a potassium binder and actually use it. Only thing is the creatinine increase more than 30%, start looking for other causes. So another study, a Benedict study showed ACE inhibitors were useful even in type 2 diabetes, because normally we say for type 1, lot of benefits from ACE, and for type 2 it was mainly from ARBs, but then this study showed you can also use the ACE inhibitors. So what is the target you want to keep? So the ACC AHSA is less than 130/90, ADA less than 140/90, but if you have an ASCVD risk more than 15%, the target should be less than 130/80. What about dyslipidemia management? So field study, fenofibrate. So in this, albuminuria on an average progressed 15% less frequently, reversed 16% more among those who received fenofibrate. And similarly, statins also have been found to be beneficial in reducing albuminuria. So what are the other prevention strategies? Lose weight. So you have an entity known as obesity-induced glomerulopathy. So this is a separate entity. So he may be normotensive, but still can develop a kidney disease. So obesity, because that's because of inflammation. Obesity is you have the adipocytes which are inflammatory, and that can produce reactive oxygen species producing damage to the kidney. So it's always better we lose weight. So another cause. So you may think he's metabolically healthy. No, he may develop glomerulopathy early also. So BMI, once again, as the BMI increases, you can see the hazard ratios increases. Cessation of smoking, very important once again, so that will also help. So diet, a DASH diet, we say, fruits, vegetables. You can use less of starchy, whole grain starchy vegetables, okay. So consume diet high in vegetables, fruits, whole grains, fiber, legumes, plant-based proteins, unsaturated fats and nuts. Avoid processed meats, refined carbs, sweetened beverages. And if you have CKD, protein intake of 0.8 grams. If they are already on dialysis, don't restrict it because they are already protein deficient. There you can use up to 1.2 grams per kg per body weight. So dietary fibers actually help against diabetic nephropathy because they act on the gut bacteria. They produce increased short-chain fatty acids. This can act on the G protein-coupled receptors, producing improvement, amelioration of nephropathies. Low sodium diet, less than 2.3 grams is beneficial. Suppose people say, I'm eating salt, you tell 10 grams, it's 40%. Suppose you are giving 10 grams, that means 40% is sodium. So you have to give around 6 to 7 grams so that it comes below 2.3 grams of sodium. So now what they have found is, suppose somebody has albuminuria and you give more salt, he will develop an increased response to blood pressure compared to somebody who does not have albuminuria. That's the reason salt restriction is very important. So you have two patients, both don't have hypertension, but one of them has albuminuria. You get a worse response with a patient with albuminuria. Coming to pharmacological prevention, you have 4 pillars. Like in heart failure, you have the 4 pillars. Similarly, you have the number 1 is RAS blockade, very important. Then you have the SGLT2 inhibitor, so you must start it as early as possible. And then you have used this and still you continue to have albuminuria, start finrenone. So non-steroidal mineralocorticoid receptor antagonist. And then now recently the flow trial came and they found that the GLP-1 receptor agonists are also useful in preventing or slowing down the renal problems. A lot of evidence for SGLT2 inhibitors, the EMPA-REG, CANVAS, DECLARE-TIMI. Initial were secondary outcomes, but then in the CREDENCE, the DAPA-CKD, the EMPA kidney, they were primary outcomes. So they found beneficial effect up to 30 to 40% improvement. Non-steroidal, you have the Figaro, Fidelity, and Fidelio CKD, DKD trials, and the combination, the Fidelity outcomes. So they showed a benefit in patients with diabetic kidney disease. So what do you do? Diabetic kidney disease, you have RAS blockade. Add SGLT2 inhibitors to this group. If SGLT2 inhibitors is contraindicated, then you add finerenone. Efficacy and safety of SGLT2 inhibitors and finerenone combination in diabetic kidney disease is unknown. There is a trial known as a confidence trial, which is just going on. We were a part of this. Unfortunately, we just got the ethical approval just around 15 days back, and we couldn't recruit much. So that will tell us whether this combination will actually help. So if you have a potassium more than 5, don't initiate finerenone. GFR more than 60, give full dose of finerenone, 20 milligram. Less than 60 and 25 and potassium less than 5, start with 10, stable, then you can actually up titrate to 20 milligram. And if it is more than 5, withhold it. More than 4.8 but less than 5.5, continue same dose of finerenone, which could be 10 or 20. Less than 4.8, continue the same dose of 10. So GLP-1, this is the flow trial recently published in the EAST. 24% risk reduction in major kidney outcomes, and the decline in kidney functions were also seen better with GLP-1. So you have other studies also. LEADER trial also showed a benefit of 22%, SUSTAIN trial 36%, AVARD, REWIND trial, all of them showed. Tirzepatide, which is going to come next year, once again was associated with reduced occurrence of composite kidney outcomes. And there were other trials. We are a part of Avasentan trial, Aliskirin trial. They all did not see the light of the day. So holistic approach for diabetic kidney disease prevention, healthy eating, good physical activity, smoking cessation, weight reduction, good amount of sleep is important. First line therapy, metformin, SGLT2 inhibitors, you should use it. Still the blood glucose is not coming under control, use a GLP-1 agonist. Suppose for blood pressure you have used RAS, it's still albuminuria is present, add a mineralocorticoid receptor agonist. But if the BP is still high, you can add a CCB or a diuretic. High intensity or moderate intensity statins to be added to prevent cardiovascular outcomes. And then up titrate the dose of mineralocorticoid receptor antagonist. And for ASCVD, if it doesn't come down with a statin, ezetimibe, PCSK inhibitors, etc. can be added. So my take-home message, diabetic kidney disease is a leading cause of end-stage kidney disease. It suggests generalized endothelial dysfunction. It's not only at the level of the kidneys, it's the heart, everywhere it's happening. Prevention of diabetic kidney disease provides cardiovascular protection and reduces mortality. Whatever targets, A1C less than 7, blood pressure less than 130, only proven primary prevention intervention for DKD. Early screening and treatment is the key to prevent progression. You have the 4 pillars: RAS blockade, SGLT2 inhibitors, non-steroidal mineralocorticoid receptor antagonists, GLP-1, along with weight reduction, exercise, DASH diet, and smoking cessation will actually help to ameliorate the diabetic kidney disease. Thank you for patient hearing.
Thank you, Ganpati sir, for that overview of diabetic kidney disease. If there are any questions related to this complication, I think there is one.
Thank you very much for your excellent presentation. I've got one question. That if a patient who just recently diagnosed as diabetes and is on antihypertensive medication for a long time, for example, for the last 5 to 10 years, and suddenly if we find that there's increase in creatinine more than 30%, but the potassium level remains normal, should we change the ARB or ACE inhibitor, or should we continue it?
If the increase has happened immediately after starting, only then you will stop it. Suppose he has been used, as you told, for 5 to 10 years, you don't have to. Because that is, he was not so well controlled with diabetes, hypertension as well as diabetes. So both could have worsened the increase in creatinine, or also look whether he's on other medications, like he took an NSAIDs and that could have led, or he's on a diuretic, excessive diuresis. This could have led to that. Immediately after starting, then only.
And what would be the drug of choice of anti-diabetic in this patient? Should we go on to like linagliptin or SGLT2 inhibitors if the patient is borderline diabetes?
SGLT2 inhibitors are naturally better because you have outcome trials. With linagliptin, they're all neutral. Here it is superior. So you have to use this. If the GFR is more than 20, you use it.
Thank you very much.
Yeah.
Sir, in Indian scenario, which formula for EGFR?
Okay, we are using the CKD EPI. So that's the one you can actually use it.
Sir, weight is very or not? Suppose 60 years male persons?
Yes. There is a problem with that. Yeah, I do agree with that. But in general, we follow that. Okay. So that's the reason sometimes if you find there is an abnormality, they say you calculate with cystatin C and creatinine. That will be better, they say, to avoid for this Indians like that, racial differences.
Thank you, sir.
Thank you, Dr. Ganpati, for that talk on DKD. A big round of applause. From monologues, it's time we move on to heated discussions. And there are a couple of debates lined up immediately. For the first debate, I'd like to invite on stage the Dr. Anish Kaur and Dr. Piyash Gargari. Both of them on stage, please. Both of them happen to be senior residents at Department of Endocrinology, IPGMER, Kolkata, and close associates, colleagues, and friends. They will be discussing on primary aldosteronism, while Dr. Anish will be favoring complex testing. Dr. Piyash will probably say it's better not to test, but treat empirically. And at the end, both of the speakers will get 10 minutes each for their initial deliberation, followed by 2 minutes for rebuttal, and then the motion will be put to the House for vote. Dr. Anish with complex testing for primary aldosteronism.
Thank you, Dr. Pankaj Singhania. It's always an honor to be speaking after your respected teachers and guides. And after such excellent presentations, we'll now be going into the debates, and especially regarding an area such as primary aldosteronism. And I'm happy that I will be debating my colleague and fellow SR, Dr. Piyash Gargari, on this report, but I may not be kind to him. So going straight away into the details, the outline of my presentation would be the description and epidemiology of PA, why should we be testing, the screening criteria, who to test, the biochemical testing, screening, and both confirmatory tests, how subtyping may help, and definitely after that, if you have time, precision diagnostics in primary aldosteronism, so as to answer what exactly are we trying to test. Why are we asking so many questions? Because as Dr. Albert Einstein said, never lose a holy curiosity, and we endocrinologists are always chasing after the what's, whys, and hows. So primary aldosteronism, it can be defined as a group of disorders with the following hallmarks. There will be a suppression of baseline renin secretion, there will be an inability to stimulate renin secretion normally, and there will be an inappropriate and non-suppressible aldosterone production. So what happens is that you have the non-suppressible aldosterone being secreted from foci in the adrenal gland, and they are so much so that they, in spite of the stimuluses which would usually cause aldosterone secretion, so there is low angiotensin 2, low renin levels as well. These go and increase the sodium conductance in the epithelial aldosterone sensitive tissues via increased sodium conductance to the ENaC channels. Meanwhile, there is increased potassium extrusion, increased hydrogen ion excretion in the distal tubule, which would explain the hypokalemia and the metabolic alkalosis as part of this syndrome. Now, the non-genomic effects of aldosterone outside its effects on epithelia would include the cardiovascular disease risks. It has been seen to contribute to left ventricular hypertrophy, atrial fibrillation, stroke, and heart failure. As far as kidney disease is concerned, it contributes to glomerular hyperfiltration, accelerated decline in GFR, end-stage kidney disease, and proteinuria, as well as could be a part contributor to type 2 diabetes, metabolic obesity, obstructive sleep apnea, as well as predisposing to osteoporosis and fractures. So if we see, mostly across screening guidelines, if you see all hypertension, even Dr. Kahn, who had discovered primary aldosteronism, said that PA accounts for maybe 15% of patients, as in the red bar. But you see that the pathophysiology starts getting shaded in red quite way before that. If you concentrate down that to resistant hypertension, where patients are requiring at least 3 antihypertensive drugs on maximum or maximally tolerated doses, including a diuretic, then in that scenario, the PA population is overrepresented at 25%, and the continuum increases at an even earlier state. And only maybe 1 or 2 out of 100 people are screened, even in the best of screening facilities and in high-risk populations. So we are losing out quite a number of patients with undetectable primary aldosteronism. Again, if you are dealing with hypertension, and a part of it is secondary hypertension, which is mediated by hormones, then primary aldosteronism is possibly the most common cause of endocrine hypertension. But if you go to screen it as a whole in the hypertensive population, it will account for 1 to 2%. This was even seen in the Indian population as well in a meta-analysis published in 2014. But then why are we so concerned? This study published by Dr. Brown and Anand Vaidya et al. In 2020 in the Journals of American Internal Medicine, they showed that as you screen these hypertensive or normotensive individuals on the basis of 24-hour urine aldosterone secretion, why, we'll discuss that later, then in normotensive individuals, that accounts for a crude prevalence of 9%. If you consider a suppressed renin, that increases to 10.9. And if you go by an aldosterone-renin ratio of more than 30, then it accounts for 26% of that left bar. So all these percentages gradually increase across stage 1 hypertension, stage 2 hypertension, so much so that in resistant hypertension, that accounts for almost 24% of individuals with PA, and maybe in the unselected population, where with a suppressed renin, that increases to 52.6, and almost 26% of resistant hypertension individuals have an ARR of more than 30 and a 24-hour urine aldosterone of more than 10 nanogram per deciliter. So even in an Indian study published by Dr. Alam et al. In 2021 in the Indian Journal of Endocrinology and Metabolism, it showed that around of 202 young onset hypertensive patients, 18.8 screened positive, and 17.8% had confirmed primary aldosteronism. The mean age was around 43, and the median duration of hypertension was around 10.5. So there is a high prevalence and a long delay in the diagnosis of primary aldosteronism. Whom to screen? The Endocrine Society guidelines recommend those individuals having a sustained BP of more than 150 by 100, or those having resistant hypertension, or those with spontaneous or diuretic-induced hypokalemia, or with adrenal incidentalloma, or with OSA, or with a family history of PA, or with a family history of early onset hypertension or stroke at less than 40 years of age, should be screened as per the JCM guidelines published in 2016. Please remember, this was not a pharmaceutical sponsored guideline, rather the Endocrine Society solo funded this venture. Then hypertension with atrial fibrillation was proposed as one of the screening criteria. Then in 2022, Dr. Vaidya said that maybe this population should be expanded to new onset hypertension, stage 2 hypertension, and maybe all hypertensive individuals. That is the current recent consensus, and that is even agreed, but on an expert opinion basis across the various specialized societies dealing with hypertension. In fact, the recently published European Society for Hypertension guidelines state that screening for primary aldosterone by renin and aldosterone measurements should be considered in all adults with confirmed hypertension. So then these would be the standard ways we would be going ahead with a plasma aldosterone and a plasma renin activity or direct renin concentration. These guidelines are to be followed. I will not detail them,
But at this point, I should point out that immunometric assays are commonly used worldwide, including ours. And oftentimes, there may be issues in measuring the various substrates on these assays. And PRA, plasma renin activity, is a better parameter than the direct renin concentration, as it measures the active renin only. And it takes into account factors such as patients being on OCPs that could alter endogenous renin substrate levels. The direct renin concentration, if you go to measure it, take into account that it is lower in premenstrual women but remains unchanged as if you measure PRA. And at the lower levels of normal, there is poor correlation between PRA and DRC. So if DRC samples are handled at room temperature, then freezing or exposing samples to low temperature during this assay can artificially increase the value owing to cryoactivation of prorenin to renin. And if you are using the PRA assay, then handling the plasma at room temperature can lead to angiotensinogen consumption, increased angiotensin 1 generation, and therefore high blank values, which could lead to an underestimation of renin. These are the cutoffs which have been mentioned in the JCM 2016 guidelines, and ARR of 1.12 has also been proposed as a cutoff. So then what about the various drugs? Because that is always a big bugbear when we go around to testing our suspected PA patients for primary aldosteronism. So as we can see in this nicely detailed table, most of these drugs that common antihypertensives that we use can lead to false negative or false positive tests. But the drugs which are safe to be used in this regard include alpha blockers such as prazosin, verapamil, and hydralazine. So if your patient remains on those drugs, there should not be an issue. And a current scenario stating all these influences states that if patients are on diuretics, MRAs, or ACE inhibitors, ARBs, or calcium channel blockers, and they have a high ARR, then PA is highly probable. And if they have a negative ARR, then you should at least stop the diuretics for 4 weeks, and you should stop the mineralocorticoid receptor agonists for 6 to 8 weeks, and then repeat it once again. But this has also been suggested that if your renin levels are suppressed despite being on antihypertensives, including the above, then you need not do a drug washout in that scenario. So now, what about aldosterone? There is high intra-individual variability of plasma aldosterone, and this has implications for case detection. And there could be variability of measurements during AVS sampling for PA as well. So the current recommendation states to have a plasma aldosterone concentration of more than 10 nanograms per DL and a PRA of less than 1 nanogram per ml per hour, or a DRC less than the lower reference range. But maybe we should be transitioning to a 24-hour urinary aldosterone excretion. Why? Because this 24-hour urinary aldosterone, it integrates production throughout the day. It is less susceptible to daily variability, unlike aldosterone. It also only measures the free and acid labile aldosterone. But the problems regarding it is that the patients need to be educated on how to collect an adequate 24-hour urine sample, and it requires that the patient be on a relatively high sodium balance for interpretation as well. The confirmatory tests and the ones we commonly use are the saline infusion test.
Dr. Anish, I think you have 30 seconds to wind up.
Right. So just going ahead, they also have their own issues as well. And if you have a PRA of less than 1 and a PAC of more than 20, then they do not need to undergo any confirmatory testing. So this is the current approach. Subtyping AVS should be given in those individuals where you have a high probability of suspicion, especially in the elderly, because that can help us target the surgical approach to this patient as well. And if you are going ahead with AVS, an ONDST should be done to rule out cortisol co-secretion, which would mandate the removal of the causative lesion as well. I would like to stop my presentation here and hand it over to my co-debater, Dr. Gargari, to speak. Thank you,
Dr. Anish. I think you've made it more complex than we expected, and we expect Dr. Piyash Gargari to simplify it for us and maybe treat our patients right away. Dr. Piyash Gargari.
Thank you, dear Pankaj. So at the outset, first let me thank the organizers of Crescendo 2024 for giving this opportunity of having this debate, and especially with my bosom friend on Dr. Kaur here. Yes, but I am a bit hesitant because despite being a bosom friend, I may not be truly friendly to him today because I am a debater here. So my topic is whether empiric medical therapy is of choice. So you can see here, this is a picture. This actually summarizes my entire topic. You know, two people actually in this recent Paris Olympic 2024 got the same silver medal. One from South Korea with fancy gadgets and another Yusuf Dikek, of whom we all know. The reason is pretty clear why one got famous and another not. So let's just discuss two real life cases. These two cases, I am in doubtful to my juniors for these two cases. These are two very real life cases. The first case is a 43-year-old lady, hypertensive for 3 years, having a PSC 26.7 nanogram per DL, with a CCT abdomen showing a left adrenal adenoma with an inconclusive AVS. What is the treatment? And for case 2, a 54-year-old lady, hypertensive for 2 years, having the same picture and having a same adrenal adenoma with a lateralization towards left side, but conclusive or inconclusive, 2.23. What is the treatment? Can anybody volunteer? These are two real life cases. Okay, just let me clarify. The first case was treated by adrenectomy. The second case was treated by medical management. So what is the benefit of the so-called complex testing? So we know the empiric medical therapy, certain mineralocorticoid receptor antagonists, epithelial sodium channel inhibitors, aldosterone synthase inhibitors, that these all we know. But when we are going to choose between two schools of thoughts, the good old AFAS criteria should be considered, which is acceptable, feasible, affordable, sustainable, and which one is more safe. So let's just find out which one is acceptable. Just brushing up a bit pathophysiology. What Dr. Kaur says is absolutely true, but we have come beyond the guidelines, right? The guidelines were published in 2016, but we are living in 2024. So this article is from 2024, which explains the pathophysiology of primary aldosteronism, which says primary aldosteronism is considered to stem from either unilateral adenoma or bilateral adrenal hyperplasia. This is a traditional concept and this has been challenged. Why? This has been told that there is accrual of clusters of cells with dysregulated or ectopic CYP11B2 expression, which are called aldosterone producing micronodules. And as the age advances, there is diffuse and parallel accrual of these cells, thus leading to the heterogeneous distribution of each adrenal gland. Therefore, CT scan may show nodularity in case of hyperplasia and may miss tiny nodules in cases of where there is adenoma is actually there. There is chances of non-lateralization or false lateralization. Chance of inconclusive report, obviously. Now, 2016 guidelines, ES guidelines had been shown by my previous speaker, but the current literature does not identify a gold standard confirmatory test for PA from the same guideline. So that actually summarizes the slide. So coming to what are the confirmatory pitfalls which come beyond the guideline? We know the meta-analysis is the highest level of evidence. So from this evidence, we can see the wide variation of specificity. We know when you are going to choose a confirmatory test, it has to be of high specificity. But if you look carefully here, the specificity actually ranges from 0.6 to 1. So that's a wide distribution, which is even clarified by this ROC curve, where the points are distributed haywire across the graph, right? So all that glitters are not gold. So regarding, as Dr. Kaur has said, AVS is traditionally used as gold standard, but all that glitters are not gold. Traditionally, lateralization index is used, and why this is used? But we don't know what is the outcome, because any test that is employed for that outcome should be assessed using post-surgical normalization. And verification is obviously impossible in patients who are not operated. And sometimes where there are cortisol co-secretors, particularly in large tumors, this would lower the selectivity index. And the result you all know. So regarding this, like a gladiator who stood against the entire Roman Empire, there this trial which came out to oppose the entire guideline. That is the Spartacus trial, right? Published in Lancet, and which showed that adrenal sampling versus CT scan to determine treatment in primary aldosteronism, which showed there is absolutely no difference. Can you imagine? There is no difference between AVS and CT in terms of medical outcome, in terms of surgical outcome. And therefore, the result is treatment of primary aldosteronism based on CT or AVS did not show significant differences in outcome. So is AVS at all necessary? No. Because obviously, does a patient accept a 20 to 50% chance of having the wrong adrenal removed? No, obviously. Now regarding certain fancy tests, 18 hydroxysteroids, okay? It's good, but the data are derived from small studies and anecdotal experiences and not replicated in larger ones. Regarding empirical medical therapy, we know that traditionally the pathophysiology is excessive MR activation. And if we target the excessive MR activation, we are going to hit the jackpot, right? So growing evidence supports the extended benefit of MRA use for target tissue protection. And there is instantaneous onset of action, which is not achievable in case of your complex medical testing because the patient has to wait. And there is risk of target organ complications which dissipates gradually following initiation of medical management, right? So I think it is clear which was more acceptable. Regarding which one is more feasible. Confirmatory test, patient may need admission. Test may need to be repeated because one test may be false, one test may be true, who knows. Needs to achieve normocalemia as mentioned by previous speaker. May change concomitant medications for a certain duration of time. You can see that from my previous speaker, right? And again, where do we have exactly the AVS? Almost, you can see in this paper published in IJEM 2023, this is the first study from the Indian subcontinent. Probably 10 to 15 centers across India are doing AVS as of now. The reason is complex and costly procedure, the high-end learning age, and the differences in anatomy of the adrenal veins. And it is not even for the right adrenal vein to demonstrate because of adrenohepatic fusion. And it lacks the standardized procedure nonetheless. Regarding the advanced imaging, obviously, you need a cyclotron for them. And why everyone is so fancy? Because these are not available. We do not have cyclotron in every nook and corner of our country, right? And regarding the availability of medication, I don't think so. It is to be answered. Look, it's everywhere. Which one is more affordable? Just let's discuss a bit of economics. As per the latest data published in 2023 from the Ministry of Social Justice and Empowerment, the per capita income in West Bengal is approximately 1.5 lakhs per year. And if you just see from patient's viewpoint, at a one go, if we choose complex medical testing, the patient has to spend 55,000 to 94,000 rupees at one go. I don't know whether every patient will be able to afford that. And if we see just for the medication viewpoint, the patient has to spend almost 150 rupees per month. So isn't the choice obvious by now? And again, as my previous speaker has mentioned about the guideline, I am telling you, it is bias and bias everywhere. Why? Back to the guideline. In the long term, adrenalectomy is more cost effective than lifelong medical therapy, right? But just look at them. Was the methodology okay? Because the cost of treating was same considering the previous to adrenalectomy as well as the medical therapy, fine? And there is, you can see the significant disparity in the cost of the medicines and as well as the tests. Now, which one is more sustainable? We know that primary aldosteronism is associated with cardiovascular, metabolic, and renal complications. My co-speaker may argue that there is significantly higher risk of adverse CV events. But again, let me introduce one more caveat to this. When MR antagonist therapy resulted in substantial increase in renin, the excess risk was mitigated, replicated in American and replicated in Taiwanese studies. And the German studies even showed there is higher LVH reduction in patients who had increased renin. And obviously, don't forget the PO, that is the finerenone. We know that it showed significant CV outcome safety and significant renal outcome safety in the Fidelio and Figaro trials. So who knows, it might be a game changer. Now regarding the sustainability of complex investigations, reproducibility is poor. Also, the incidence is very low of primary aldosteronism, as already mentioned. Hence, in the absence of routine testing, might not be sustainable economically for an endocrine center. And AVS, the occurrence once in a while, not always possible to cannulate, CLI may not be confirmatory, and in inconclusive cases, suppose a report comes inconclusive, may need to repeat AVS. And God knows, if you are going to make the patient understand what that means, which one is safe. Just confirmatory tests are associated with life-threatening complications like hypertensive emergencies, hypertensive spikes, arrhythmia, radiation hazard. You have 2.5% risk of adrenal hemorrhage, infarction. It's fatal. But let's look at the medical therapy. It's not entirely void of side effect, but they are mild. And even if they occur, the drug might be switched to alternatives. EGFR may decrease initially, but that may gradually come out. And hyperkalemia can be a risk which can be overcome by other medications.
Dr. Piyash,
yeah.
Please wind up. We'll give you another 2 minutes.
Just with the last case. last case of mine, a 42-year-old gentleman comes with a hypertension with a primary aldosteronism. Saline infusion test proves it. CT adrenal left localization, but AVS shows right localization. Now, to all the respected delegates, what will you do next? Will you go for a repeat AVS? Will you go for a medical management, or what will you do? With that, I think I am able to prove the concept that if it is primary aldosteronism, it is better to go for empiric medical therapy. Thank you.
Thank you, Dr. Piyash. We will get back to Dr. Anish Kaur, and he will have his 2 minutes to make things complex further. Dr. Anish.
Excellent points made by my opposing member, Dr. Gargari, regarding the complexity of testings involved in primary aldosteronism. But again, keep in mind, here as endocrinologists, we are looking after the whys. Definitely in our country, you have to consider about affordability issues as well. But in the era of precision medicine, if you are not able to give directed solutions to your patients, then you may end up in a situation where a patient with primary aldosteronism, it could be maybe a middle-aged male, and he gets subjected to aldosterone therapy in the form of maybe spironolactone or eplerenone. He comes up to you and starts to say that he is having side effects such as gynecomastia. He is having problems such as his libido is going down. Regular monitoring has been advised, including maybe 3 to 6 monthly serum potassium reports, because the doctor has explained the risk of hyperkalemia. So the patient, and especially in our setup, especially at government endocrine centers where patients come from far off, they have to buy tickets in advance in addition to the burden of medications which are needed, so that the cost of monitoring and the side effects adds not only monetarily to the patient but also to the psychological well-being of the patient as well. So a broad-ranged empiric medical therapy for primary aldosteronism a la resistant hypertension treatment in the form of spironolactone may not be the way out. Also, if you're going to talk about these days regarding AVS, as Dr. Gargari said, that many centers in India are doing it, but even in inconclusive cases, based on the lateralization ratios or even the contralateral suppression ratios, you may decide on which adrenal to remove, considering the risk versus benefit. If you remove the adrenal containing the causative lesion, not only do you abrogate the hypertension rapidly, but the non-genomic effects of aldosterone excess on the other organs of the body are mitigated as well, which would not be the case on a patient, in a patient of primary aldosteronism on spironolactone therapy. So that's one rebuttal against that point. And yes, he showed a picture of the shooter in this recent Olympics.
I think, Dr. Anish, that's
okay. And I would rest my case. So that would be my rebuttal to Dr. Gargari's
Dr. Gargari
points.
will have the final word, another 2 minutes to Dr. Gargari to say how he believes empiric treatment is still better than complex testing, and that he's not convinced with Dr. Kaur's submissions.
Thank you. And actually, I am grateful to Dr. Kaur because actually he has made my job easier. Because in his words, actually, the controversies lie. Like Dr. Kaur has said, the psychological well-being of the patient is even greater than diagnosing. We are the endocrinologist, we run behind the why. But first of all, you are a doctor and you need to treat. Suppose a patient comes to you and after doing a confirmatory test, after doing an AVS, you find the AVS comes with a lateralization ratio between 3 to 4. Will you be going to discuss a further AVS or a further metabolic testing and what next to that patient? Would that not be a traumatic to the patient? Obviously it is, because you are the doctor, you have to treat. The patient will ask, Dr. Saab, I need some treatment. Right, there lies one point. The second point is, what if by mistake you remove the wrong adrenal? Still the hypertension is remaining. And you are liable, you are answerable to the patient. So there comes the thing that where you can show something to the patient that, look, I have given you this treatment, so you are going to improve. Right? And Dr. Kaur's mostly was concerned regarding spironolactone, right? But we are not only dependent on spironolactone here. We are dependent on the ocedurodone, we are dependent on phenreninone, we are dependent on eplerenone, and not to mention amiloride and all those agents. So that's another thing. So actually that explains in entire things. If you just go to discuss a patient that, look, these are the medical therapy, these are side effects. Like you may have gynecomastia, you may have erectile dysfunction for which there are treatments. Vis-a-vis, this patient, you may land up with stroke, and you may land up with hypertensive emergencies, you may land up with a paralysis for the rest of your life for doing a complex test. Just look at the patient and see what the patient chooses. And thereby, by address my cases, I think the answer is pretty clear.
I'd request both the debaters to please sit while we put the motion to vote, as is customary, with a show of hands. The motion was complex testing is better than empiric medical treatment for primary aldosteronism. Those in favor of complex testing for a definitive diagnosis may please raise their hands. I think there are maybe less than 10 or 12 hands. Those who do not want to do complex testing, rather treat the patient straight away and relieve them of hypertension despite having a tumor, may please raise their hands. So I think the motion falls, and empiric testing is perhaps the way forward. Obviously, ours is a resource-constrained setting, resources are not available, and treatment comes first. Thank you, both the debaters, for taking us through this wonderful debate. And we now move on to the second debate for today. And for the second debate, I'd request both our debaters on stage. We have Dr. Sattik Siddhanto and Dr. Semonti Chakraborty. They will be debating on treatment of Graves' disease, which is another contentious issue because we have a number of options available for treatment, long-term thionamide therapy versus definitive therapy. Dr. Sattik Siddhanto, who happens to be a close colleague and senior, currently is in the Department of Medicine at IPGMER Kolkata as Associate Professor, and he will be debating in favor of long-term thionamide therapy, medical management for Graves' disease. Dr. Sattik.
Thank you, Pankaj, for the nice introduction. At the very outset, I must thank the entire organizing team of Crescendo for bestowing on me the opportunity to speak in front of such an august gathering. Well, I've been asked to debate for the motion in favor of long-term thionamide therapy is preferred over definitive therapy in Graves' disease. Just a bit of introduction. Graves' disease is the commonest cause of hypothyroidism. Many are affected in the prime of their life and productivity. Hence, it can be disabling and result in significant healthcare cost and economic loss. However, the goals of therapy remain rapid restoration of euthyroidism by intervention and maintenance of stable euthyroidism even after stoppage of medication, a complete cure, that is lifelong full recovery without any further medication, intervention which is easy for the patient as well as the healthcare provider, low complication rate from the disease or therapy, and an acceptable not only to the patient but also to the society. So we all know the treatment options for Graves' disease ranges from non-invasive medications to the invasive, though definitive, that is surgery, as well as radiotherapy. The treatment, if you see the treatment choice parameters, be it thyroid in thyroidology, be it in your diabetology, efficacy, safety, availability, patient preferences, and quality of life, and of course, the financial constraints. So how many of the patients or your patients will prefer surgery or radioiodine? Well, I doubt, probably nil, if you have thionamide. So don't worry, my delegates, we have oral thionamides, and that is the first line, and that has been endorsed by the current guidelines, be the ATA guidelines or the European guidelines, which clearly recommended thionamides as the first line of therapy for patients with Graves' disease. Coming to one of my important goals, that is cure. By cure, we mean lifelong full recovery without any medication. However, the majority of patients treated with radioiodine either become hypothyroid sooner or later, and the current trend in thyroid surgery also favored making the patient hypothyroid by a subtotal or a near total thyroidectomy. So accordingly, technically, only those patients who can hope of a permanent cure are those who stop antithyroid therapy and have entered the phase of remission. And even in the best of the series, a maximum of 50% of patients will achieve high euthyroidism without any further therapy in the rest of their lives. So continuous use of long-term therapy to the tune of 12 to 18 months, studies have shown a remission rate of 50%, and higher remission rate is achievable with milder disease and lower thyroid hormone levels. And studies have clearly shown that a prolonged duration of more than 24 months have achieved a higher considerable degree of remission. So the benefits of thionamide therapy are non-invasive oral medication, flexible dosing, easy to titrate, and last but not the least, it also avoids permanent hypothyroidism. As far as patient preference is concerned, surveys have clearly shown that patients clearly favor a non-invasive nature and making decision process easier for the patient. And antithyroid drugs remain the drug of choice, not only in India, Europe, Latin America, and recently it has been shown that previously US, there was radioiodine therapy swept, but nowadays there also it's prevalent. So globally, antithyroid drug remains the therapy of choice in Graves' disease because thionamides often report better quality of life compared to those undergoing definitive therapy, and patients undergoing radioiodine surgery may experience hypothyroidism, requiring lifelong replacement and periodic monitoring. Here is a study which showed the mean thyroid-related patient-reported questionnaire scales in Graves' disease. And if you see from the graphs, the lower the score, the better the quality of life. And those on thionamides had a lower score and hence a better quality of life compared to the counterpart, that is the definitive therapy. So patients treated with radioiodine surgery have a lower quality of life compared to ATD. Here is another study which showed the quality of life is worse at 6 to 10 years after radioiodine therapy of Graves' disease compared with treatment with antithyroid drugs or surgery. It included around 1,200 Graves' disease patients, and the quality of life was assessed by a ThyPro questionnaire and the non-specific SF36 questionnaire, and their study clearly showed that patients treated with radioiodine had a worse thyroid-related and general quality of life compared to patients treated on antithyroid drugs. Also, the financial implications, the long-term thionamide therapy was lesser costly compared to the cumulative costs of surgery and the upfront cost of radioiodine ablation, not to forget the lifelong L-thyroxine therapy, which the patients require. So one must not and never choose radioiodine therapy because it will cause aggravation of orbitopathy and also promote a new onset orbitopathy. It will result in permanent hypothyroidism, not to forget the radiation restrictions of the treatment. It is contraindicated in pregnancy, lactation, and people contemplating pregnancy in future, and also in contraindicated in pediatric age group to the tune of less than 5 years. So radioiodine therapy, we all know, worsens Graves' orbitopathy, and multiple studies, according to a 10-year Australian study, 4.3% of patients on radioiodine therapy developed worsening of the Graves' orbitopathy or a new onset orbitopathy. Not only that, the acute complications, be it eye redness, increased milphosis as well as madarosis, also increased, rendering a significant negative impact on the quality of life and activity of daily activity of the patients. Recent studies have also shown that radioiodine therapy have increased the incidence and prevalence of solid tumors. And not only that, in patients with post-radioiodine relapse, long-term thionamide therapy was found to be superior to radioiodine therapy. See, here is a study which included 64 patients with recurrence of hyperthyroidism of radioiodine therapy. They were either randomly assigned to receive radioiodine therapy or low-dose long-term methimazole, and both the groups were followed up every 1 to 3 months, and studies have clearly shown that 97% of patients in the methimazole arm remained euthyroid in contrast to the radioiodine arm, where only 25% were euthyroid. Not only that, the mean time to achieve euthyroidism was 9.4 plus minus 5 months in the radioiodine arm and 3.5 plus minus 2.8 months in the levothyroxine arm. They were telling this entire story. So even if we require radiotherapy, even if we can convince the patient, let's see the Bengal story. The overseas and the outstation delegates can entirely enlighten us about the other state. We have 26 government medical colleges, including 5 in Kolkata, and 3 has DM curriculum. Unfortunately, I don't know any college where radioiodine ablation is being done. Forget the periphery where the private sector is also booming. Only in a few fibrous sectors of Kolkata that radioiodine ablation is probably done. So implementation of radioiodine therapy is probably in our state is more of an idealistic goal than a realistic proposition. No, and same applies to surgery where we lack high volume thyroid surgeons, not to forget the immediate complications lacking from neck scar, hypoparathyroidism, recurrent laryngeal nerve therapy, and high costs. So one must always avoid surgical risk and preserve thyroid function, not to mention that surgery also will result in permanent iatrogenic hypothyroidism. So imagine your patient came to you with hyperthyroidism and you're leaving the patient with hypothyroidism. Your patient came to you for correction of Graves' disease and you are giving you a new onset disease in the form of thyroid orbitopathy. The only point where my opponent, my dear junior, Graves will opine that Graves' disease is notorious for its high relapse rate. However, this relapse rate can be countered by long-term thionamide therapy. Here is this meta-analysis which clearly showed that the long-term antithyroid therapy, the annual remission rate for each year of treatment was 16%, long-term antithyroid therapy induced a remission rate of 57%, and rate of complication was 12.1%. Here is a study by Azizi and his team which included 258 patients treated with antithyroid therapy for more than 18 months. They lateralized, they either divided into 130 patients which received methimazole for more than 60 months or 128 patients who discontinued therapy. So long-term methimazole therapy will surprise to know that only 18, that is 15% only had relapsed. And among the short-term therapy, 53% therapy, thereby reiterating the fact that long-term therapy can definitely help in reducing the relapse. So if you see the course of TRAB levels and remission rate of the term, early and long-lasting, that is in green, 41% patients having a remission rate of 89%. Smoldering variety having a 21% smoldering course of TRAB levels, and there also remission may occur with prolonged long-term low-dose methimazole therapy. The only problem is that those having a fluctuating TRABs where there will be waxing and waning, and this is the black line. So remission is definitely possible in the smoldering variety and the smooth fluctuating variety and smooth term variety. So long-term therapy definitely sweeps not only in the time to achieve biochemical improvement, but all the echocardiographic parameters, the abnormal TSH, worsening of Graves' orbitopathy, and also the anthropometric and metabolic parameters. Here is another review article which clearly shows persistent normalization of TRAB after 5 years of thionamide therapy. Antithyroid therapy for more than 60 months in low dose can offer a remission to the tune of 85%. So long-term antithyroid therapy for more than 60% is very safe. So if you summarize the pros, cons, and contraindications of the various modalities of treatment, the pros of antithyroid therapy are definitely sweeps over radioiodine therapy and thyroidectomy. The cons of radioiodine and thyroidectomy are too much to be discussed due to paucity of time. So also is the contraindications of radioiodine as well as thyroidectomy, which sweeps compared to the contraindications of antithyroid drugs. So long-term antithyroid drug is the treatment of choice for Graves' disease because an earlier and sustained achievement of euthyroidism and not hypothyroidism. There are less variations in TSH concentrations, the low occurrence of both subclinical and clinical hypothyroidism, the less chance of developing orbitopathy, a better atherogenic profile, a quality of life, and of course freely availability, and of course low medical costs. To summarize, antithyroid therapy are the treatment of choice in Graves' disease and will remain the treatment of choice in Graves' disease because to avoid relapse of hyperthyroidism, long-term therapy with low-dose antithyroid drugs is advised because it will achieve cure. Unlike the definitive management which does not achieve cure, it causes iatrogenic hypothyroidism, and it has a swarm of complications and poor quality of life, and it also contraindicated in many situations. Thank you all for your patient hearing.
Thank you, Dr. Sattik Siddhanto, for that sweeping presentation of yours. I request the opponent, Dr. Shemonti Chakraborty, to deliberate on how she thinks definitive therapy and not long-term medical management or long-term thionamide therapy is the standard of cure or should be the treatment of choice for Graves' disease.
After an excellent deliberation by my worthy opponent, I am the devil's advocate here. I would say why I think definitive therapy should be the choice in Graves' disease patient, and I will put forward. I think thionamides are only for a small group of Graves' disease patient, those having milder disease, small goiter, low TR antibody levels. They are eligible, elderly with multiple comorbidities, and patients having moderate to severe. In rest of our patients, our target should be definitive therapy. ATA guidelines say that we should target 150 millicurie per gram or 10 to 15 millicurie. We have many concerns regarding the radioiodine exposure, how I'm going to address each and every point separately, because my worthy opponent has made RAI a criminal. I will say that it's not a criminal, but it can also be considered in a fixed group of patients. Regarding RAI, there can be a cost issue, but if we go for fixed dosage, then we can cut down the cost issue, because this study has shown that if we consider a fixed dose versus a calculated dose, there is not much difference in the remission rate. And the use of a fixed dose method simplifies the approach with potential cost savings. We know the indications for surgery in a hyperthyroid patient, but the complications which my worthy opponent has highlighted occurs in a very few number of patients, 3 to 1, in vocal cord paralysis in 3%, hypocalcemia in 3, recurrent permanent hypopara in 1%, and recurrent hyperthyroidism in only 2%. And ideally, the surgery should be done by a high-volume thyroid surgeon doing more than 50 surgeries per year. And in the pipeline, we have better therapies. I saw one paper with antigen-specific therapy. Now, when we compare the 3 modalities of therapy, if we see the success rate, thionamides have a 45 to 50, maybe the rates improve with prolonged duration of therapy, but when we see with the definitive therapy as expected, they are much, much higher. And when we compare the adverse effects, thionamides have an adverse effect in the range of 12 to 17%, whereas radioiodine 1 to 6, and surgery varying from 6 to 24%. This initial studies published long back in 1996, it showed that the risk of relapse was highest in the medically treated young adults, 42%, and followed by those treated with iodine 131. But surgically treated ones had a better response. And when a group of Graves patients followed up over 8 years who had been given ATD surgery or radioiodine, it was found that a patient selecting ATD therapy as an initial approach had only 50% chance of ultimately avoiding ablative treatment and 40% chance of eventually being euthyroid. My worthy opponent has repeatedly stressed on the point euthyroid, but hypothyroidism treatment is not that much difficult, I suppose. So, and this study, he has also quoted that even after 6 to 10 years, the patients on RAI and ATDs did not have a very good quality of life, but the patients on surgery had. And when we consider this study published in 2020, where 4,800 patients were enrolled, of which 60% were on ATD, 33% RAI, and 6% surgery, factors associated with treatment success was only in the higher age group population, and where ATD was more successful, and female sex for RAI. But surgery was successful as expected in all the groups. Though ATD was the most common GD therapy, but it has the lowest efficacy and infrequent significant adverse effects. And this is the latest one where it has shown, though it doesn't support my topic, my point, but still I had put it, because it has shown a paradigm shift in the management of Graves' disease among the endocrinologists of different countries. It has shown that though RAI was the first line initially, but gradually it has decreased. And now ATD supports most of the subset of patients of Graves' disease when we choose. But we cannot ignore when we consider surgery and RAI. In patients, pregnancy planning, the guidelines say if the patient is planning a pregnancy more than 1 year later, you can consider either RAI or surgery, and less than 1 year, then surgery. The dangerous transient increase in TR antibody levels after RAI, but it gradually decreases. And regarding thyroid eye disease, I will quote studies where RAI has shown benefit under steroid cover. Pregnancy and lactation, we consider ATDs followed by surgery. And prior adverse reaction to thionamides, we have to consider surgery. Our main concern, who is the devil here? Radioiodine. Why it's becoming less popular? Association with worsening thyroid eye disease, patients' fear regarding radiation exposure, and increased risk of carcinogenicity. But if we counsel our patients properly how to minimize exposure, for how long they have to remain away from their family members or other adults or using public transport, and we solve their queries, radioiodine is not too a difficult topic, and this shows, depending on the amount of millicurie exposure, how many days of separation is required. Now, this slide where thyroid eye disease, radioiodine is recommended in mild and active disease under steroid cover because study has shown that it doesn't worsen. If the patient is smoker, if the patient is having moderate to severe TED, we don't advocate RAI. And this study where hypothyroid patients with Graves' ophthalmopathy were given RAI and followed by a 3-month course of prednisolone or methimazole for 18 months. No patient who received a course of oral prednisolone following RAI developed new or progressive thyroid eye disease, while 15% who did not receive steroid had a progressive thyroid eye disease. And similar studies with oral steroids as well as solumedrol injections have been studied where patients did not have worsening of ophthalmopathy even after giving radioiodine. And the courses offered for oral prednisolone were 35 milligrams started a week prior and tapered over 10 weeks, or intravenous methylprednisolone 500 milligram per week for 2 weeks and 250 milligram per week for 2 weeks. No patient on prophylaxis developed ophthalmopathy after RAI, and they remain well over follow-up. Serum antibodies also increased after RAI, but less in patients receiving the steroids. And regarding cancer incidence, studies have shown that there can be increased cancer risk RAI. Because site-specific cancer, they have seen that there has been an increase in thyroid cancer, but Graves' disease as it is, it's a predisposing factor. And in dose-response analysis, RAI was significantly associated with breast cancer mortality and other solid cancer mortality. The overall pooled cancer risk after exposure to RAI therapy versus non-exposure was not significant, and a linear dose-response association was observed. That this tells us that the radiation-induced cancer risks for hyperthyroidism are small, only in observational studies, and found at higher levels of administered doses, which we don't advocate in our Graves patients regularly. And if there is we know the guidelines say that pregnancy should be delayed at least 6 months, but studies have shown that if the patient has accidentally conceived, we do not ask them to abort because congenital anomalies do not appear to be more common in women treated with radioiodine, as the gonadal dose is approximately only 3 rad, similar to that for HSG or barium enema, and the risk of genetic damage is only 0.005%. And radioiodine fails if the patient is smoker, high baseline serum concentrations of T3 and high TR antibody levels. And the issues with surgery, hypothyroid, hypoparathyroid, which is more in total thyroidectomy, initially supposed, but it was found that total thyroidectomy gives a better response, and near total is not superior to total with reference to the transient postoperative hypopara. And whether we need to prepare our patients with potassium iodide, which we sometimes do for large goiter, whether that improves the surgical risk of the patient, whether it minimizes bleeding, not much benefit has been found. And regarding post-operative hypocalcemia, it can be avoided that patient, when supplemented with 1 gram calcium carbonate 3 times daily for 2 weeks preoperatively, it reduces the risk, and also less common when vitamin D. So I complete saying that it's better to debate a question without settling it than to settle a question without debating it. Thank you for your patient hearing.
Thank you, Dr. Chakravarti, for that discussion. Dr. Satwik Siddhanto will be given another 2 minutes to rebuttal his points in favor of long-term thionamide therapy for treatment of Graves' disease.
Thank you, Shemunti, for the illuminating talk. A few points. Yes, side effects of thionamides are there in 12 to 15% of cases, as is reiterated. But as I have mentioned in the slide, in the cons of antithyroid therapy, probably that's the only area where we'll prefer definitive therapy. If the patient is intolerant or develop persistence despite thionamide therapy. Shemunti has reiterated the fact of the fixed or calculated dose. My reasoning is again to the same, be it fixed dose, be it calculated dose, patients are bound to develop hypothyroidism sooner or later, and that is not a cure of your hyperthyroid patient. Now coming to high volume thyroid surgery, as Shemunti has reiterated, that 50 surgeries per year, I doubt how many surgeons will get that is to do 4 surgeries per month at least. Yes, Shemunti has rightly pointed out that hypothyroidism treating is not difficult. We can all treat hypothyroidism. But my point is, why will I render the patient hypothyroid if I have thionamides in my kitty, and that to low dose, long duration, achieve my remission to the tune of 85% of patients. Radioactive therapy under steroid coverage again decreases the incidence of thyroid eye disease. I fully agree. Again, I am giving a steroid which itself has its adverse effects, where I have thionamides which does not have any effect on thyroid eye disease. Cancers, again, it's again a very pertinent point which Shemunti has itself pointed out. Last but not least, I reiterate the fact about availability in our country, particularly in our state, which I have known where I've done my undergraduate, postgraduate, and postdoctoral. It's more of an idealistic goal, not just the poor patients, but also the patients who have affordability. Suppose staying in Purulia where Pankaj is staying. I think it's very tough for him to refer the patients because the centers are very lacking. Thank you.
Thank you, Satwik. I do agree with you. We do not have radioiodine in Purulia. Dr. Shemunti for her last turn and her last words in favor of definitive management for Graves' disease.
Thank you, Dr. Siddhanto and Pankaj. But still, I would reiterate that in this era of precision medicine, I know I am practicing in a high resource setting, but still definitive therapy, because my patients, when they sit in my clinic, they first ask the question, how long, what are the side effects, is this going to permanently cure me? They will come with 100 Google researches, but if I have to counteract them, I will say them that I will give you thionamides to control your symptoms, but if I'm not achieving a remission within a year or 18 months, my point would be to send you for definitive therapy, that is radioiodine or surgery. Surgery acceptance is truly low in our patients, but for radioiodine, if we convince them and refer them to proper centers, the cost is an issue, but the patient can have radioiodine therapy followed by cure. And in Graves' patient, I make it a point, after treating for 4 or 5 months, I always get an ultrasound done. If there is a suspicious nodule, if there is a cold nodule on scan, then in those cases, we can't avoid surgery. As endocrinologists, we have to think of all the finer complications that can happen in a Graves patient. One of my school friends who had Graves, but I referred for surgery instead of RAI, finally had a papillary micro-PTC, and she thanks me even today for providing her with definitive therapy. So I consider all my patients educated, and I would always offer them definitive therapy as the choice of therapy in comparison to antithyroid drugs. Thank you.
Thank you, Shemunti. And I think Dr. Nilanjan sir has a point before we close the debate.
So, yeah, both of my students have debated very well. You have your points. I won't add to any of the confusion, but just 2 comments. to Shattik mainly, the institute where you are currently posted once had the facility of radioiodine therapy in the Department of Nuclear and Experimental Medicine, and we have used it when we were students, and even after that. It is a pity that it's not being currently done, but we can always hope that it can be done again. And also, this, of course, someone may correct me, from the institute where you had your undergraduate education, that institute also was having radioiodine diagnostic test, definitely, and if my memory serves me correct, had facilities for radioiodine therapy too. So you are young, you don't know the history, but it was there, but yes, we should again restart it. That's one thing. And when it comes to pregnancy, despite what you have said, what Shemanti has said, and what the recommendations have said, I am most comfortable with radioiodine therapy if the patient plans pregnancy in near future. Because during pregnancy, predictive hypothyroidism is much easier to manage than thyrotoxicosis, optimizing the dose of thionamide, which thionamide to use, change over to PTU, change over to carbimazole, like that. Thank you.
Thank you, Nilanjan sir, for those insightful words. So as is customary, we'll put this motion to vote again. Long-term thionamide therapy, that is medical management for Graves' disease, versus definitive therapy, that is radioiodine or surgery. Those in favor of long-term medical management or thionamide therapy, please raise your hands. I think there are quite a number of those. And those in favor of radioiodine surgery or definitive management, that's to my surprise. I think definitive management, I think it got influenced by Nilanjan sir's closing remarks. Thank you everyone, and we close this debate over here. Big round of applause for both our speakers. From precision medicine, we now move on to rational prescribing. And we have 2 sessions on rational prescribing guide with 2 senior doctors, 2 senior consultants to guide us through. For first talk, I'd like to invite on stage Dr. Sujoy Mujumdar, who will be taking us through treating type 2 diabetes with ischemic stroke. Sujoy sir happens to be a senior consultant at Apollo Hospital and GD Hospital, and he has all these credentials: MRCP examiner, vice chancellor, IRCPI, number of publications, and I know him as a very good speaker and organizer. Sujoy sir.
Thank you, Pankaj, for such kind words, and really I would like to start by offering my thanks to the organizers for giving me a chance to speak on this particular very important issue at the moment. So basically, this topic I found it very interesting, Guide to Rational Prescribing. Now, what is rational? That's the first question. Well, by rational, I mean something which would be undoubtedly something which would be non-controversial. That is how I look at rational, and something which is based on evidence. So these are the 2 factors which should influence our treatment or our guidance to any sort of a rational prescribing as we talk about. Now, the topic that I have been allotted today is rational prescribing in type 2 diabetes with ischemic stroke. So let us start with some of the basics. So what we know. We know that type 2 diabetes and atherosclerosis, they're basically 2 complementary diseases. So atherosclerosis is something which goes hand in hand with the evolution of diabetes. And we also know from the available data, there are multiple data, I'm going to go through them very briefly because if I start talking about the data, it's going to take a whole half an hour because of that. Now, a few facts which we should remember: that ischemic stroke is thrice as common in type 2 diabetes without controls. And what is very important is that the degree of the lipid profile or the degree of the lipid status does not influence the outcome of the stroke. Now, this is a very important message, because there have been studies which have shown that mortality with stroke in type 2 diabetes is nearly 4 times higher than in a non-diabetic patients who have got the same level of lipids. So obviously, lipid does not play a very major role in the evolution of the stroke or the outcome of the stroke, but the glucose control and the presence of diabetes does make a big difference. And for example, when we're looking at the younger stroke patients less than 55 years of age, the risk of stroke is 10 times higher in a diabetic patient than a non-diabetic patient. And as the age group goes even further lower down, there is something like a sex-related difference. This was based on a very famous study known as the healthcare professional study of USA, which basically showed that black females have got an increased rate of stroke, but the rate of stroke in white males is nearly 3 times that, or nearly 7 times that amount. So you can see here a male sex, a Caucasian background, younger age group, presence of an uncontrolled diabetes, these are all risk factors. But the important point is that a tight control of hypertension, dyslipidemia, sedentary lifestyle, it does not decrease the effect of diabetes in causing the stroke. So you can get all these other factors well controlled, but the chance of the stroke remains high if the glycemic control is poor. Now this is a very busy slide. I'm not going to take you through all this. The simple take-home message, this is a sort of an epidemiological study of the different studies which have been done on ischemic stroke in type 2 diabetes. But the important take-home message here is that the type 2 diabetes, it increases the risk of stroke between 2 to 10 times. And there is an increased risk of large artery stroke and small vessel stroke. Now what these are I'm going to discuss later on, but not the cardioembolic stroke. In other words, the risk of embolic stroke from somebody who's having an atrial fibrillation is not increased in patients with diabetes when compared to a non-diabetic patient. And also another important issue here is that people who have got diabetic foot or neuroischemic diabetic foot, they're at an increased risk of developing ischemic stroke. So a neuroischemic foot confers an increased risk of developing a stroke in a diabetes patient. Now this was a sort of a forest plot which explains what are the risk factors. If you have a look at it very, very carefully, what you'll find out that all ischemic stroke, large vessel strokes and the small vessel strokes, there is one significant point which is there, it is the presence of diabetes. The absolute value of the glucose, the level of the insulin and the BMI, they do not play a consistent role across all these sub-head groups. The next question which we need to address is which part of the brain is involved in the stroke. Now, as I mentioned earlier, type 2 diabetes is associated more with a higher prevalence of subcortical infarction. And there is also a higher relative frequency of small vessel and large artery atherosclerotic stroke, and also cerebral small vessel disease. Now, there is something, the cerebral small vessel disease can present as lacunar infarcts, they can present as small subcortical infarcts, formerly categorized as acute lacunar stroke, and they can also present radiologically as what is known as a white matter hyperintensity, where there could be just a microvascular level of stroke, but without any frank, I should say major neural damage. And they can also present as microbleeds and enlarged perivascular space. So these are something which are the features of a cerebral small vessel disease. And remember that in a diabetic patient, probably this cerebral small vessel disease is much more present in an insidious fashion. If the patient presents with a large vessel disease, he presents patients with a frank neurological disability. But a patient could have a cerebral small vessel disease which is going on for months and years without the patient developing the neurological disability. These are the areas, as you can see, are the areas which are affected primarily by the stroke. So this particular thing will explain what is basically the areas or what are the types of vessels involved in an ischemic stroke in diabetes. And the mechanism we all know. So there are basically 3 major factors. That is the hyperglycemia, the presence of the free fatty acids, and the insulin resistance. It adds to the oxidative stress, and there are increased markers of certain inflammatory markers. This leads to 3 factors. One is a vasoconstriction, one is the inflammation, which worsens the vasoconstriction, leading to the formation of the thrombus. So this is, in a small way, how the ischemic stroke evolves. One important issue which we need to discuss here is a new onset hyperglycemia. Now, how does it differ from the pre-existing diabetes? What studies have shown that up to 40% of acute ischemic stroke is admitted they have hyperglycemia without a previous history of diabetes. And new onset hyperglycemia, as we all know, it carries a much higher or a worse prognostic risk. It is associated with an increase in mortality by nearly 3.3% compared to in non-diabetic patients, and is associated with worse neurological disabilities. Now, what happens, what leads to this new onset hyperglycemia? It's still very much debatable. One of the possible hypotheses is the probable cerebral ischemia because of the activation of the hypothalamo-pituitary adrenal axis, an increased stress-induced release of cortisol, and this cortisol overexpression leads to the gluconeogenesis, glycogenolysis, and lipolysis. And also, there's overexpression of the inflammatory markers like the TNF-alpha, IL-1, and IL-6, and this leads to further worsening of the endothelial inflammation of the cerebral vessels. So new onset hyperglycemia leads to basically it can happen because of cortisol overexpression because of cerebral ischemia. So at the same time there is hyperglycemia as well as this inflammatory process which is going on. Now this brings us to the next important million-dollar question, which would be the guide to the rational prescribing. So what are the effects of the glucose-lowering drugs in ischemic stroke? Now this is again a busy slide, but if you can have a look at it very carefully, we have got evidence that a particular agent causing a benefit in an ischemic stroke you'll find with only certain agents. What are these? The UKPDs show the beneficial effect of metformin, and similar observational studies have shown, some of these other studies have shown that metformin is beneficial. Sulfonylurea does not show any significant benefit. In fact, studies have shown here that sulfonylurea can actually be harmful in patients with ischemic stroke. The TZDs, we are all familiar with the proactive stroke study. This is one study which showed that pioglitazone has got a significant role in patients with ischemic stroke. The other important issue, for example, what we can see here is the effect of the SGLT2 inhibitors. SGLT2 inhibitors, in fact, did not have any specific benefit on the stroke. In fact, with the EMPERID study, it showed that after 30 days of the cessation, there was an increase in the risk of strokes. And there have been one meta-analysis done by Wu et al., which specifically showed that with EMPA and CANA, this was a meta-analysis based on a cohort of nearly 16,000 patients, and it showed that there is a 30% increased risk of stroke with these two classes of molecules, that is EMPA and canagliflozin. Now, effect of GLP-1 receptor analogs, again, is something we all know, that the semaglutide actually showed a significant outcome benefit in patients with stroke. And this has also been validated with exenatide and exenatide and insulin with observational studies. Effect of insulin is something which, again, this meta-analysis has basically shown that use of insulin in patients with stroke compared to non-insulin therapies can have a slighter degree of more worsening of the outcome of the stroke. Now, this is a debatable issue, so I'm happy to take questions on this in the discussion portion. This was a further subgroup analysis of SGLT2 versus other agents, and all these studies have specifically shown that SGLT2 inhibitors, so far as comes to the ischemic stroke, it does not confer any additional benefit. But whereas with GLP-1 receptor analog, with ischemic stroke, as well as with other presence of other conditions like the CKD and CLD, so obviously if you look at the total cohort of the stroke between 16 to 339 weeks, what you can see here is that GLP-1 receptor analogs have got a specific protection benefit in ischemic stroke. So if you look at, to summarize, if you look at all the experimental evidence benefit, what we have seen here, in the experimental data also, metformin showed benefit. In the real life data as well as in RCT like UKPDS, it showed benefit. Thiazolidine has shown benefit in RCT like the proactive study and also in the experimental data. DPP-4 inhibitors, again, they have shown benefit, but again, only in experimental data and in real life data. GLP-1 receptor analogs, experimental, real life, as well as RCT, they've all shown benefit. Insulin, again, did not show much of a benefit in real life data and RCT. So to summarize, and just to make it a little short, basically my evidence-based rational prescription is that if the HbA1c is more than 9% and the patient has got a deep pulse, I'll go for a metformin, a GLP-1 receptor analog, semaglutide, and a pioglitazone. Now, making this statement in India is a bit risky because the data with semaglutide that we are talking about has come from the injectable semaglutide, something which is not available in India. So for an Indian patient, perhaps would still be better off giving something like a metformin and pioglitazone, on which we have got hard evidence. And if the HbA1c is more than 7.5 to 9%, again, if the patient is rich, pioglitazone plus GLP-1 receptor analogs, the two agents which have shown the best possible data. If the patient is not rich, maybe metformin and pioglitazone. If the patient is not rich and has got a heart failure, I'll probably go for metformin and DPP-4 inhibitors, because DPP-4 inhibitors have been shown to have, in some studies and some meta-analysis, an inkling of a benefit, not a very steady benefit. In fact, majority of the RCTs, they did not show any significant benefit with the DPP-4 inhibitors. And if the HbA1c is less than 7.5%, probably I'll go for a GLP-1 receptor analog, and either of metformin or pioglitazone if the patient is rich. If the patient is not rich, again, maybe a DPP-4, metformin, and pioglitazone. So with that, I end my presentation. I'm sorry I've finished a little bit too early because I tried to put in the full data and leave some time for the question answer session. Thank you very much.
Thank you, sir, for that interesting and crisp talk on ischemic stroke with type 2 diabetes. If there are any questions for this session, I'd request the delegates to ask, if any. Thank you, sir. With that, we come to the end of this talk. A big round of applause for Dr. Sujoy. Coming on to the last talk before the inauguration this evening, which will be delivered by none than Professor Nilanjan Sengupta, sir, who is the professor and head of the Department of Endocrinology at NRS Medical College. A lot of accolades to his credit, and he's also the outgoing secretary of the Endocrine Society of Bengal. Sir will be talking about type 2 diabetes with PEF, or heart failure with preserved ejection fraction. Sir.
Good evening, friends. This is I think, the last talk before the inauguration. And the topic that has been given to me by Dr. Rana Bhattacharjee and Dr. Parthapratim Chakraborty is a topic of the cardiologists: heart failure with preserved ejection fraction, of course with a tinge of diabetes. Now, how do you define heart failure? When we were students, definition of heart failure was a qualitative, clinical, and much easy to understand one. That is, it's a complex clinical syndrome with signs and symptoms that result from any structural or functional impairment of ventricular filling or ejection of blood. But since then, much water has flown down all the rivers of the world, and now we are having a quantitative definition of heart failure, which is not merely a clinical definition, but that includes measurement of the natriuretic peptides and also an echocardiography. And to complicate matters further, heart failure has been subclassified into heart failure with reduced ejection fraction, with mid-range ejection fraction, and preserved ejection fraction. Whether this classification is a man-made, arbitrary classification needs to be discussed, debated, but suffice it, or even industry-driven classification, but suffice it to say, heart failure is a continuum, and if anything, this classification has been made for therapeutic convenience. So then what is this heart failure with preserved ejection fraction? Here the ejection fraction should be more than equal to 50%, with signs and symptoms suggestive of heart failure, with elevated levels of BNP and NT-proBNP, and also objective evidences of pulmonary or systemic congestion. But that is not all. When you diagnose heart failure with preserved ejection fraction, the important mimics of heart failure with preserved ejection fraction needs to be excluded, notably pericardial disease, intrinsic myocardial disease, high output heart failure like in severe anemia or an uncontrolled thyrotoxicosis, which are the areas where the role of an endocrinologist comes more, or a physician comes more than of a cardiologist. Now, why we are discussing this in an endocrinologist forum? This is because the factors which contribute to heart failure, or for that matter, heart failure with preserved ejection fraction, are more or less similar, which are operating in cardiometabolic diseases like physical inactivity, obesity, central adiposity, a bad unhealthy diet, hyperglycemia and diabetes, chronic kidney disease, essential hypertension, dyslipidemia, so on and so forth. And therefore, it's quite natural that heart failure with preserved ejection fraction is more prevalent in patients with diabetes than without. And generally speaking, about 2.5 to 21% hospitalized patients suffer from this condition, and this can be present in around 4 to 9% patients in the general population. The pathogenesis of heart failure, again, it has considerable overlap with diabetes, that is hypertension, hyperinsulinemia, obesity, dyslipidemia, endothelial dysfunction, diabetic kidney disease, oxidative stress, formation of adverse glycation end products, so on and so forth. Now, presupposing that this heart failure is actually a consequence of atherosclerotic cardiovascular disease, not secondary to an intrinsic myocardial or pericardial abnormality. And at the cellular level, as I've said, the age-range combination, generation of reactive oxygen species, mitochondrial dysfunction and mitochondrial injury, role of pro-inflammatory cytokines, role of lipolysis, triglycerides, defective function of the cardiomyocytes and endothelial dysfunction, abnormalities in macrophage function, all come into play in the causation of this heart failure. Now, this is a scoring for heart failure. I do not diagnose heart failure, nor do I try to classify or treat. It is the duty of my cardiologist colleagues to do, but true in some situations, as in general practice, physicians have to take care both of diabetes, thyroid, and heart diseases. I am not sure whether our cardiologist colleagues use any such scoring system daily in their clinical practice, or these are used in experimental studies only. So there are other scores. But this is the general approach. If patient comes to you with dyspnea or edema, you should assess for certain non-cardiac causes of the symptoms, commonly an anemia. Then you apply the universal definition of heart failure, which I've shown, assess and exclude the heart failure mimics, use that score in an ideal setting, and then diagnose heart failure with preserved ejection fraction. To a cardiologist, this may take 30 seconds, but this is not that straightforward like diagnosing of PCOS with Rotterdam criteria, however controversial that may be, or confirming a diagnosis of primary hypothyroidism with a T4 or TSH. Now, after having diagnosed heart failure with preserved ejection fraction, how to manage? Fortunately, management is easier because we have data and evidences with only 2 classes of agents that show benefits in heart failure with preserved ejection fraction. That is diuretics for relieving congestion and SGLT2 inhibitors, that too dapagliflozin or empagliflozin for modifying the process of heart failure. But the third pillar is equally important, that is treatment of etiology and addressing cardiovascular and non-cardiovascular comorbidities, as I have been pointing out from the very beginning, a bad anemia, volume overload due to chronic kidney disease, or even an uncontrolled thyrotoxicosis. Now, what should be the management pillars from a cardiologist's perspective when a cardiologist is faced with heart failure with preserved ejection fraction in a patient of type 2 diabetes? Now, among the anti-diabetic agents, you should consider SGLT2 inhibitor as a first-line therapy for type 2 diabetes. GLP-1 receptor agonists directly probably do not have any effect on the pathophysiology of heart failure per se, But since GLP-1 receptor agonists have beneficial effects on atherosclerotic cardiovascular disease, which in turn is the causative factor for heart failure in most of the cases, so may have an indirect benefit. Finerenone used in diabetic kidney disease to mitigate albuminuria can have additional cardiovascular benefits. Until and unless the patient is very much decompensated, metformin is a safe and affordable additional agent. That's how the cardiologists look at. Start with SGLT2 inhibitor, add metformin as an additional affordable safe agent. I think we endocrinologists look at it in a slightly different way. Avoid definitely any form of thiazolidinediones, but because they can cause fluid overload. And if you have to use a DPP4 inhibitor, avoid saxagliptin, alogliptin, and probably also vildagliptin. So this is the treatment of heart failure with preserved ejection fraction, loop diuretics, and MRA. Now, when does MRA come? Eplerenone, not actually finerenone, but eplerenone. When this goes into the phase of heart failure with reduced ejection fraction, then also you have to use valsartan, sacubitril, and ARBs. So a closer look at the guidelines. Why SGLT2 inhibitors, dapagliflozin or empagliflozin, have been recommended as a class 1 recommendation in heart failure with preserved ejection fraction because of the EMPEROR and DELIVER trial data. So you have to use these agents, and as I said, in type 2 diabetes with DKD, if you are using finerenone, you can also have an additional benefit of mitigating heart failure with preserved ejection fraction. I have said that metformin is generally safe, but in the very much decompensated patient, hospitalized patients, or with an eGFR of less than 30, metformin should be avoided. Now coming mainly to the endocrinologist's viewpoints. If you have to use a DPP4 inhibitor, along with the patient is having heart failure or treatment for heart failure, it is best to avoid saxagliptin because of the SAVOR-TIMI experience. In the EXAMINE trial, alogliptin group had an increased heart failure hospitalization, though that was not statistically significant as compared to placebo, but giving the benefit of doubt to the patient rather than the molecule, you can avoid alogliptin. Sitagliptin and linagliptin are reasonably safe. We have paucity of data with the other gliptins, and with vildagliptin, the vivid experience is not very encouraging. There was a tendency to increase in the end diastolic volume in the vildagliptin arm. On the other hand, linagliptin is quite safe. As I've said, SGLT2 inhibitors are promising agents, and which is why probably we are discussing this, because we endocrinologists use a lot of SGLT2 inhibitors and they decrease heart failure hospitalization. And among all the trials, the SCORE trial with sotagliflozin included patients who were at risk for cardiovascular disease, while other trials recruited already patients who had established cardiovascular disease. But the point is that no matter how encouraging the data with sotagliflozin are, it is not approved or available for use in India. So, to summarize, if you have to choose, if you practice evidence-based medicine, and if you have to choose an SGLT2 inhibitor for prevention or management of heart failure in a patient of type 2 diabetes, it has to be empagliflozin or dapagliflozin. And since the data are with innovator molecules, it is safest to use the innovator molecules. A little bit about GLP-1 agonists, as I've said. Most of the GLP-1 agonists have neutral effects so far as heart failure is concerned, except probably this one, F-paglinatide, which is not available in India, which showed some benefits favoring GLP-1 receptor agonists in heart failure. But suffice it to say, GLP-1 receptor agonists as a group are cardio-safe and may have benefits on the atherosclerotic cardiovascular disease, so they can be used. As I've talked about finerenone, that are Fidelio Decadi and Figaro Decadi studies, I think you have gone through the studies over and over again. Finerenone has dominant anti-inflammatory and anti-fibrotic properties which operate not only at the level of the renal glomeruli, but theoretically also at the level of the cardiac myocytes. Therefore, it is quite expected that finerenone also may have some benefits on the pathophysiology of heart failure, though it has not yet been approved for use in heart failure par se. But when finerenone is used in patients with CKD and type 2 diabetes, there has been a tendency towards improving heart failure hospitalization. This is a very interesting finding, and who knows, in years to come, finerenone, through other studies, may enjoy an approval status in the management of heart failure. So the management of heart failure with preserved ejection fraction is not just a prescription of empagliflozin and dapagliflozin with a diuretic, but a holistic control targeting at chronic kidney disease, targeting at hyperglycemia, targeting at the coronary artery disease, obstructive sleep apnea, if any, obesity, diabetes, hypertension, NAFLD or MASLD, so it would be a holistic treatment of metabolic syndrome. So this is also true when you treat the hyperglycemia of diabetes. So since there's so much overlap and there is clustering of these diseases, just as treatment of diabetes today is not equivalent to just controlling the blood sugar, treatment of heart failure with preserved ejection fraction is just not equivalent to giving diuretics and SGLT2 inhibitors, but going for a holistic risk reduction strategy so that not only the heart failure can be managed in the short term and further deterioration can be tackled. So these are the comorbidities that needs to be addressed, and this is a message more to the cardiologists, because the cardiologists would be happy in just prescribing those drugs related to the heart and looking at the cardiological parameters, not very much, cognizant of the blood sugar values or how the kidneys are like, how's the potassium, sodium are like. So, but the treatment has to be a holistic one, either by the cardiologist himself or in collaboration with the nephrologist and the endocrinologist. Now, when to refer to cardiologists in heart failure with preserved ejection fraction, these are the indications, but in my practice, I refer every patient that I suspect to be suffering from any degree of heart failure, not only for diagnostic confirmation, but also for classification and appropriate management. So, from the endocrinologist's perspective, when the pharmacotherapy of this sort of patients come heart failure with preserved ejection fraction in a type 2 diabetes, SGLT2 inhibitors, notably dapagliflozin or empagliflozin, are safer. So are GLP-1 receptor agonists. You can use sulfonylureas. You can use metformin. You can also use insulin and a DPP-4 inhibitor, probably avoiding saxagliptin or allogliptin. Imeglimin, it's a Japanese molecule. becoming popular in Indian patients, among the Indian physicians, have shown to have some beneficial effects through manipulating mitochondrial bioenergetics, affecting not only the beta cells, but also the cardiac myocytes and endothelial cells. So at least conceptually, theoretically, imeglimin may be helpful. To conclude, therefore, heart failure with preserved ejection fraction is a challenging condition to an endocrinologist. There are challenges in diagnosis. The threshold to define heart failure is usually arbitrary. That's a 50% ejection fraction. The use of correct terminology is important. Heart failure with preserved ejection fraction is not synonymous with diastolic dysfunction. No single test is available to establish the diagnosis, and one needs to exclude potential mimics, both cardiac and non-cardiac. The therapeutic challenges are there, but they are less formidable as the diagnostic challenges. You have to use SGLT2 inhibitors and diuretics if they are not contraindicated. Treatment of etiology and other comorbidities. Try to avoid agents like pioglitazone. And lastly, this calls for a multidisciplinary collaborative approach. Thank you.
Thank you, Professor Dr. Sengupta, for that lucid lecture on the neurocardiohormonal milieu, that is heart failure with preserved ejection fraction. Do we have any questions from the audience? Yes.
Sir, like other parameter, N-terminal proBNP should be measured in patient with diabetes mellitus annually?
In all patients with diabetes mellitus?
Yes, sir.
In CAMS, I don't think so, because the interpretation is not that easy. That can lead to more confusion than clarity. But if you have a high pretest probability, the patient is symptomatic, then definitely you should do it. But as a routine in screening CAMS, I think that is better to be avoided.
Thank you, sir, for your excellent deliberation. Just a small query that SGLT2 inhibitor, do you think any acute mortality benefit in heart failure? That means in hospital settings when the patient actually presented with heart failure. Then do you think
in my practice, I do not use it. I am not aware of any study you may come up with. But I think with any SGLT2 inhibitor, when you use it, though, like in COVID, there was a study in the acute phase, you give dapagliflozin, that is a mortality or morbidity benefit at least. I think SGLT2 inhibitors are best avoided when the patient is acutely ill, whatever be the etiology, let the acuteness subside, and then you give it. I'm not aware of any studies, but even if there are studies, I would be wary of using it in SGLT2 inhibitors in any acute situation.
Thank you.
Thank you.
I think so there is one study, the Impulse trial, which
Right.
uses empagliflozin in hospitalized patients with acute heart failure, have been shown to reduce mortality.
Reduce mortality. But again, I said, even despite that, just because of one trial, I would not probably give it. Let the acuteness be over and then give it, because there may be other problems also, which may be the non-cardiac problems. The problems with these studies is that they have a myopic vision. So we have to take it, as I said, to give you the example of COVID. In COVID, there was a DARE study with dapagliflozin, but then with the DARE results, I wouldn't dare to use dapagliflozin in COVID-like illness. Let the acuteness subside, then give it.
Thank you, sir. Thank you so much. A big round of applause for Professor Nilanjan Sengupta.
Thank you, sir. With the end of that, we go into the next part of the program, and that would be the inauguration. And for that, I would request Dr. Nilanjan Sengupta, sir, to wait here. I am requesting all the dignitaries to be coming up on the dais. That would include the organizing chairperson of Crescendo 2024, Professor Dr. Nilanjan Sengupta, Dr. KVS Harikumar, sir. He unfortunately could not be here for personal reasons. We also invite Dr. Dasharathi Sarkar, sir, ex-chairperson of Endocrine Society of Bengal, as well as the organizing secretary of Crescendo 2024, Dr. Rana Bhattacharya, sir. Requesting Dr. Rana Bhattacharya, sir. Sir, if you are here in the auditorium, can you please come to the dais? I now request the organizing chairperson of Crescendo 2024, Dr. Nilanjan Chengupta, sir, to give the welcome address. Sir, the podium's yours.
Actually, we are, thanks to the very efficient management of Drs. Pankaj Singhania and Anish Kaur, we are running ahead of time in this hall, which rarely happens in any conference. And our official time is at 5:20, and the session in the Indu Madhav Mallik Hall is going on. So when we should have the inauguration, when we have only the inauguration and no other program is going on. So we will actually wait till the official time of 5:20 for starting this inauguration. But don't go away. I think we can keep yourselves engaged. I can make some important, I'm not saying anything official, what I'm supposed to say, which I'll say officially when it starts. But regarding, we have exciting things lined up this year. We will be having the annual conference of the Endocrine Society of India, that is ESICON 2025, in this very city under the very able leadership of Drs. Pradip Mukherjee and Dr. Sujoy Ghosh in the lead. Of course, it would be a joint effort. Everybody of us would be there, but the lead players there would be Dr. Pradip Mukherjee and Dr. Sujoy Ghosh. So I think within a month or so, you would be communicated the date and venue, exact date and venue of ESICON 2025, which should be a very prestigious event of Endocrine Society of Bengal. I think last time we had it in 2012, if I'm not mistaken. So after Agjug Pore, after 12 years, actually, we are having this conference. Next year, sometime in the month of November, December, definitely, I think after the pujas is the usual time that we have it. This time we are having it in the first week of November at Visakhapatnam. So the city is fixed, and so you should all block your dates and tell your friends to block your dates, because that conference is a conference of the all India stature and with participation from SAARC countries also, Bangladesh, Nepal, Bhutan, Sri Lanka, Maldives, sometimes even Afghanistan, and definitely Pakistan too. So, and with some, definitely there would be international speakers, audiences or delegates from countries like Kenya, and it's spread from, I am talking of delegates, not from actually invited guest faculty. They are from all over the world, but delegates do come from certain African nations too, from the SAARC countries. Though it is an Indian conference, it has assumed the dimensions of an international conference. So try to be a part of it. As soon as the dates are announced, please block your dates for the next year. So that is one important announcement. And what else? And we would be having a whole program tomorrow, a whole half-day program. As you have seen, that will also be a very interesting program, including we are having, Anish, if I'm not mistaken, some sort of, I don't know the details of it, an audience participated quiz, isn't it? Today evening. So that, I don't know, I've not asked the main organizers what they mean by an audience participated quiz, but I understand that your participation is very important, and I'm not sure whether the quiz master will have any surprise in the form of any prizes. I don't know, that's my guess, but even if there are no prizes, I think there will be no dearth of applauses. So stay back for the audience participated quiz 2, and the quiz master will be Dr. Debaditya Das, who is a young, bright endocrinologist with a pediatrics background. So you can expect some more questions from pediatric endocrinology. I think he should not be biased, but still, that's a tip I give you. There may be questions from pediatric endocrinology giving his background. Right, Anish, we do not have any videos or something, you know, of our Crescendo, no. So I think we have to wait till the persons from the other hall come. Hello? I think, yes, so we can start. So I was unofficially telling about you, about today's quiz and tomorrow's program and the ESICON that we are going to host next year. But as organizing chairperson of Crescendo 2024, may I invite you formally all, may I formally invite you all to this conference that we have put through in not probably the best of times, but still a very beautiful program has been stitched under the guidance of Dr. Sujoy Ghosh, mainly by Dr. Rana Bhattacharjee and Dr. Parthapratim Chakraborty, ably supported by Dr. Shomi Goswami and others. You have already got a taste of the academic extravaganza in the first half of this program today. So the rest part of today's evening program, including the quiz, are in store for you, and you have a full half day up to lunch academic program running in 2 halls simultaneously for tomorrow also. So enjoy this academic extravaganza. All are welcome once again.
Thank you, Professor Sengupta, sir. Next, I would request the audience present in this hall. As we all know, this city of joy had witnessed a heinous incident almost 1 month back, maybe amounting to 40 days. So in memoriam of our deceased colleague, Dr. Abhaya, I would request everyone to please stand up and observe 1 minute of silence in her memory. On that somber note, I would now request all the dignitaries led by Dr. Dashrathi Sharkar sir to declare the conference open, with a few words, of course.
Good evening, everybody. On behalf of Endocrine Society of Bengal, this is my great pleasure to welcome you all here in the Dhanodhano Auditorium, Kolkata. Now, you all know the great turmoil is going on for last 45 days, and there is much repercussion, not only in the education field, but also in society at large. In spite of that, our Crescendo team has done a great lot. The leadership of Dr. Niranjan Sengupta, Pradeep Mukherjee, Rana Bhattacharjee, Partho, and Somik, and others. Anyway, let us enjoy this academic extravaganza. Now, let me inaugurate and declare the opening of the academic session of Crescendo 2024. Thank you.
Thank you, sir. I would next request Dr. Rana Bhattacharya sir to declare the recipients of the prestigious Endocrine Society of Bengal research grants. The podium is yours, sir.
Thank you. So, as you know, that like each year, Endocrine Society of Bengal provides research grant to the postdoctoral fellow around the various medical colleges in Bengal. Now, this year we have many recipients of the research grant who are doing their research in the subject of endocrinology. So our recipients of this year are Dr. Ronita Bhattacharjee from Medical College, Kolkata, Dr. Sapan Vijayakumar Shah from NRS Medical College, Dr. Rajdeep Basu from NRS Medical College, Dr. Anushtup Mukherjee from Medical College, Kolkata, Dr. Moinak Sharkar, Dr. Orundhati Das, Dr. Akshay Khatri, Dr. Shishendu Mondal, Dr. Shet Nidhi Shailesh Vai, Dr. Ayush Agarwal, all from IPGMR Kolkata, and Mr. Akash Kumar Haldar, who is a research scholar from the Ramakrishna Mission Seva Pratishthan, Kolkata. So all those are the recipient of our grant, research grant.
Thank you, sir. With that, I would like to request you to give you the vote of thanks as well.
Thank you. The dignitaries on and off days. I must thank all the delegates who are present here for this academic program that we designed in these difficult times. Although we do admit we did not go for any overdrive regarding these programs, and just the word of mouth that all of you have responded. We are grateful to all of you. We are also grateful to the outstation faculty who came from all over India, across the metro cities and other large academic institutes and big private institutes, and enriching us with their knowledge and wisdom. We also are grateful for our local faculties, not only from Kolkata, but also beyond, from the cities like Midnapur, like Durgapur, Kollani, and Siliguri. We are also very grateful. I personally am very grateful to two persons, Dr. Shomik Goswami and Dr. Demmallo Shannal, who actually had equal share of all the things that we have done in the past 1.5 months and bit more. And they helped me like anything, so I'm really grateful to them. We know the academic program is the backbone of any conference, and Dr. Partha Pratim Chakraborty has stitched together a beautiful program in both the halls, as you are witnessing today and also tomorrow. And of course, we have a guidance from our seniors, Dr. Kaushik Pandit, Dr. Sujay Ghosh, Dr. Pradip Mukhopadhyay, Dr. Shubhankar Chaudhary, Dr. Moutushi Rai Chaudhary, Dr. Sholil Pal, Dr. Dashrati Sharkar, and many others. And we are really thankful for their guidance. We couldn't have this program without the help of our office staffs. Pradip Mondal again is the backbone of our office, and he was ably helped by Chandan, Robin, Raju, Bipul. Our event management team, RX Event, also helped us a lot regarding all the logistics support. We also must thank the pharma participants, not only for their help with finances, but also again with some of the logistics support that they have provided. We must thank the auditorium officials to let us use this beautiful auditorium for this academic program, and mainly Tushar Babu and Deepak Babu. We are really grateful to you. Caterer, 6 Baliganj Place, we are also thankful to them. Printer, Repro Digital, and a decorator and audiovisual personnel, Bulbulda. Again, they helped us a lot in conducting this particular program. And I must have missed many names that are there, and I'm really apologize for that. And at the end, I think we should continue our demand for justice of the heinous crime that has been committed, and we hope that justice will prevail in near future. Thank you all for your patient hearing.
Thank you very much, sir. I would request all the members of the organizing committee seated in the front rows to please join the dignitaries on stage so as to capture this moment for posterity? Sir? Okay. On that note, we therefore close the inauguration program, and we will move on to the rest of the academic program for the evening. Thank you. Thank you, everyone.
After the inauguration program, we quickly move on to the industry symposium programs for today evening. For the first session, which will be on premix insulin therapy, I'd like to request Professor Ashish Kumar Basu to be on stage to chair this session for the deliberations being done by Dr. Silima Estarenia. Dr. Salima will be talking on initiating with premix insulin, which happens to be one of the most commonly used insulin therapies in our part of the world.
Good evening. I'm extremely thankful to the organizers for giving me this opportunity to be a part of this academic extravaganza. Now we are about to start an important session initiating insulin therapy with premix insulin. You know, in India, the current diabetic population is about 74.2 millions, and in spite of best efforts, only 37% reach the target HbA1c. And as of now, only 11% patient, they have exact initiation of insulin in the way which is very rational and scientific. And you know, there are so many guidelines, and I think the sensible guideline is RSSDI and ESI guidelines, where if 3-way day, it fails to reach to the target, then insulin therapy, and also in the HbA1c is more than 9, like that. So all these will be taken care of by Dr. Silima, one of our bright students and upcoming, endocrinologist in the next few minutes. So over to Silima.
Thank you, sir, for the kind introduction. A very good evening, everyone. At the very outset, I would like to thank the organizing committee of Crescendo for giving me this opportunity and the supporting partner, CIPLA. I have been entrusted to speak on initiating with premix insulin. There is no conflict of interest, and these slides have been provided by CIPLA. So diabetes is a huge and growing global health concern. The prevalence of type 2 diabetes mellitus is expected to increase all the more, given the increase in prevalence of obesity and other factors which are influencing it. As the type 2 diabetes progresses, it eventually leads to beta cell decline and dysfunction. That is where the question of initiation of insulin arises. So we have a few data to highlight on the gravity of the situation. About 101.3 million Indians have diabetes, but unfortunately only 36.3% Indian diabetic patients achieve the target HbA1c less than 7%. And 80% of Indian diabetic patients are having a HbA1c greater than 7% in spite of taking 3 oral anti-diabetic agents. Now, whenever the question of insulin initiation arises, the choice of insulin is determined not only by the safety and efficacy of the available formulation, but also by the convenience and simplicity of the method of use. So the most widely regimens that we come across is the basal bolus regimen and the premix regimen. So in the basal bolus regimen, usually there is one basal insulin which is given once a day to take care of the fasting, and 3 shots of bolus which are given just before each of the 3 major meals to take care of the postprandial sugar spikes. This might appear inconvenient to some patients because multiple pricks are involved, multiple injections are involved. The second one is the premixed insulin, which is conventionally given twice a day. Now there is no definite consensus as in which particular type of insulin or which particular regimen is the most efficacious or is going to bring down the sugar levels to the optimum in patients of type 2 diabetes who are failing after tablets and lifestyle therapy. So the decision to initiate should be individualized depending upon the physician's choice, the patient's choice, and other factors like avoidance of hypoglycemia, any comorbidities, and the urgency of glycemic control. So what are the options that we have? So as far as insulin is concerned, we have come a long way. Initially, there were derivatives from animal insulin, that is animal sources, that is the porcine or the bovine. From there, we come to the human insulin, which is produced by the recombinant DNA technology, where the amino acid sequence is similar to that of the human insulin, and it acts in a similar fashion. Coming to the analogs, these are insulins in which the amino acid sequence is altered to an extent to alter the pharmacokinetic property. So here we can see that we have the basal insulins, where human NPH is the human insulin, and glargine, U100, U300, detamers, degludec, etc. These are the analogs. Coming to the prandial ones, we have lispro, aspart, glulisine, etc. These are the analogs, and regular is the human one. Now, since today's discussion is based on premixed insulin, so what are these premixed insulin? These are basically fixed component formulations containing a rapid or short-acting insulin along with a long-acting one to take care of both fasting and the postprandial sugar level peaks. These can be traditionally the human premixed insulin, where it is composed of regular insulin and NPH, and the analogs, that is the Biasp 3070, Lispromix 2575, others. Idegasp is another example where a very long-acting insulin is added with a short-acting one. Now, coming to insulin in the Indian context. So how is it that us Indians, we are different from the in terms of treatment or in terms of diet, etc. So there was this study, START study, which was conducted way back in 2014, if I'm not mistaken, and they demonstrated, basically it was a diet survey, that the amount of carbohydrates in our diet is very high. It was about 64.1% of the energy that we are deriving from food is from carbohydrates. Also, studies were done comparing the Indian population with the Caucasians, where it was shown that the contribution to the HbA1c, to the increasing HbA1c, in case of Caucasians, it was obviously the fasting plasma glucose which was contributing more, but in case of Indian population, it was seen that as the HbA1c was increasing, the contribution from the postprandial glucose levels was also more in comparison to the Caucasian ones. So what is the issue of postprandial blood glucose level? Why do we need to control it? A is because for a complete management of diabetes, not just the fasting, but the PP needs to be controlled, or else HbA1c won't come into place. And secondly, isolated increase in postprandial blood glucose levels is also associated with CV mortality, diastolic dysfunction, impaired myocardial blood flow, oxidative stress, pancreatic cancer, etc. And in some studies also it has been shown that at similar levels of fasting plasma glucose, an isolated elevated postprandial blood glucose level is an independent marker of mortality. So that is why not just the fasting, but the PP also needs to be managed to get a wholesome control. So are we starting insulin at the right time? There is often a delay in the initiation of insulin therapy, resulting in higher risk of failure of only basal insulin. So there was this study, the IMPROVE study, where there were around 9 to 11 countries which were involved, and India was amongst them, and 60% of Indian data was from the South Indian states. So here, in the baseline characteristics of the Indian cohort, they demonstrated that there was not only a very poor glycemic control, but also these subjects had a huge delay in initiating the treatment, whether it be insulin or OADs. So now whenever it comes to insulin initiation, it is not always the patients who are refusing it. Many a times even it is inertia which is from the healthcare professionals. Say we are in a very busy OPD and we have to attend lots of patients. We do not really give that kind of time to explain to the patient, to familiarize him with the idea of insulin and how to train them, etc. Secondly, we also sometimes feel that, okay, maybe there might be an hypoglycemia or etc. And we also sometimes step back where introduction of insulin was probably necessary. And coming to the patients, of course, they always have needle phobia, fear of multiple injections, cumbersome regimens, hypoglycemia, and cost issue, definitely. So I've already discussed this slide. We can see here that in the brown marked is the fasting, and in the yellow color, mustard yellow, is the postprandial glucose. In the East Asian, the contribution of the postprandial is increasing as the HbA1c is going on the higher side in comparison to the Caucasian data. So now coming to some guidelines. So recommendations from the global and Indian guidelines on the choice of insulin regimen. The ADA, AACE, IDF, Canadian Diabetes Association recommend basal insulin alone for insulin initiation. The NICE guidelines, they ask for the use of premix insulin apart from basal insulin, whereas the RSSDI, EADSG, and some Australian guidelines recommend either basal insulin or premix insulin or co-formulation for initiation of insulin therapy. So coming to the RSSDI ESI recommendations for diabetes mellitus 2022, which sir was already talking about, that insulin therapy should be considered for the patients who fail to achieve glycemic targets to 3 oral agents. Second, insulin initiation should be considered in patients with symptomatic severe hyperglycemia or unstable state, that is if the patient is having any features of catabolism or there is osmotic symptoms. And a 3-step protocol involving initiation, titration, and intensification is recommended for all patients requiring insulin. So how do we initiate it? As per the guidelines, once daily basal or once daily premixed insulin or twice daily premixed insulin, either alone or in combination with other OADs based upon the patient's age, clinical features, glucose profile, risk of hypoglycemia, and patient preference. Patient preference has to be given importance because if the patient is not wanting or is reluctant to take 4 shots of insulin, then we might as well give him an adequate control with twice daily premix. And also, for instance, risk of hypoglycemia. If the chances of hypoglycemia is much higher in a patient, then we start with a lesser than usual dosage. So this is the ADA 2024 recommendation on initiation of insulin therapy. The slide seems very busy, so I'll just summarize. As per the ADA 2024, here what they state is, whenever the requirement of an injectable pops up for a patient of type 2 diabetes, the first to go for is either a GLP-1 analog or a GLP-1 along with a GIP-1 analog. Once we initiate that, despite giving that, if the patient is still not achieving the glycemic control, still not achieving the target HbA1c, only then to go for insulin, that to a basal one. And we know how to initiate the basal one. Either we go with 10 units of NPH or glargine for the matter, and the titration is done either twice weekly or once in 3 days, about 2 to 3 units, adjusting to achieve the adequate fasting targets. And of course, if hypoglycemia seeps in, then we bring about a dose reduction. Now, after this basal insulin initiation and titration, if still the HbA1c targets are not met or if the sugars are not being controlled, in that background, they have suggested to go for a prandial component. Now, this prandial component can be in any aspect. Either, for instance, if a patient is having controlled fasting, but one particular meal, the sugar spikes are very high. So in this situation, we can start with a basal plus 1. That is 1 bolus, which is going to target the highest meal or the meal with the least controlled blood glucose levels. Another option is if there is grossly elevated blood sugar levels in all the major meals, we can directly start with a basal bolus regimen. That is basal, along with it 3 shots of bolus. And another regimen would be go for a twice daily premixed insulin or any kind of analogs. So this is the American Diabetic Association and the EASD consensus, and they also walk along the similar lines as I just discussed regarding the ADA. Now, what are the considerations for premix therapy? So some of the studies have shown that if the postprandial spike is greater than 54 mg per dl and the fasting plasma glucose by HbA1c ratio is less than 20, then that is a somewhat objective parameter for the introduction of premix insulin. And if the patient is having a limited literacy and requires a very simple, easy to understand regimen, convenient regimen for future titration, then again we can opt for premix insulin. Last and but not least is if the patient is on a high carbohydrate diet like people in our country. So now coming to the steps for initiating premix insulin, this slide too looks a bit busy. What we need to keep in mind is usually we keep a target, pre-meal target of about 115 mg per dl and a post-meal target of about 140 to 160 mg per dl. And we go for twice weekly titrations, or it can be even a greater number of titrations depending upon the association of the patient with a healthcare professional. And slowly but gradually, the plan should be to optimize the glycemic control, excuse me, and bring down the HbA1c levels to the target. So now we have a small little case study before I end. So we have a hypothetical patient, 61-year-old male, who was a known diabetic for 6 years, hypertensive. 3 months back, his HbA1c was 9.3%. Weight is 72 kg, BMI is on the higher side. Feet and eyes are normal, BP is reasonably controlled with medications. Currently, his lab reports demonstrate that his HbA1c is 9.3%, fasting and PP both are high. 170 mg per dl is the fasting and 280 mg per dl is the PP. Creatinine is 1.1, which tunes to the eGFR of 80. Urine ACR is 70 mg per dl. Lipid profile is deranged. The LDL is way off target. It should be around 70 mg per dl, considering that he has a family history of cardiovascular disease, which is mentioned in the next slide. Triglycerides are also high. However, the liver function is normal. The patient has come to us for the inappropriate blood glucose control, and the medications, he is on a host of medications with probably highest doses of majority of the ones, metformin 2 gram, glimepiride, sitagliptin 100, DAPA 10. Excuse me, atorvastatin 20. Family history, father had coronary artery disease at 56 years of age. Dietary pattern is a predictable diet with heavy breakfast and dinner, and he is compliant with medication. So we don't really have much scope over here, but to initiate insulin. So what would be our preference? Now, if we look at the guidelines of the ADA, etc. So in that case, they might be hinting towards starting either a basal insulin or maybe switching the sitagliptin for a GLP-1 analog, given the cardiovascular risk, family history, etc. But since this is a premix talk related to premix, so I'll try to be highlighting the areas where premix is advantageous. Now, coming to studies, there are many studies which have compared premix versus basal. Some studies would be suggesting that a premix is going to give better control of HbA1c or for less hypoglycemia. Some studies would say against, and they would claim that probably long-acting glargine is better, and some studies would have a neutral stance. For instance, they would claim that in both premixed twice daily versus glargine, both would be having equal outcomes. So in this particular case, there is one study, that is the durable trial, which was Lispromix versus glargine, and it was done to check the efficacy and safety of Lispromix twice daily versus glargine once daily on top of OADs. And it was shown that the patients who were on the arm of Lispromix had shown lesser, or rather they had achieved a better HbA1c control, slightly better HbA1c control, and the number of people who had achieved it was more in the Lispromix arm. Whereas hypoglycemia was concerned, overall hypoglycemia was probably slightly higher in the Lispromix arm, but nocturnal hypoglycemia rates were similar. So in this particular patient, we started with Lispromix 10 units before breakfast. Dose was titrated at weekly intervals. After 6 weeks, second dose of Humalog mix was introduced, 10 units before dinner, receiving 16 units before breakfast. Further 4 weeks later, it was finally stabilized to 20 units before breakfast and 14 units before dinner. At 3 months, the glucose control comes down to normal, HbA1c 7.5. So if we go back, the initial HbA1c was 9.3, persisting for a long time with a host of OADs. But we brought down and we started, they started Lispromix and settled it at a dose of 20 and 40, and in another 3 months, the glycemic control was reasonably good. So to conclude, only about a third of Indian diabetic patients achieve HbA1c less than 7% goal, and only 11% of all treated patients are on insulin, there is often a delay in initiation of insulin therapy, resulting in higher risk of failure of only basal insulins. Indian guidelines support premix insulin as well as basal insulin as the initial choice. Choice of insulin for initiation should be based on patient's glycemic characteristics, postprandial spike, etc. lifestyle. Greater durability and percentage of achieving HbA1c less than 7% was observed for Lispromix when compared with basal insulin. Thank you for your patient hearing.
Thank you, Srilima. So it crystallizes from your talk that in Indian scenario, the major contributor of HbA1c is postprandial glucose, and Indian dietary habit is rich in carbohydrates. And the lack of knowledge about initiation of insulin at the right time is rather a horrible feature in the Indian scenario. And I quote from legendary figure or doyen of diabetes, Professor Elliot P. Jocelyn, that lack of knowledge about the initiation of insulin is more dangerous than lack of insulin itself. So with these few words, I open her talk for interaction from the gathering, from the August gathering. If anybody has any question to ask our speaker. So let me put it in other way. As in Indian scenario, there are several modalities of initiation of insulin. And you know, the delay in the initiation of insulin when it is required has harmful effects. One of the effects is that in delay of insulin, when the beta cell is completely exhausted, the paracrine crosstalk, which is helpful for fighting against the hypoglycemic episodes, is lost. If residual insulin is there in the beta cell, it helps to mount the response during hypoglycemia through paracrine crosstalk. So that is number one lost. So when we contemplate that insulin is necessary at this point of time, we have to start it. And for initiation of insulin, premix insulin is a very good option, as she has already alluded. And in Indian scenario, studies has already pointed out that premixed insulin is a good choice, is a preferable choice than the basal insulin. And she has already discussed in depth about the initiation, titration and intensification of the premixed insulin therapy. So if there is no more question, with this I can declare this session closed. So thank you all, everyone in this August gathering for giving us the time to share this important information. And thanks Srilima for wonderful presentation. Thank you.
Thank you, sir. Thank you, sir.
So that brings us to our second part of the session. Now, talking on the tailoring diabetes therapy, that is the role of degludec and its co-formulation, I call upon stage two eminent endocrinologists, Dr. Arindam Rai and Dr. Shubhadeep Pramanik. So we want to know about the degludec and its co-formulation. So the stage is all theirs.
Thank you, the organizing committee, for giving us the opportunity, and warm good evening, everybody, all the delegates. It's almost the last, second last talk or discussion that we have now. And thanks, Dr. Silima Tadinia and Professor Bashu, because they have already made the, set the ground. Here, our discussion will be a bit easier. So, pointing today's discussion on the tailoring the diabetes therapy, the role of Degludec and its co-formulation, and thanks the Novo for sponsoring the session. This is a financial disclosure, I'm not going details of it. So definitely the diabetes as a disease, it's growing day by day, and what we're predicting in next 10-15 years, the burden of diabetes will be so high that India can be the capital of diabetes, and we are not worried about the number of diabetes, but rather the glycemic control, which is the most important part to prevent the complications, the microvascular complications of diabetes. So that is the horrifying picture we are getting from landmark trial, where the average A1C in Indian patients is around 9.2%. Again, this is a study that shows that only 19% of the diabetes patients in India are actually good in glycemic control. But almost the mean A1C in this study, the patients have around 8.9 to plus minus 2.8%. So my question to Dr. Shubhadeep, why do you think we fail to control, and what is the way out of this danger period?
Thank you, Dr. Arindam, for asking such a pertinent question. Definitely, we are living in the year 2024, and now we have so many drugs in our hands, starting from metformin, sulfonylureas, the gliptins, the SGLT2 inhibitors, GLP-1, insulin. But still, Arindam has shown the paper from 2011 that showed that most of our patients are having HbA1c around 8.9. But believe me, today also the scenario has not changed much, because the study from 2020, it also showed the average A1C in our patients is 8.48%. So when I was going through this data, I was a bit astonished that what are we doing? Are we treating it well? And I wanted to know that what my patient status is. So that's why I opened up my patient data sheet from HealthFlix, and I got shocked that this was the average A1C of my patient who are under my treatment. When they come for the first time to me, their average HbA1c is 9.08%. Imagine, more than 9. Well, maybe they came with high sugar, that's why they came to see an endocrinologist. But what are about the patients who are already under me and are coming for revisit? Still, in those group of patients, those who are continuously showing their average HbA1c was 7.8%. That means a majority of patients treated by an endocrinologist, at least for me, I couldn't achieve HbA1c of below 7. There are lots of causes behind that, but believe me, we need to find out a solution. So Dr. Arindam asked me why is it happening and what is the way out. So I understood there might be possibly two issues why these things are happening. One is we are adding on OHA. One, the patient's HbA1c is not under control. We are adding 1, then 2, then 3, then 4. And every time we add one OHA, we think, okay, I'm adding a gliptin, it will reduce the HbA1c by 0.8%. Well, patient is on already metformin, gliptin, glimepiride. Let me add a dapagliflozin. It will reduce HbA1c by another 0.8%. But believe me, it doesn't happen. So this slide beautifully shows that when you add the fast OHA, it can reduce HbA1c by even 2%, even if it is a metformin like that. When we add a second line agent, whatever agent we use, it reduces HbA1c around 1%. Then the third agent, I'm not telling the name of the agent, but if you give a gliptin or SGLT2 everywhere, the third agent will reduce A1C by 0.5%, and the fourth will be 0.2%, and imagine fifth, what it will do. So basically, we are getting into a trap. We are adding on the OHA, but we are not getting a solution. Our patients are coming back again and again, telling, Doctor, arektu time din ami komiye felbo. But if you see that the insulin, the use of insulin has been shown to reduce that HbA1c unlimited. In this particular trial, it was 1.3%, but basically insulin has unlimited capacity. And the second issue is the carbohydrate intake. In India, we do take more carbohydrate, and our Indian phenotype also support that more thin fat Indians, more visceral adiposity, and that's why the beta cell exhaustion is even faster. That's why our OHS doesn't last long. So ADA guideline, my previous speaker has already shown this part, that when an injectable is indicated, it should be an GLP-1, but still after that A1C is not under control, we should add a basal insulin. So basal insulin is obviously the treatment of choice according to the most guidelines available internationally, be it the ADA guideline, be it the ACA guideline, ESA guideline. Now, among the basal insulins, now you and I, everybody using glargine 100 unit for pretty long duration, and we are very happy with that. But have you ever imagined that with glargine 100 still we have different unmet needs? Like glargine, although we call it a long-acting once daily insulin, it's not actually 24-hour acting. It's 20-hour acting, and many of our patients, when we give glargine at 10 p.m., their pre-dinner sugars are high. The variability, it's not a peakless insulin. There is always a variability. Fixed time dosing is required, sometimes difficult for our patient, and higher nocturnal hypoglycemia. Obviously, it's lower than the NPH that we used to use in previous days, but still nocturnal hypoglycemia do occur, and our patients comes with Somayagi phenomenon where the fasting control becomes very difficult, and that's why we need a better insulin. So here I'd ask my co-speaker, Dr. Arindam, can you suggest me a better basal insulin in this regard?
Yeah. So in modern days, we have many insulins in our hand, including the basal insulins, which we can call as second generation or generation 2 insulin, which has definitely some the good aspects like robust glycemic control and less hypoglycemia, because these are the two important issues that definitely we'll take care when we prescribe any insulin to the patient. Definitely it's safe during the transition or the maintenance phase. There is minimal weight gain, the flexible dosing, stable and prolonged action of more than 24 hours, which is just mentioned by Dr. Shubhodip. There is less glycemic variability, because we all know that glycemic variability is a very important part of the glycemic pentad that we actually trying to achieve in any type 2 diabetes individuals. Effective and sustained glycemic control, and definitely less overall or nocturnal hypoglycemia. So we have in our hand degludec U100 and glargine U300 as the second generation basal insulin. Now there are studies like CONFIRM study, that data from real world evidence, that hypoglycemic events, and the data shows that comparing the two insulins, the degludec have a definitely, the rate of hypoglycemia, at the same time the proportion of patients with hypoglycemia, they're all less with the U300 insulin compared in the degludec arm. Again, if you think about the onset of action, the degludec starts early, 0.5 to 1.5 hours, whereas glargine 300 is 2 to 6 hours. The peak action, definitely both of them has a minimal peak, whereas the duration of action is also more. For degludec is more than 40 hours, whereas in glargine 300 is around 30 to 36 hours. So definitely degludec is fast acting and prolonged in duration compared to glargine U300. Coming to the flexibility, which is a very important part of any insulin, because many of our patients actually come, they have a very busy schedule, so many times they actually try to forget, unfortunately, when to take the insulin. So degludec is such an insulin that can be taken at any time between 8 to 40 hours of the last dose. So it has definitely have a more flexibility than glargine U300, which has to be taken plus minus 3 hours, and here's the advantage of insulin degludec. So this is the study that shows the intraday variability also less in insulin degludec compared to the insulin glargine U300, where in the right hand side we can see the variability with the insulin glargine 300 is maximum in 0 to 6 hours and 18 to 24 hours, which shows a U-shaped curve, whereas the better, the 24 hours clock coverage with the degludec, which shows almost a constant or steady level in this study. Also, when we compare the two insulins for inter-day variability or day-to-day variability, here also we can say that this blue bar showing the degludec showing almost a constant level, whereas the insulin glargine U300 that shows definitely a higher variability comparing this inter-day or day-to-day variability. So degludec seems to be a better compared to insulin glargine 300 in this aspect. Again, the study also shows, which is a statistically significant data,
where the insulin degludec is more potent, more than 30% potent than the insulin glargine U300. So definitely from the studies we can conclude here that the ideal insulin, the basal insulin that should start can be insulin degludec, because it has a flat, it has a peakless activity profile, minimizing the risk of hypoglycemic events. It's a long duration of almost more than 24 hours, say about 40 hours, allowing dosing flexibility and definitely minimal glycemic variability. It can be both intraday or interday. So my next question to Dr. Shubhadeep, can you share a real life case where you are fighting with this multiple OADs and can have a better result with this basal insulin initiation?
Well, so Dr. Arindam has passed with flying colors in theory. Now it's practical examination for him to apply degludec to a difficult case that I am going to give him now. So this is about a 50-year-old male patient who is engineer by profession, diabetic for long 11 years. He presented with an HbA1c of 8.8% with a fasting plasma glucose of 188 milligram per dl and postprandial of 218 milligram per dl. The patient is obese, BMI 27, has more or less controlled blood pressure, but obviously on medication, has dyslipidemia as well. The renal function is in stage 3A, eGFR of 55, with urine albumin excretion of 200 milligram. That means somewhat CKD stage 3A and albuminuria stage A2. He has family history of diabetes, takes alcohol, moderate consumption, non-smoker, and exercise pattern is very irregular. So this is a garden variety of our patients who come to us for our clinical checkup. And on medication history, we found he was already taking full dose of metformin, 2 gram, empagliflozin 25 milligram, liraglutide 1.8 milligram once daily, and glimepiride of 2 milligram. Despite taking that, patient's fasting was 188, postprandial 218, and HbA1c of 8.8%. So basically on 4 drugs, including an injectable GLP-1. So here, as I have already shown, addition of a 5th agent is unlikely to reduce HbA1c from 8.8 to below 7. So my primary challenges that I faced during this patient is uncontrolled hyperglycemia despite taking so many drugs. There's a hectic work life, fears insulin initiation will affect work life due to hypoglycemia risk. Basically, they need to work even at night as well. And travels often unsure about taking insulin at fixed time of day. And obviously, the exercise pattern is very irregular for this particular patient. So I'll ask my co-speaker, Dr. Arindam, what next in this patient? And what insulin do you consider for this particular patient?
So this is the slide that makes the answer here. So when the postprandial, we have to actually watch the postprandial glucose excursion. So we have to measure the preprandial and postprandial glucose, and we have to check whether the difference between the two values is less than 40, 40 to 74, or more than 74. And this has been actually the data that has been calculated from different studies. So here, if the prandial the prandial increment is less than 40, then definitely the basal insulin is the choice to start, because here the fasting actually going to be the predominant, the part of for the glycemic uncontrolled state of the patient. So how to initiate this insulin degludec? Here we can start the insulin degludec alone, or we can combine with other oral antidiabetics or GLP-1, or even with the bolus insulin. And the recommended starting dose is around 10 units, though it can be varied according to the weight of the patient. We usually start with a 0.2 unit per kg body weight and request subsequent individual dose adjustment, which we usually do every 3 to 4 days, or at least once a week for actually the titration to make the target the fasting sugar around 80 to 130, though it can vary according patient to patient with complications. When we are actually switching from other insulin to the basal insulin, we can go for either a unit to unit switch, or if the patient is actually getting twice daily insulin like basal insulins or glargine 300, then we can actually reduce the dose by 20% for avoiding hypoglycemia. So in our patient, we have started the insulin injection degludec 10 international units subcutaneously at 10 p.m., though the time actually can vary, as I've already mentioned. And we have done the 4th day SMBG, the fasting, and titrated to make the fasting EG is around 80 to 130.
So here the result after 3 months, which shows the fasting control with 110, postprandial control at 152, and HbA1c down to 6.8 without hypoglycemia. So here in India, definitely the insulin initiation is very, very late. But the situation is to some extent different. As in my last talk, Dr. Selim has also pointed out, the postprandial correction sometimes makes a very challenge to the HbA1c correction. So basal insulin initiation may not be sufficient many a times. So here the slide has already been shown, but again I am repeating the slide because it's a very, very important to know that particularly Indian context, as the STAR study value shows, the prandial correction is important because of the high carbohydrate load. So in all HbA1c categories starting from 8.5 to 9.3, we can see the prandial contribution to the high glycemic control is very important, and we have to take care of this prandial correction at the same time with the basal correction. So my next question to co-speaker, Dr. Shubhadeep, why this postprandial is more for Indians and what is the way out of it?
Yes, absolutely rightly pointed out. In India, actually, the insulin initiation is often late. And I remember one of my patients who was already on 5 OADs, persistently HbA1c around 7.5. When I offered him insulin, told, doctor, are you offering insulin at such a low sugar level? I think it's okay, I can manage. So basically they don't even understand that 7.5 HbA1c is also harmful to them, and they need it to be lowered according to their age and morbidity status. It's at least below 7 or below 6.5. But that's the usual denial mode for our patient when we try to start insulin at a timely initiation. So basically what happens next, that patient's HbA1c keeps on increasing, and ultimately patient agrees to take insulin when their HbA1c is around 9, 9.5 or even 10. And why it happens very rapidly in Indian, the next slide gives the answer. It's a typical Asian Indian phenotype, also called thin fat Indians. That means being a similar BMI, we do Indians have more visceral fat, and that's why there is insulin resistance, and more insulin resistant means the beta cell need to function more to overcome that resistance, and that's why beta cell exhaustion are even earlier in patients, in Indian patients. And as there is more insulin resistance, more beta cell exhaustion, the diabetes related complications are also more to be seen in this country. So the clinical profile of type 2 diabetes in Asian Indian differed from that of Caucasian. We do have earlier beta cell dysfunction and exhaustion leading to more complication. So as a clinician, what is our aim? Our aim to just to identify that what level of beta cell function do our patient have. So if you see this chart properly, in the x-axis I have written the diet, the time that after initiation of diagnosis, for how many years the patient is having diabetes, and in the y-axis I have kept the beta cell function. So at time of diagnosis, already 50% of our beta cell are gone. And for the next subsequent years, whatever we do, however we treat, whatever diet exercise we do, we till date cannot prevent beta cell dysfunction. The beta cells are progressively getting damaged. But obviously those who are doing diet, exercise properly, their beta cell protection, slight protection is there definitely. Again, beta cell function is not an universal thing. It can be recovered. Let's say somebody presented first time to us with an HbA1c of 10, 12%, then after doing diet, and at that time possibly only 30% of their beta cell is functioning. But once they are doing proper diet and exercise, and some of them do have remission of diabetes, so for them at least 20% of their beta cell regain function. That's called the reversibility of beta cell function. So that's why we need to find out that what exact status of the beta cell, and for that we have few tests, our clinical experience, the patient phenotype, the duration of diabetes, everything determines. So I often tell my patients that somebody coming to me for the first time with an HbA1c of 10, 11%, we can manage with OHA if you do proper diet and exercise. But the same patient, if the diabetes duration is of 20 years, nowhere the OHA will work at 11% HbA1c, we must start an insulin. Because in last 10, 11 years, their beta cell function has progressively been declined. So here I have shown that how initial years diet and exercise works, then diet become inadequate, sorry, slide is not action. Then OHA monotherapy, after that OHA combination is required, then OHA becomes inadequate, and that portion, if you start an basal insulin, it will work. But if you make a delay there, you are hesitant, you are reluctant, then the scope for basal insulin is gone. They will present with an HbA1c of 9, 10, and that time your PP blood sugar will start rising and will lose the scope of basal insulin therapy. There we need either a basal bolus insulin or either at least a premixed insulin or co-formulation. And even what happens later than that, the patient becomes absolutely insulinopenic, and that time we need to think even beyond that, and maybe some insulin pump will be required. They behave just like a type 1 diabetic. Now, why happens in India? This major reason is, I have already told, the thin fat Asian phenotype, and the second issue is high carbohydrate intake. The starch study, my previous speaker also told about it. We Indians do take more carbs, more than 65%, and it's not a particular state. It's all over India. 5 regions, they have shown similar carbohydrate intake, and it has been shown more carbohydrate intake leads to more postprandial blood sugar, and that's why we need something to control the postprandial blood sugar. Because in this group of patients, if we give only basal insulin, it will obviously inhibit the hepatic glucose output and reduce the fasting plasma glucose. But what about the PPG? For PPG, their OHS have already failed. So we cannot control with the gliptin, cannot control with the metformin or SGLT2 or even with sulfonylureas. We need some amount of insulin to combat the postprandial blood sugar. So that's why our Indian RSSDI has come up with a practice guideline in 2022. They're saying that insulin initiation in India, we have 3 options. One, the basal insulin that most of our international guidelines are recommending for a timely insulin initiation. But in India, we are already late. We must have a postprandial component into our insulin therapy. And that's why either a premix or a co-formulation that has to be used. Now, already we have heard about the premixed insulin, and Dr. Arindam has also told about the basal insulin. Let me focus on the co-formulation, what it is. So co-formulation is basically a soluble combination of 2 individual insulin analog. One is the ultra long-acting degludec, 70%, another is short-acting aspart of 30%. And those both are combined together, and they are together called IDEC aspart. In the pharmaceutical formulation, they remain as a hexamer in a single syringe, and we have to inject it into the subcutaneous place. After injection, usually the aspart gets absorbed into the circulation rapidly, whereas degludec slow dissociation, then come out, bind to the albumin, and act through a longer period of time. So where this combination is really important. One, where there is high carb diet, because postprandial insulin, the aspart will take care of that carbohydrate. High PPG level, obviously, with high carb, you'll get high PPG. Uncontrolled or multiple weighty, high HbA1c, delayed insulin initiation. So this group of insulin are going to combat both the fasting as well as postprandial component. So basically, co-formulation is a basal insulin with a built-in rapid-acting component for a reason. The reason is high PPG. So this is the RSSDI clinical practice guideline. They recommend that IDEC aspart as a choice for insulin initiation. Some benefits are obviously there. The less hypoglycemia, flexibility of administration with any major meal, low dose is required because degludec is a very strong basal insulin, and lesser weight gain as compared to the premix. So, well, again, enough of theory with this co-formulation. Now I'll request my co-speaker to share one patient detail where the insulin initiation was late. So can you share a case?
Yes. So this is the case. Mr. Amit, who is a 53-year businessman, 7 years of type 2 diabetes, presented with a HbA1c of 10.2%, with definitely BMI of 25. The fasting is 206, and the postprandial is 278. And the blood pressure is reasonably controlled, with the LDL a bit high, 138, EGFR of 70, and the patient is a non-smoker and non-alcoholic otherwise. And the concern, the treatments are getting the metformin 2 grams, sulfonylurea with 2 milligram, the dapagliflozin 10 milligram, and sitagliptin 100 milligram. Again, the fear of hypoglycemia, all the patients have, similar to this patient. Uncontrolled hypoglycemia, we have to take care. Erratic dietary pattern is a very important issue, and again, travels often, so unsure about taking insulin on fixed time of the day. So what next to this patient? And what insulin would you prefer consider in this patient?
Well, again, I'll take the help of same slide which Dr. Arindam took for the initial basal insulin selection. Now, this paper was quoted from Dr. Sanjay Kalra's paper in 2015, but after that, I think ADA has slightly changed the values. I didn't change the slide because it's a pharma symposium, but nowadays 54 is usually taken as a cutoff below which we can use a basal insulin, and above 54 we can use a premixed insulin. So obviously in this patient where the difference of fasting PP is quite high, almost 72, and HbA1c of more than 10, that already implies that patient's insulin initiation is already delayed. Here we have to think either of a mixed insulin or a co-formulation for that matter. Now let us see what is the advantage of this co-formulation as compared to basal insulin. So when we search the literature, there are multiple studies. Some studies favored basal insulin, some studies favored co-formulation. I was a bit confused why is this happening. Later I understood that it's actually the inclusion criteria which could determine that which insulin will win. Because if you start with the basal insulin at a timely insulin initiation, possibly that is one of the best thing you can do. Like Dr. Arindam's first case, he achieved a very good glucose control with the usage of basal insulin alone. Had I given a co-formulation there, I could have landed up with more hypoglycemias, but obviously control would have been same, but hypoglycemias would have been better, would have been more. But in later stage, when C-peptide is even lower, the beta cell exhaustion is even more, at that time, if we start this co-formulation, then you will have an advantage over basal insulin because it will control both the fasting as well as postprandial sugar. So what I tried to do, let us not focus on a single study, let us go for a meta-analysis, and I'll discuss what are the efficacy endpoint, the safety like hypoglycemia, quality of life and flexibility associated with co-formulation insulin. So this meta-analysis by Moon et al. I am going to just discuss in short, where they have taken effect of once daily deglutec aspart on glycemic control as compared to the basal insulin with the safety outcome of hypoglycemia, because once we have a prandial component, there is always chance for more hypoglycemia. Now in this meta-analysis, they beautifully showed that to achieve the same HbA1c control, same fasting sugar control, because most of the trials were designed in a way to achieve a similar fasting plasma glucose control by SMBG. So a fasting plasma glucose was expected to be same in both the group, but it was seen that the PPG and the self-monitoring of blood glucose was better than in the co-formulation group, and exactly that is what expected when we have an insulin with prandial component. PPG control was much better. But what is important here is the safety issue, that overall confirmed hypoglycemia were more or less same, but nocturnal confirmed hypoglycemia was significantly lower in IDEC aspart group. Now you may ask why lower, because it has a prandial component. The answer to this is that when you're using basal insulin alone, you're going to give a higher dose to achieve a better A1C. And to do that, you're actually landing up with a nocturnal hypoglycemia. And again, glargine 100, I've already shown, it is not truly peakless insulin. So if you increase it, you are actually going to have nocturnal hypoglycemia. And the more important thing is, most of the time, you can't understand it from a fasting PP report, because due to Somogyi phenomenon, the patient fasting will be 140, PP will be 132, and the HbA1c will be 6.4. And you will be thinking, oh, fasting is slightly high, let us increase. So that's the way the patients actually suffer from nocturnal hypoglycemia, and often we miss it. So that's why if we have a prandial component of insulin with co-formulation, there you can achieve a better HbA1c control with a lower dose, and obviously as the HbA1c is better, you are not increasing the insulin much, and ultimately patient is protected from nocturnal hypoglycemia. Now the question is how much safe and easy is for the patient when they are shifted from glargine to IDEC aspart. Obviously, when IDEC aspart co-formulation is prescribed, the number of wages come down. So in this particular trial, when the patients were shifted from once daily basal insulin to a co-formulation, it was seen that the quality of life improved. And many patients, they choose to continue with the co-formulation and didn't want to go back to the basal insulin due to multiple reasons. And one of the reasons was the flexibility of dosing, and because basal insulin, like glargine 100, has to be given at the same time of every day. The glargine 300, there's a flexibility period of 3 hours. However, IDEC aspart you can give with any major meal of the day. And what do we mean by major meal? For that, we have to understand how do we initiate this one. So the recommendation is we have to initiate IDEC aspart with the most carbohydrate heavy meal of the day. Remember, it's not the heaviest meal of the day, but it is a carbohydrate heavy meal of the day, most carbohydrate heavy meal of the day. And once you are choosing it to give BD, which my co-speaker will discuss, there you have to select the two most carbohydrate heavy meal of the day. And how do you calculate? For that, you need to know the food constituents. Your dietitian might help that regard. So somebody's night dinner is the most carbohydrate rich meal. Somebody have the lunch. In India, mostly the lunch time is the highest carbohydrate meal, and then that way they need to inject it before that time. So coming back to the case which Dr. Arindam gave to me, this patient had a high fasting PP gap, sky high HbA1c on 4 OHs. So that patient, we had started a co-formulation of IDEC aspart, 15 units subcutaneously before lunch, because for that particular patient, lunch was the heaviest meal. SMHE was advised every 4th day, titrated the co-formulation dose to keep the fasting between 80 to 130 and adjusted the weight accordingly. After 3 months, the fasting came out to be 114, PPG of 162 and HbA1c of 6.9 with relatively no hypoglycemia. So again, that's a pretty good example. When the patient comes late, there is delayed insulin initiation. Just adding a prandial component in a single dose, you can achieve a very good glucose control. But the story doesn't end here. What happens when the patient's beta cell worsens further? Because we know it's a progressive disease, we cannot stop. So when the beta cell is even worsens, what will happen, Dr. Arindam?
So after the initiation of this once daily premix insulin, so what the option we can have a kind of basal bolus treatment regimen, or we can go for twice daily co-formulation. So this is the IDEC asp, which can be given twice daily. And when to intensify, that is a very important aspect we have to know. When the postprandial glucose excursion after 2 meals in a week, the excursion is unresponsive to diet manipulation, and when once daily dosing is actually increasing more than 30 to 40 units. And how to intensify? The total daily dose split over the 2 meals with greatest carbohydrate content, like lunch and dinner or breakfast and dinner, and the ratio based on relative carbohydrate content and the PPG excursion. So for that detection, we can take a good carb count, or we can do a 7-point SMBG, or we can go for AGP or CGM. So this is the study that shows multiple daily dosing, like basal bolus treatment. What we actually do, the insulin plus OAD, then basal plus insulin aspart, then basal plus twice daily, then thrice daily, which is a conventional way. If you can straightforward go to IDEC asp once daily to IDEC asp twice daily, so gives the almost similar HbA1c result benefit, at the same time the similar hypoglycemia or the lesser hypoglycemia and better quality of life by reduction of number of pricks and reduction of hypoglycemia and weight gain. So with this, to summarize our today's talk, timely insulin initiation definitely is a key of diabetes management, particularly in Indian context where the HbA1c control is very poor, and definitely that lands up with a poor, the complications and quality of life. Generation 2 basal insulin have the better safety issues. Definitely we concern about when to start with the basal insulin. Degludec versus insulin glargine, I have seen the comparisons where the degludec is definitely better from potency point of view, at the same time less hypoglycemia and day-to-day and inter-day variability. And again, when we think about the co-formulation, that is the IDEC asp is better PP control, important for high carb diet, particularly in Indian context, and definitely when the initiation is quite late because the beta cells are already exhausted. And we can go for twice daily IDEC asp if the HbA1c is again out of target, for better compliance to the patient and better quality of life. So with this, I think we can stop here and waiting for the question answer if there is any.
Thank you.
Thank you. That's an excellent discussion. So any questions from the floor? So if there is none, then let's just thank our two excellent speakers for their excellent duologue. And thus, this comes to an end. And we will give round a big round of applause. Thank you. And we would like to call upon stage For discussion regarding semaglutide research, we would like to call upon stage none other than Dr. Shoumik Goswami, our beloved professor from NNRS Medical College and Hospital. Sir, the stage is all yours.
Okay, so a very good evening to all of you. We have had a long day of academics. Just to liven up things a bit, can anyone in the audience tell me what relation do these people have to what I'm going to speak over the next 20 minutes? Just a relationship, I'm not asking for their names. Okay, so the fact remains that yesterday when the Lasker Awards were announced, now what are the Lasker Awards? They are sort of a semi-final for the Nobel Prizes in medicine. So since 1945, after the Lasker Awards have been instituted, 96 of Lasker winners have gone on to win the Nobel Prize in Medicine. So these three individuals were declared the winners of this year's Lasker Award for discovering GLP-1. The gentleman on the extreme left and the lady on the extreme right, they played a role in discovering the physiology of GLP-1. And Lotte Knudsen, the lady in the center, is a scientist with Novo Nordisk who helped in the invention of or played a pivotal role in the invention of liraglutide. Now again, what I'll be speaking today is a lot different. Not only we have come a long way since the early discovery of GLP-1 receptor agonists. We now know that the gut neuroendocrine axis, the gut hormonal system, is possibly the largest endocrine gland in our body, secretes a number of peptide hormones. And we have moved to more modern GLP-1 receptor agonists like semaglutide. This is the mandatory disclosure. So when we are talking of adiposity-based chronic diseases, obesity, till a short while ago, we have been considering it like the six blind men and the elephant. We have been reaching for only a part of it, whereas now we know that it's an entire whole. There's a metabolic aspect of obesity, metabolic complications of obesity. There are some mechanical complications of obesity, and there are some psychiatric complications of obesity. And you cannot look at them differently. They are a part of the whole, but since if I take you through all of them, it will take more than 20 minutes. I am taking type 2 diabetes as a microcosm of ABCD, adiposity-based chronic diseases, as a microcosm of the bigger whole. Because we know that type 2 diabetes is something which involves each and every organ system of the body, and at the same time we have the GLP-1 receptor agonists which act at almost each and every organ system of the body, from the brain to the heart, to the pancreas, to the gut, to the muscles. It acts all across the human system. And to take you through the potential benefits of the modern GLP-1 receptor agonist semaglutide, I'll be taking you through different parts of the human system. But first of all, we need to clear some concepts. We need to clear a confusion. If you look at trials, you will find that there are trials with oral semaglutide, there are trials with injectable semaglutide. Now the semaglutide which is available in our country is oral semaglutide, goes by the name of Rybelsus, has a dose of 7 to 14 milligrams once daily. It has an equivalent injectable version which is a once weekly injectable version called Ozempic. So most of the trials that I am going to take you through are either with Rybelsus or a few with Ozempic, because if you look at their pharmacology, if you look at the GLP-1 levels attained after using these agents, they are similar. There is a third form of semaglutide available, not in our country, again in other parts of the world, called Wegovy, which is an anti-obesity agent, which is indicated predominantly or only for the management of obesity, not per se for the management of diabetes. So with this background information in mind, let us first look at a very basic thing. When you are using a drug in type 2 diabetes, you would like it to reduce blood glucose. So how well does oral semaglutide, the Rybelsus that I am talking of, reduces blood glucose? So if you look at all these figures, it can be summed up in 2 or 3 sentences. One, on an average, it reduces blood glucose by 1.4 or 1.5 percent point. It reduces blood glucose more effectively than empagliflozin, sitagliptin, liraglutide. It reduces blood glucose irrespective of the duration of diabetes, and it reduces blood glucose by this similar extent even in patient not controlled on insulin. But when we talk of blood glucose reduction, we also need to know how many patients are achieving target, because we know higher the A1C, more will be the glucose reduction. But what matters at the end is whether you are attaining of target of less than 7 or not. So with monotherapy, 8 out of 10 patients attain target. In patients on insulin, not at target, if you add semaglutide, about 7 out of 10 patients attain target. And compared to empagliflozin, compared to sitagliptin, 1.5 times greater patients attain HbA1c target with the use of semaglutide. So if you look at the ADA-EASD position statement, there are certain drugs which have a very high glucose lowering potential and without causing hypoglycemia, and oral semaglutide fits the list of those drugs. Now, from hyperglycemia in diabetes, cardiovascular disease in diabetes. And talking of cardiovascular disease, we have a superiority trial with semaglutide, injectable semaglutide. We have a non-inferiority trial with oral semaglutide. The superiority trial showed that semaglutide reduces cardiovascular events significantly. The non-inferiority trial showed that it is safe to use in patients with high cardiovascular risk or cardiovascular disease. We all know that with the oral formulation of semaglutide, there was a trial called the SOUL trial for superiority, which was terminated a short while ago. We know that a trial is terminated either because of increased adverse effect or because of increased benefit early on, and we all believe that it's possibly because of increased benefit early on that this trial was terminated. Now, from atherosclerotic cardiovascular disease to heart failure, there is data with semaglutide in obese patients with heart failure and preserved ejection fraction, which shows that it gives significant symptomatic improvement. If you look at the curve here, you have something called the Kansas City questionnaire to look at the improvement in quality of life. There was a 16-point improvement in this questionnaire with semaglutide. For comparison, if you look at SGLT2 inhibitors in heart failure with preserved ejection fraction, there's a 3 to 4-point improvement in this questionnaire. There was an improvement in the 6-meter walk test with the use of semaglutide, which hasn't been seen with any other oral agent till date or injectable agent till date in heart failure. It has been seen only with a structured exercise regime. However, I would like to say that this has been achieved with the higher dose, the anti-obesity dose of semaglutide, not the anti-diabetes or the anti-hyperglycemic dose that we use. So if you look at the good old position statement again, if you have high cardiovascular risk or want to reduce cardiovascular event, semaglutide fits the bill. Heart failure with preserved ejection fraction, we don't have data with the lower dose of semaglutide, but the higher dose of semaglutide has shown benefits in there as well. Now, from moving to from heart to body weight per se, the main factor that we are talking of now. If you look at the data with oral semaglutide, on an average, the heart failure, the body weight reduction has been from 3.5 kgs to 4.5 kgs. Again, it has been seen across the duration of diabetes. It has been seen to be more than that seen with liraglutide. It has been seen even in patients who were on insulin. But what I would like to say is that the dose of semaglutide that we use in our day-to-day practice will give you 3.5 to 4.5 kgs of weight loss. For 15, 16 kgs of weight loss, you need the anti-obesity dose, which is not available in our country. This is the best that we have, but you need to be patient because in most of the patient, the peak weight loss might be seen after 6 months, after 9 months, and it's not permanent. If you discontinue semaglutide, in 2/3 of the patient, the weight comes back as well. So if you go back to the position statement and if you look at drugs which cause significant weight loss, semaglutide is right there at the top of the list. So we spoke of glucose reduction, we spoke of weight reduction, we spoke of cardiovascular improvement. So what if we put them all together? Again, it is said that you cannot compare apples with oranges. So what I'll do is I'll predominantly look at liraglutide and semaglutide because both of them come from the same stable and both of their trials had similar characteristics. For example, in the leader trial with liraglutide, about 80% of patients had established ASCVD, the rest had high CV risk, which was almost similar in the SUSTAIN 6 trial with semaglutide. But if you look at the hazard ratios for the 3-point MACE, with semaglutide, it was numerically much greater compared to liraglutide. In both the trials, the baseline HbA1c was about 8.7. Again, with semaglutide, the A1c reduction was far greater. The baseline body weight in both these trials was about 92 kgs. But again, if you look at the weight reduction with semaglutide, it was twice as much with liraglutide. We know we cannot compare apples with oranges, but if you look at a bird's eye view, the numerical figures are stacked in favor of semaglutide. We next move to kidney disease, because if a patient has diabetes, obesity, heart disease, can kidney disease be far behind? Most of our patients will have kidney disease as well. Now, when we treat a patient with kidney disease, there are 2 or 3 aspects of it. One, is the drug going to act? Is it safe to use in kidney disease? Is the drug going to improve renal outcome? Is the drug going to improve cardiovascular outcome? We know that SGLT2 inhibitors improve renal outcomes but do not reduce blood glucose in patients with renal disease. GLP-1 receptor agonists, semaglutide interestingly, can be used across the spectrum of renal dysfunction, needs no dose adjustment, and shows as good a glucose lowering efficacy as in patients with normal renal dysfunction, normal renal function. And now we have the FLOW trial as well, which shows that it prevents worsening of renal function. It prevents renal death, it prevents progression to dialysis, it prevents deterioration of eGFR. And if you look at the secondary endpoints of this study, cardiovascular outcomes improved as well. There was improvement in 3-point MACE outcome, there was improvement in cardiovascular death, there was improvement in all-cause mortality. Again, these are secondary outcomes. We cannot say these are statistically significant or not, but there was a hint that all of them were to the left of the midline. So again, if you look at the guidelines, I'll now differ a bit with the guidelines, because the guidelines say that in patients with renal dysfunction, you use a GLP-1 receptor agonist after the SGLT2 inhibitor, and if the SGLT2 inhibitor does not take you to glycemic goal. I would now say that you can use both of them together rather to reach your glycemic goal, because it's the semaglutide which will reduce glucose in renal dysfunction, not the SGLT2 inhibitor. And if you look at the FLOW trial, the subgroup analysis of the FLOW trial, the semaglutide benefit was there irrespective of whether one was on an SGLT2 inhibitor at baseline or not. Now, what about stroke? We spoke about the heart. What about the brain? What about Alzheimer's disease? Now, stroke, again, we do not have dedicated stroke trials, but we have an Alzheimer's trial coming up. Now, how can a GLP-1 receptor agonist act in improving Alzheimer's disease? We have had small animal studies showing benefit, and frankly speaking, we still don't know the exact mechanism of action. But what is known is that in Alzheimer's disease, insulin signaling in the brain is weakened, and semaglutide or SGLT2 inhibitors can correct this insulin signaling by generating more of second messenger, cyclic AMP, P13 kinase, which can have a neurotropic effect, which can have an anti-apoptotic effect, which can have an anti-inflammatory effect at the brain. And there are 2 big trials going on in patients with early Alzheimer's disease with minimal cognitive impairment or early dementia in 38 centers across the world in amyloid-proven cases to show whether there can be any benefit with the use of semaglutide or not. Again, we do not have the results yet. They will be available after a year's time. Finally, shifting our focus to the problem which is there in possibly 100% of patients with type 2 diabetes, which is metabolic dysfunction-associated steatotic liver disease. Now, when we talk of MASLD, we often sort of think that it's something innocent. It's something which every patient who does an ultrasound has some fat in the liver. There's nothing to be concerned about it. But if you look at the scenario, we did a trial in 603 patients. We did a fibroscan of the liver in patients attending the diabetes clinic at NRS Medical College. And we found that 1 out of 4 patients with type 2 diabetes in Kolkata attending our clinic had clinically significant liver fibrosis. So it's not only fat in the liver. 1 out of 4 patients with type 2 diabetes in our population already has clinically significant liver fibrosis. Now, interestingly, there are no GLP-1 receptors in the liver. So if there are no GLP-1 receptors in the liver, how can a GLP-1 receptor agonist give you hepatic benefits in MASLD? Most of the fat that is deposited in the liver in MASLD does not come from the diet. It does not come from de novo lipogenesis as well. Most of the fat that you see in the liver, in so-called fatty liver, comes from the white adipose tissue stores. There is hypertrophy of the white adipose tissue stores, there is insulin inflammation there, lipolysis there, release of non-esterified fatty acids which then find a home in the liver. Now when you're using GLP-1 receptor agonists, you are reducing body weight, you are improving insulin resistance, improving insulin sensitivity rather, reducing lipolysis, reducing this transport of free fatty acids to the liver, and reducing fat in the liver. Besides this, you are reducing glucagon levels, which in turn reduce de novo lipogenesis, which in turn reduce hepatic neoglucogenesis. So there are a variety of effects by which a GLP-1 receptor agonist can give hepatic benefits despite the fact that there are no GLP-1 receptors in the liver per se. Now, do we have a trial with semaglutide? We have a phase 2 trial with semaglutide in patients with non-alcoholic steatohepatitis, either having fibrosis stage 1, 2, or 3, but not having cirrhosis, which showed that with the use of semaglutide, there was significant improvement in steatohepatitis without worsening of fibrosis. But when it came to improvement of fibrosis, although in 43% of those getting semaglutide, there was improvement in fibrosis, in about 33% of those getting placebo, there was similar improvement in fibrosis, because of which there was no statistical significant improvement in fibrosis, but statistically significant improvement in steatohepatitis. However, when the investigators also looked at worsening of fibrosis from F1 to F2 or F2 to F3 or F3 to fibrosis, to cirrhosis rather, the semaglutide arm was doing far better compared to the placebo arm. Again, this is a phase 2 trial. We have a dedicated phase 3 trial, the Essence trial going on, which is looking at liver outcomes, biopsy-proven outcomes, and cardiovascular outcomes in patients with MASLD, in patients with fibrosis. So if you look at the spectrum of MASLD, a patient might have a simple steatotic liver disease or fatty liver disease, where weight reduction in adiposity would help prevent further increase in fat deposition in the liver. A patient might have steatohepatitis, where again the leading cause of morbidity and mortality is cardiovascular disease, not hepatic disease, where a GLP-1 receptor agonist can give you cardiovascular benefits. Or a patient might have clinically significant fibrosis, advanced fibrosis or cirrhosis, where possibly a GLP-1 receptor agonist can give you liver benefits as well. If you look at the AACE recommendation, the AASLD recommendation, or the 3 European bodies, the diabetes, liver, and obesity body recommendations, all of them have said in unison with a strong level of evidence that in a patient with type 2 diabetes and steatohepatitis, or type 2 diabetes and non-cirrhotic NASH or fibrosis, there is a very strong reason for using a GLP-1 receptor agonist. And when we think of GLP-1 receptor agonists, I think in our country, for all practical purposes, at this point of time, the only one which is available is oral semaglutide. Now, all of you might be thinking that we have certain drugs for treating MASLD. For example, in our country, saroglitazar is an approved drug. There is some sketchy data with pioglitazone as well. So where does semaglutide come in the treatment of MASLD? What we need to realize is that MASLD treatment will be a multimodal treatment. Just like we treat type 2 diabetes with a variety of agents targeting different pathways, we treat hypertension with a variety of agents targeting different pathways. In the present day and in the near future, MASLD treatment will need multimodal therapy with different agents targeting different pathways. And in this respect, I think that in our country, along with saroglitazar or pioglitazone, the next best option that we have for improving the lives of patients with MASLD happens to be oral semaglutide. Now, we saw that use of semaglutide is allowed in patients with kidney disease. Now, what if you use semaglutide in a patient with advanced fibrosis, but unfortunately the patient progresses to cirrhosis? Is it still going to give benefit? We do not have dedicated data with semaglutide, but we have this propensity matched population data from Taiwan with all GLP-1 receptor agonists put together, which shows that in compensated liver cirrhosis, not in decompensated cirrhosis, but compensated liver cirrhosis, GLP-1 receptor agonist gives you liver benefits, gives you cardiac benefits, gives you survival benefits as well. So possibly, this is a drug which can be used safely across the spectrum of liver disease till there is decompensation, expecting benefits till the very end of its use. So if you look at the spectrum of diseases, the spectrum of conditions related to adiposity or the so-called adiposity-based chronic diseases, semaglutide sort of covers them all. It has shown cardiac benefits. It definitely reduces blood glucose much better than any other agent available. It reduces body weight much better than any other anti-diabetic agent which is available. In MASLD, there are some compelling reasons, cardiac benefits and possible hepatic benefits where you can or should use a drug like semaglutide. We now have data on the renal benefits of this as well, and most importantly, it does not need any dose modification across the range of renal dysfunction. I began with Western scientists. I'll end with our very own fictional Professor Shonku. And I believe the creator of Professor Shonku had a prescient insight. Several decades back, he could see that something is going to happen because two of my favorite inventions of Professor Shonku are Botica indica and Miraculol. Now, you know that Botica indica is something which sort of suppresses appetite. If you take a pill of Botica indica, you can go without meals for several days, whereas Miraculol is a miracle cure for all. It cures a number of diseases, and I believe that with the data that is coming up with semaglutide, it sort of fits both this criteria, appetite suppression and a variety of benefits across the spectrum of obesity-related diseases. Thank you.
Thank you, sir. Thank you, sir, for that excellent deliberation. So the hall is open for questions. Is there any questions from the audience? So if there is none, so thank you, sir, for enthralling us with such beautiful deliberation. And we would like to give a big round of applause for sir. Thank you. So for the next session, we have a topic which are going to challenge the experts, right? For dialogue that matters, I would like to call upon stage Madam Professor Shormishtha Mukhopadhyay, Professor and Head of the Department of Medicine and Endocrinology of B.R. Singh Hospital.
So very good evening to everyone. First of all, I would request to arrange 5 chairs and in the dais so that we can sit and talk very easily with our audience. So our panel discussion, the so-called panel discussion today, the topic is the dialogue that matters, challenge to the expert. So it's a little bit unique rather than the other panel discussions, because here we are more focusing on the questions or challenges from the audience rather than discussion of topics among the questions thrown by the moderator and answers by the panelists. We are more focusing or emphasizing on the challenges and questions from the audience. And the second thing in which it is unique is that there is no definite or clear-cut boundary, because you can ask, the audience can ask any question, of course related to endocrinology and metabolism, to our experts. So although we have not many audiences, but I think the interactions will be better if there is a closed group. So I would request all the audience who are present here to please come in the front rows so that we can interact well. Along with me, there are 4 experts, expert endocrinologists, Dr. Shottam Chakraborty, Dr. Umakanto Mahapatra, Dr. Rajan Palui, and Dr. Rahin Mahatap. So I would request all of them to come to the dais and join along with me. Will you please provide chairs and also hand mics if possible? So please come forward. All are requested to come to the front rows, if possible. I can see Shubhadeep and Arindam are coming forward. Any other physicians who want to come forward?
जितने एंडोक्रिनोलॉजिस्ट हैं उमेश बॉस अपना क्वेश्चन आप खुद ही आंसर करोगे आप ही क्वेश्चन करोगे
So experts cannot challenge the experts. That is the dictum. Okay. So may I ask our audience if they don't come forward? What is your greatest challenge in treating diabetes in your OPD or in your chamber? Can I ask Dr. Mondira Banerjee, because I know that she is treating the patients, particularly the elderly patients and also the employees in OPD. So what are the challenges you face? Just a friendly discussion. She is in my hospital, so I am asking her. Every day she sees lots of patients. Any floor mic? Or you can come forward also. Patient compliance is your main challenge. Compliance in which things? OHA or insulin, or where the compliance challenge is more? Is it really a challenge? Because in railways where you work in BR Singh Hospital, all the medicines are supplied. Still there is a challenge in compliance. You think so? Okay. So any other, in initiation of insulin, anyone can tell what is the challenges in initiation of insulin? Okay, let the audience think of the questions and we discuss among others. Okay, please.
Welcome to the panelists and very good evening to all. So we have facing some problems regarding the sarcopenia in elderly patients with long-standing diabetes. So there are structured exercise programs, protein supplementation, essential amino acid supplements, and the calcium vitamin D supplementation. Is there any pharmacologic therapy you suggest for sarcopenia in diabetes? Thank you.
Dr. Shottam Chakraborty.
So sarcopenia is a part of the natural aging phenomena, and more so when you are having any chronic metabolic disease like diabetes, sarcopenia will accelerate more. Now the first point is strict glycemic control. If you can have a strict glycemic control, that is the first point when you may not arrest the sarcopenia totally, but at least arrest the gross progression of sarcopenia. Now again, in the elderly's long duration diabetes, we understand that these patients might have beta cell exhaustion. So in these areas, we at times we are frightful to initiate insulin. We need to understand insulin is one of the mainstays of treatment as far as long-standing diabetes is concerned. Insulin is an anabolic hormone. Patients who are exhausted, you will find these patients are cachectic. Okay, they have a loss of a lot of muscle mass loss as well, and this in turn increases the insulin resistance. So we need to initiate insulin as early as possible when it is required. But here, while we are talking about initiation of insulin in this context, okay, we all understand by now what is threat culture. I hope everyone understands what is going on. And sometimes in our closed clinics, we also use this threat culture. এর পরের বার যদি কন্ট্রোল করে না আনেন তাহলে কিন্তু ইনসুলিন চালিয়ে দেব। So we in totality should abstain from any sorts of threat culture, and there we need to educate our patients that why insulin is at all required, and then we can move on. So I think this is one of the most important part as far as sarcopenia is concerned. Now, talking of nutritional supplements, do you think that the normal healthy diet which a patient who is taking orally, who consumes, needs any other types of nutritional supplements? I don't think. They are, most of us think that they are for the critically ill patients who are long-term bed-bound. Okay, for example, a healthy, nutritious diet, I don't think we will require any extra supplements whatsoever. Anyone please add?
Yes. Another thing is that the structured exercise which you have mentioned, that should start from little bit early ages. In an elderly patient, you cannot start structured exercise at that time, at say 70 or 75 years of age, but it should start early. And it has been already discussed earlier by our previous speakers that in majority Indians are dependent on carbohydrate foods. Mainly 64% of calories come from carbohydrates, and many patients, elderly patients and particularly the housewives, they are deficient of protein. So naturally sarcopenia is very predominant in our society. Dr. Pali, please.
That what ma'am is saying is true. Like some of the time we see when we are saying some diabetic kidney disease, we are restricting the protein to some extent. When we send to the dietitian, then we came to know he or she, the patient may not be even taking that amount of protein normally in that particular diet. That is common in our part of study. So maybe we can see whether the patient's intake of protein, whatever in their regular diet, whether that is adequate or not. Another thing that what ma'am was telling, resistive exercise is very much important. Like whenever we are telling the patient, if even a 30-minute brisk walk, whatever we commonly say, that is not going to give any benefit from the sarcopenia per se. So few normal exercise, maybe 1 kg or 2 kg if the patient can, and to rotate the different group of muscles doing exercise, household items like 1 kg water bottle or something like that, that can give them some help in building or preventing muscle mass.
So in continuation, in continuation this question, some of our patients who are on SGLT2 inhibitors do complain of sarcopenia. I'm losing weight. Even if the absolute weight loss is 3 kg, still they feel their muscle mass is losing. So what do you suggest in this scenario? Should we stop SGLT2 or we continue? How do you counsel the patient?
First, what do you suggest?
I am asking the experts.
No, you are also an expert. What do you suggest?
We try to counsel the patient that it's a beneficial drug. You increase your protein intake and continue the SGLT2. But I am to hear from you.
So basically, when you have any agent which will cause fat loss, there will be shrinkage of the skin. There will be an imaginary thing that I am getting older. So that is somehow eluding, and people might think, and patients will also complain, everybody is telling, are budo hoye jaccho. So we need to, this is the point that we need to give time to the patient. That the medication which we are using, that is cutting off your fat stores, and that will normally cause some shrunken skin. So again, go for resistance exercise. That is not going to harm your muscles. Go for resistance exercise. You will gradually build up your muscles and you will have the glaze. That's all.
And you have to counsel about the benefits of the SGLT2 inhibitors, its cardiorenal protection, etc.
Yes.
And that definitely it's much, much more than the harm it causes. So
sometimes if the patient is not elderly, I try to add a pioglitazone in his regime. So sometimes I've seen that with that agent, patient somewhat better, but I'm not sure of any guideline. But what is your opinion on that? Pioglitazone.
Wait, like what is the mechanism
Subhadeep,
you're thinking of?
So, elderly patient or young patient?
Young patient only.
Young patient. So, in young patient, pioglitazone will increase the body weight. That may be increase
the patient has
tissue.
lost 5-7 kgs of weight, very much concerned, wants to gain weight in that situation.
So yes, pioglitazone will increase the body weight, increase the adipocyte. So there will be compensation.
So, what is the mechanism? Why should
See, basically with pioglitazone, your subcutaneous fat is redistributed. Yeah, so that's why they are feeling that they are getting old and their skins are shrunken. That can be counteracted.
So if optimal glycemic
pioglitazone, there are good fats which are goes to the
I think
subcutaneous.
it's not our duty to only to please the patients about their figure or structure, but we should always counsel about the benefits and harms and the side effects of the drugs. So one who wants to get thinner, we will add them only SGLT2 inhibitors, and one who wants to gain weight, we will add pioglitazone. This is not the dictum, but other effects should be considered as well. That is my point of view.
So yes, madam. Yes, madam. If glycemic control is not achieved, at that time we can consider pioglitazone. Otherwise, only for weight gain, we should not add pioglitazone.
This is not accepted. And
Dr. Mohapatra, good point. This is the first thing if patient is not achieving glycemic control. Let the delve into the what is happening with the SGLT2, what are the scientific basis of adding pioglitazone, is there any scientific evidence? Let me explore the things. What happens? There is a fat loss, and the fat loss happens where are the fat pads or fat bed depots. Most important fat pad which other people see is your buccal fat pad. That's all. Yes, patient will complain, my waist size is out because love handles are gone. But what happens whenever you are adding pioglitazone, you are doing three things. I counter your point, it causes weight gain. I counter. Weight gain with the pioglitazone composed of two things. Interstitial fluid, hardly 0.5 to 1.5 kg. That is usually encountered by low-dose diuretic, or as if patient is on SGLT2, that doesn't happen. Second compartment of weight gain comes from beneficial part, that is subcutaneous fat. That serves two purposes. Cosmetic, that is not our duty. But our duty is superficial peripheral fat, which serve two purposes. It improve your insulin sensitivity. Because peripheral fat, I do have my own papers published even in Nature Communications, which has shown visceral fat is related to insulin resistance, while subcutaneous fat is protective. So it improve insulin sensitivity, it control your glucose, there is no weight gain, and it improve cosmetics. But the first thing are two. One, patient should be young. Second, glycemic control should be your target. That is the scenario. There are lot of papers which has used combination of SGLT2 with pioglitazone. There was no detrimental effect on bone mineral density, which is usually a theoretical concern. No weight gain. Yeah.
Thank you very much for your input. Now, moving from diabetes to thyroid, how many among the audience do you prescribe only TSH for monitoring of thyroid disorders? Only TSH. I can see PRs for monitoring of thyroid disorders, I am telling. How many of you? And how many of you use both FT4 and TSH, or all the three components, FT3, FT4 and TSH? Thyroid disorders as a whole. T3, okay. For hypothyroid, you advise only TSH, okay. All hypothyroid you use only, I'm just asking
Yes,
to the
yes.
audience in the back. Do you use TSH only or you use all the things, all the three components, T3, T4 and TSH? T4, TSH, okay. So may I ask Dr. Palui that what is the problem associated with monitoring with TSH only in hypothyroid patients? Do you face any problem, or do you receive any patients who are monitored with TSH only and they have come to us with some problem or some fallacies? So can you highlight this?
In case of hypothyroid patient, like the dictum is for initial diagnosis, we need to do both TSH and free T4 because we should not miss central hypothyroidism. Whenever we are doing only TSH, we can miss central hypothyroidism. And during monitoring also, definitely, if the patient is a known case of hypothyroidism long term on a stable dose, we can do with TSH, but in sometimes we need to do TSH and FDT for both. And for the initial diagnosis, it is very important to do both together so that we do not miss any central hypothyroidism.
So very well said, but one thing is that in case of central hypothyroidism, sometimes L-thyroxine replacement is given, and when the patient goes to some doctor, erroneously sometimes the dose of L-thyroxine is reduced by seeing low TSH. So in case of secondary or central hypothyroidism, we always have to have T3 and T4 in our hand, because TSH will always be low or inappropriately normal, or sometimes it is a little bit high due to bioinactive TSH. So when you are treating any central hypothyroidism, say any hypopituitarism, panhypopituitarism, or any patients with operated macroadenoma, and those patients go to you, something you want to add?
Just one thing, just for the one thing, that whenever we are thinking of central hypothyroidism, before starting levothyroxine, you should always check cortisol, like to check the HPA axis before starting, whenever you are suspecting central hypothyroidism.
Exactly. Next, if any question from the audience, you may please ask. All the questions are asked by Dr. Shubhadeep, or you are commenting. You are commenting.
Your comment.
No,
you are
I'm
expert.
asking, I'm question. Actually, this is a situation where I do not know the answer before, and I'm asking. Some of our patients nowadays are complaining of increased sweating. So patients are diabetic, well controlled, maybe hypothyroid, well controlled, not postmenopausal, but age is 35, menstruating regularly, females. Anxiety level somewhat there, but sleep is well, but still complaining of severe sweating. Even when they are under the fan, that time also they are having severe sweating. And this is happening for last 1 to 2 years in my practice. So how to approach them?
Due to global warming?
I'm not sure, because
any one of
that sweating is not every time with them. Some of the time they are having severe sweating, then again they are okay.
So you want to say that there is some autonomic problem?
Maybe, I'm not sure.
You are not sure. Any of our panelists? Will enrich the knowledge of Dr. Shubhadeep Pramanik.
Whether the patient is male or female?
And not very menopausal or postmenopausal, you have mentioned.
Menstruating or not?
Not, yeah. So I think there is no clear-cut answer to this. You have to assess the patient individually.
Your opinion, what is your opinion?
Have you done the thyroid function tests of these patients? They are not thyrotoxic.
They're either taking, some of the patients are hypothyroid, but on treatment controlled, but still this type of symptoms.
This is a common statement which many patients complain, but I usually ignore them if there is thyroid function is normal. I don't know whether all of you ignore or not.
They don't have history of spale, non-hypertensive. How to investigate them, what to do.
So hyperhidrosis investigation.
Yes.
Okay, any of our panelists? Anyone from the audience? There are so many audiences in the endocrinologists in the audience. Pradip Da, Dr. Pradip Rai Chaudhuri, our teacher. So he may, yeah. Can you join with us? Can you say something about this investigation of hyperhidrosis? The question.
So regarding hyperhidrosis, we in internal medicine ask two questions.
Yes.
Do you have fever regularly or do you have night sweats?
Yes.
If the answer is no to both, then probably we may do few basic tests, basic metabolic panels as you have told. Otherwise, we just follow them up, that whether they are having weight loss or any red flag signs. But if they are having fever,
yes,
or they are having night sweats, then we
sweats,
need to investigate them.
Definitely.
So idiopathic hyperhidrosis, just follow up. If these two symptoms are present, definitely they need detailed follow-up.
I think most of us follow this decorum only.
Yeah.
Hello.
The comment may not answer Subhadeep's questions, but we need to look at the pattern of hyperhidrosis. For an example, in patients with long-standing diabetes, segmental hyperhidrosis,
Hemihyperhidrosis, gustatory sweating,
is not
etc.
uncommon.
Yes.
Despite having normal glycemic status, they may have segmental hyperhidrosis.
Yes.
Palmoplantar hyperhidrosis, quite common, probably idiopathic, needs symptomatic treatment. If these are not there, probably it's a case of idiopathic hyperhidrosis.
Yes,
One comment.
Yes, Dr. Ajitesh Rai.
Yes. So one comment is probably we do have some experience regarding this. A very subtle form of acromegaly in the very initial days, they may complain of hyperhidrosis. If you see properly, you may miss something, but you may find some subtle features of acromegaly, and they may present with hyperhidrosis. So if a patient complains of hyperhidrosis, you may ask the patient to come after 6 months, just examine patient properly. After excluding all these differential diagnoses, definitely, because it is extremely rare, but it could be. Okay. And second is if the patient is hypertensive, whether the patient is hypertensive or not. Sometimes in pheochromocytoma, generalized sweating is also increased. So patient is hypertensive, patient is getting drugs, but hypertension is not controlled properly. In that case, definitely you have to have a thinking that patient may harboring a occult form of a subtle form of pheochromocytoma. So these are the very rare diagnoses, but yes, definitely when patient will be referred to us, the rare disease will come. So we have to
follow the older dictum of cold sweats and warm sweats, because in thyrotoxicosis, anyone is talking? Oh. So, in case of anxiety neurosis, we may have cold sweats.
Yes, yes.
And in case of thyrotoxicosis, we may have this warm extremities. So that is a differentiating point. And of course, we will exclude these endocrine diseases as well, and systemic diseases as well, like night sweats in tuberculosis or in a lymphoma, B symptoms of lymphoma, etc. So that's a very good point. Good question raised by Dr. Shubhadeep Pramanik. So again, coming to thyroid, because diabetes and thyroid are our common disorders as most of us face in our clinical practices. Biochemical thyrotoxicosis, I mean low TSH, often these patients come to us when they are already have been prescribed by anti-thyroid drugs by some other doctor. So my question to Dr. Rahim Mahata, that how will you approach these patients? No investigation has been done. The patient had weight loss, hyperhidrosis, and there was a plus minus goiter and no eye sign, and this patient went to some practitioner, and based on the symptoms and based on low TSH and slightly raised FT3 and FT4, these patients have been prescribed anti-thyroid drugs like carbimazole or methimazole, and the patient has come to you. So how will you approach this patient? Any message to our doctors? Pardon, sir? SSRI, yes. That's well taken.
Now I am coming to the questions. Patient with low TSH, sometimes given neomarcazole, but there are conditions, that is thyroiditis. In that case, that is there is no need of anti-thyroid drug, neomarcazole. So first, when you are getting the low TSH, then the next step will be to look for the T3 and T4. And if the T3 and T4 is elevated or normal, then it is called as the overt or subclinical thyrotoxicosis respectively. And the most common causes of thyrotoxicosis that we may encounter, that is the most commonly Graves' disease and the thyroiditis, where we can get the non-nodular thyroid swelling. To differentiate these most common things are, first clinically we can differentiate most of the time. In case of Graves' disease, if there is presence of orbitopathy, then it is fine, it goes in favor of Graves' disease. If the symptoms is of quite longer duration of symptoms, if it is more than 3 months, 4 months, then it is goes in favor of Graves' disease. And the thyroid swelling, if the swelling is of diffuse, homogeneous, soft, and if there is presence of thyroid bruit, that it goes in favor of Graves' disease. On the other hand, if the symptoms duration is short period, if it is less than 2 months, less than 3 months, or if there is presence of local symptoms in the form of sore throat, neck pain, dysphagia, or on palpation, if the thyroid gland is firm, tender, or hard, then it goes in favor of thyroiditis. So, in case of Graves' disease, the treatment modality will be different. In case of thyroiditis, the treatment modality will be different, where there is no need of anti-thyroid drug in case of thyroiditis.
That is a very good message, because all cases of thyrotoxicosis does not need treatment. That is to be conveyed to all the physicians and general practitioners, that when they come with anti-thyroid drugs, sometimes the whole thing is jeopardized, because we cannot go for any technetium 99 per technet scan or like that, because already the anti-thyroid drug has been used and the uptake has been modified. So it is our duty as a clinician to differentiate the cause of thyrotoxicosis rather than to treat thyrotoxicosis from the beginning. Is it like that? Okay.
Yes, ma'am.
Actually, Dr.
Yeah.
Yes,
So
Dr.
I want to
Mahapatra.
add to one thing. Suppose if the patient is asymptomatic and there is no clinical finding, first we have to consider assay interference, biotin interference. Drug should be stopped for at least 1 day, and the test should be repeated. So this should be the first approach. If the patient is asymptomatic, then assay interference and a repeat of the TSEs should be done first. Yes.
Yeah, because this happens in many patients, because somebody has some hair problem, hair fall, so some dermatologist used to give this biotin molecule and test for the TSH, and TSH comes low. So,
Dermatologists always go for TSH. This is their first investigation, everything, and they come with a 6 TSH, say 6 or 6.5 TSH, and the patient expects that the hair fall will stop if they are treated. So that is a common problem faced by most of the clinicians.
One message should go to the general practitioner, that alopecia that happens in hypothyroidism is generalized alopecia. It's not only the scalp alopecia. So this is one point. And number two is that the response after this carbimazole or methimazole therapy is very important, because somebody has suppose started with a TSH of 0.05 and they don't have any T4, T3 report or no clinical sign suggestive. Now put on some neomacazole suppose, and come with a TSH of suppose 24 after 2 months. So definitely that gives a suggestion that the patient have thyroiditis rather than a Graves' disease.
It's a retrospective analysis.
So
yes.
that's also very helpful in
that
patients.
we have to do in our clinical practice. So from the, yes.
Ma'am, I have 2 questions on vitamin D. In general population, how frequently you suggest screening for the vitamin D level? And my second question is, now many normal healthy adult patients, they come with vitamin D reports which show they have no complaints, no myopathy or no physical sign, but have a biochemical report of the vitamin D that's show deficiency or insufficiency. So what is your recommendation to treat this?
Okay.
Thank you.
So coming to our panelists, who will deal with Dr. Pali? Vitamin D. Vitamin D deficiency, asymptomatic and incidental. This is your question, no? Screening frequency?
Screening frequency, as of now, it is none of the society now, when young, healthy individual, until and if they don't have any features suggestive of metabolic bone disease, either in favor of any fragility fracture or osteomalacia or some clinical symptom, we do not recommend routine screening for 25-hydroxyvitamin D. Now, once done, most of the patient, whatever we come, patient already comes with the report. So there is, even if you go by the guideline, it is deficiency and insufficiency, though two different terms are there. Insufficiency is much more common, and somehow, definitely, as we are testing, we are finding, and even if you in this room, if there are some 50 people, if you do, I think more than 50% may have some form of insufficiency or deficiency. It may be due to some extent because of our changing habit, less sun exposure, and we are more the work and everything, we are in the internal lack of exposure to the natural light. But if they are diagnosed, then we have to treat it according to the guidelines. But routine screening is not recommended in apparently healthy individuals.
Do you feel that the cutoff value of vitamin D should be, it should be modified, particularly in our...
I think 4 years back, one excellent editorial was there in NEJM. That also, like, whatever we think of cutoff, somewhere cutoff in between whatever is there, 12 to 15 may be the right cutoff to diagnose, rather than this 20 and 30 nanogram, what were you using? Anything?
Yeah, actually, you have to mention that do you recommend universal vitamin D prescription in all the patients? Because you know, as per the prevalence of vitamin D deficiency, it's very high. Even in we have done the studies from SSKM that shows the rural population who are actually walking under the sunlight, they have also a very high deficiency of vitamin D, high proportion. So do you recommend at least after 30 years of age, some, especially the woman, must have some vitamin D supplementation?
If the universal treatment is restricted to what it should be, like 8 weeks or 12 weeks therapy, then it is fine. But if the universal treatment, sometimes we see from, not from endocrinologists, but mainly from those orthopedician and other, that they are getting injection after injection, then it can reach to toxicity level. So one course of vitamin D supplementation, maybe one course of treatments of 8 weeks, maybe you can be rational if you think of the cost effective. The cost of 25 hydroxy vitamin D screening is
universal therapy, you are meaning fortification of food. Do you mean that?
No, at least 60,000 units once a month.
That is the normal.
So that is a form that at least gives some bone protection.
And usually those patients who have low vitamin D, after stopping the drug, again the vitamin D level is lowered. Usually.
But even after therapy, we usually do not suggest repeat testing for vitamin D.
No.
So that is also
Usually
not recommended.
The problem
mostly.
nowadays, the problem is that there is some package system. So all the patients come with, even in the male patients, we see, female patients, we see those copper, manganese, zinc, or but what else I can't remember. But among them, definitely there is vitamin B12 and vitamin D is there. So if there is documented vitamin D deficiencies there, and if you don't treat them, then the patients are disheartened. So I think there is no harm to give them for once.
And ma'am, vitamin D is not only for the bones. There are also pleiotropic benefits of vitamin D, anti-cancer, and there are many
extraskeletal effects of vitamin D. And for the women in a reproductive age group also, they need some vitamin D.
So one is what supplementation we are talking, and what we often see is 1 lakh unit of injection vitamin D. So there has been multiple evidences, multiple studies where it has been shown that these direct injections of 1 lakh unit, they cause much more fluctuating levels of vitamin D, and most probably they are not recommended in routine clinical practice as well as in hospital patients. So I think it's time that we move off from this 1 lakh unit of injection and go for the regular supplementation which we were discussing, if at all we need a supplementation.
Oral vitamin D I have not seen any hypervitaminosis D with oral vitamin D. It only happens with injectable, mostly used by the orthopedicians. So I think we have come at the end of our panel discussion today. So there is another common topic I would like to ask Dr. Mohapatra, that often the patients come to us with a slight, particularly the diabetic patients with slightly raised triglyceride levels and slightly lower HDL levels, and they are very much concerned about that. So what is your approach to the patients? Because the patients want that they should be treated for that much of hypertriglyceridemia. Please.
Absolutely, madam, right. Most of the patients comes with a lipid profile report, with a LDL cholesterol of 200, TG of 200 to 50 like that. So if triglyceride is more than 500 milligram per deciliter, the patient should be first patient should be addressed to have optimal glycemic control with lifestyle modification, like dietary modification, regular physical activity. Secondary cause of hypertriglyceridemia like obesity, metabolic syndrome, drugs that increases triglyceride level, chronic disease like chronic liver disease, chronic kidney disease, nephrotic syndrome, mainly hypothyroidism should be addressed. So if LDL cholesterol is above the goal, above the target level, then statin should be started. With statin, if LDL after LDL cholesterol becomes normal, if the triglyceride remains elevated, then we can start ecosupplement ethyl or fenofibrate. If triglyceride level is in between 175 to 499, so secondary cause of triglyceride should be addressed and should be managed. So
that's a message to be conveyed, that mild hypertriglyceridemia is not always, doesn't need to be treated, except that it is too high, like more than 500 milligram% to prevent pancreatitis, and rather our LDL goal is more important. So that should be counseled that patients should be counseled about that. So I think we have enough discussion today. If there is no other question from the audience, then one question from Dr. Piyas Gargari, I think, or comment. What is it?
Ma'am, it's a question. Suppose a patient comes to us with a frank Graves' disease of free T4 level of more than 7.7 and TSH suppressed, TT3 level is much more elevated. And we have established a diagnosis of Graves. After we started medical management, on the next day, the SGOT-PT level raises to around 240-300 level. So what will be our next step of management?
What is the age and sex of the patient?
21 years, male, no orbitopathy.
Okay, so Dr. Rahim Mahato, you were dealing with thyrotoxicosis, that's why you are...
The level of SGOT-PT?
240 SGPT at 320 SGOT.
If it is likely it is in between of 1 to 3 times.
5 times. It's
if more than 5 times. If more than 5 times, then you have to stop. In case of, although it has been written that is cross-reactivity in between the neomarcazole and propyl thyracil, but in this case may be considered, and
so better in this case, better in this case to stop it first, absolutely, and we have to give the time to normalize the liver function test, but and to symptomatically treat with beta blockers and this thing all. But and when
let me clarify the question what PS has asked. Somebody is not get the question. It is the day 1 of drug. After 1 day, SGOT-PT is 240. So it has to be clarified. It is not drug induced actually.
Yeah.
PS Gargari was asking,
actually, the first day it was 240, 320. It was repeated after 3 days, not but another. After 3 days it was raised. After 7 days it was also raised.
That means you were saying it's a pre-existing some liver disease is there.
This was the question, because Graves' disease itself is associated with liver dysfunction. The question is whether he should continue or not, because in the literature it is said if it is less than 5 times, that is Graves' disease induced hepatotoxicity, continue the ATD because it may help. But the here catch is it is already 5 times upper limit normal, so you have to rule out other causes of hepatotoxicity, viral hepatitis and others, preferably not to, because you are going for a legal aspect. A very well established side effect of ATD. PTU has a more hepatotoxicity.
Yes. Fulminant hepatic failure is more common with
so
PTU.
You are not going. You are going for straight male. Go ahead. As first point is
Alternative
T4 level is very high. So that predict. I want to know what was the goiter size. Male and free T4 level is very high. He is going not to respond to ATD first. You should calculate the great score. Go for radioiodine ablation.
And my question is, this is done, but had it been a case of DILI, so drug-induced liver injury, so should we stop the thianamides and started propylthyracil, or should we go for lithium, or should we go for surgery?
No, I think a few things should be clarified. First of all, autoimmune hepatitis is what sir has told. Autoimmune hepatitis is common with Graves, but there are so many markers of autoimmune hepatitis which can confirm the disease, whether it is autoimmune hepatitis or drug-induced hepatitis. One day is not enough to raise the LFT transaminase level to 250 or 230, I think. There may be previous some liver injury or liver disease is there. And the second thing is that first of all, if there are so much raised transaminase, I think personally that the drugs should be stopped. We have to wait. But because fulminant hepatic failure can kill the patient, but if there is no arrhythmia or anything, any cardiovascular problem, then thyrotoxicosis per se can wait. So we will first stop the drug, and after that we will reassess the patient after 7 days or say 14 days. If the liver function test is persistently high, we will think of other diseases also, and if it gradually decreases, we will go for alternative therapy like radioiodine therapy, because he is a 21-year-old male. Okay, so this is my opinion. Our panelists have many other opinions also, and Dr. Rana Bhattacharya will now the expert of the experts. He will give the opinion.
No. Basically, I would be a bit uncomfortable with radioiodine therapy with such a high T4 level, because hepatotoxy may even further be precipitated and likelihood of storms. What I would be comfortable with, to start with lithium, number one, and counsel the patient to get admitted, start iodine, and do thyroidectomy as soon as possible. So that would be possibly the safest option here. And lithium usually up to 300 milligrams thrice a day, and then depending on the adverse effect profile, you can adjust the lithium dose. Plasma lithium level is not required typically, because the dose needed for psychiatric treatment, so that's different. Here we are giving for a very short term, not a long-term therapy. So short-term lithium is helpful, but not very potent. It usually cannot block.
Release inhibitor, naturally it will act. Yes. So that's a very good option. If there is no other question from the audience, and also if our panelists are satisfied that Pias has more questions? No. Okay. So we are now concluding our interactive session, and I would like to thank our panelists, Dr. Shottam Chakraborty, Dr. Rajan Palui, Dr. Umakant Mahapatra, and Dr. Rahim Mahata for excellent expert opinion of the audience questions. And I would thank our audiences also, and the endocrinologists of the dais who have given their input in our discussion today. So thank you all, and I would like to conclude the session.
Thank you. Thank you, the mentors, for this excellent deliberation and excellent discussion. Probably it was one of the liveliest discussion in the whole Crescendo today. So for the next session, the brainstorming part, I would like to call upon stage Dr. Devaditya Das from IPGMER Kolkata, who will be enriching us with his lively set of questions.
Thank you, everyone. I would especially like to thank the organizers, Rana sir, Partho sir, for giving me this opportunity to conduct this quiz session. This is going to be an audience quiz, but from what I see, there is not much of audience left. But still, whoever there are, it is technically open to all, but the question levels are mainly set for medicine postgraduate trainees, not for endocrinologists, but and I would request, the format would be, there are 15 questions, and it's not that I ask the questions and you shout out the answers. It is preferable that you get hold of a piece of paper, whoever wants to play, and if you can come forward, it will be better for us. And after the 15 questions are over, we can, the participants can exchange the answer sheets and mark them, and accordingly, whoever gets the top 3 highest marks will be given the first, second and third prize respectively. It is preferable that medicine PGTs take part in this quiz, but if the numbers are low, I think with sir's permission, can we make it open to all? Although the questions are mostly of, questions are really easy, I would say.
Other than members of organizing committee and endocrinologists, I think they should be excluded if possible.
Sure.
Because you have made mainly for physicians, right?
Yes,
so
sir.
physicians
Yes, sir.
should participate.
Yes, sir.
And
So-
before starting, just ensure that everyone has a paper with them.
Yes, I would request if anyone from the back are willing to take part in the quiz, they can come forward and with a piece of paper if possible. And preferably, like sir said, it is meant for physicians. The toughness level, if you want to say, is based on PGT level only, with 1 or 2 or 3 maybe a bit difficult questions. But then it will depend upon how many are there, and we can like mix and match. তোরা সামনে চলে আয়, যদি খেলতে চাস সামনে চলে আয়, বেটার হবে। হ্যাঁ, there are prizes for first, second and third position, so and the prizes, there are really handsome prizes, so cash prizes, yeah.
And it's your discretion whether postdoctoral trainees are allowed or not. So it's your discretion. You know the question level, we don't.
Sir, postdoctoral trainees will have an advantage over MD medicine trainees. There is no doubt about that. But there are
in that case
trivia questions also. It's a mixed bag of like not core endocrine questions, but there are some 3-4 questions which are. I think, sir, we can make it open for all. But
so it's your final decision is yours.
Okay, I think it's better. It's open for all PDTs and PGTs. But not people who have passed DM Endo. I would request them from refraining from this to refrain from this quiz. But physicians, even elder physicians, if they are willing, they can take part. It's not a problem. I've mostly tried to keep trivia-based questions which can be answerable by anyone and everyone. And there are a few questions where PDTs will have upper hand, but I think they can take part. Not very, the difference is not very huge. So everyone has got a piece of paper, I hope. Shall I start with the questions? Okay. Sir. I would request the sir's organizing committee to declare what the prizes are, and that maybe then.
It's not only the prizes, just a revision of the rules as well, because I myself am also an ardent quizzer. So again, there will be 15 questions asked by Dr. Devaditto. You'll answer all those 15, numbering 1 to 15. Please write your own name. Please write your phone number as well. And after finishing asking the 15 questions, he'll be giving out those 15 answers. Before he gives out those answers, you will have to exchange your sheets, and we do it randomly, not with the person sitting just beside you, but try to do it as randomly as possible, because everyone here is playing for himself or herself, because for the first prize we have rupees 5,000, for the second prize we have rupees 3,000, for the third prize we have rupees 2,000. And it's just a matter of minutes that this quiz is going to happen.
Exactly, and so like I can see, I think maybe some teams of 2 have formed spontaneously, but again, as sir said, that this is a lone wolf quiz, every man or woman for himself, and the prizes will be like that only. So answer carefully and be a little selfish, I would say. Yash, shall I start?
Anybody else wants to participate can come forward.
Okay, so let us start. We have a timeline also which we have to follow, and So this is Crescendo 2024 quiz. So let us start with the first question. Okay. So the first question here is in your screen. This seminal paper was published by one of the pioneers in endocrinology, Dr. Fuller Albright, and his students. You have to give me the name of the first author, one of his students, which has been blanked out. Although we know Dr. Fuller Albright to be a pioneer in the field of calcium metabolism, he has delved into various aspects of endocrinology as a whole. And this was one of the landmark paper published in JCEM, syndrome characterized by gynecomastia, A spermatogenesis without A ladigism, and increased excretion of follicle stimulating hormone. The authors are respectively Harry F. Blank Jr., Edward C. Riefenstein, another prominent name in the field of endocrinology, and of course, Dr. Fuller Albright. So a pretty straightforward question to start off. You have to just give me what is there in the blank, or like you can write the full name if you want. Okay, I'll move on to the next question. I think this is very easy and straightforward. No need to give any more time. So this is, please read carefully. This is question number 2. So there were several outbreaks of X, and it was attributed to a practice which is now banned in the US called gullet trimming, where meat in the neck region of slaughtered animals is ground into a food Y. Because this tissue Z is located in the neck, it is not unusual for gullet trimmers to get abundant amount of Z into the food Y. People and presumably pets that eat such Y, which is the food, can get a very high dose of Z, which is the tissue or the organ, sufficient to induce a certain form of a disease. And this was reported by Hedberg and colleagues for the first time, and then it has been reported again and again in various journals. And the Hedberg and colleagues, they described an outbreak of X in Minnesota and South Dakota that was traced to Z contaminated by Y. Sorry, Z contaminated Y. Y is the food, and that has been contaminated by Z. A total of 121 cases were identified in 9 counties, with the highest incidence in the county having the offending slaughter plant. The patients complained of sleeplessness, nervousness, headache, fatigue, excessive sweating, and weight loss. You have to give me X, Y, and Z. If you can get all 3 right, you get 10 marks. And if you get less than 3 right, 3 marks for each X, Y, and Z. So X is a disease, Y is a food, and Z is a kind of a tissue or an organ which was ground into the food Y. And I'll just show you a screenshot of the paper that was published in 1987 reporting this outbreak of this disease caused by consumption of bovine something in ground beef. So this is a question. This is a comparatively long one. I hope that everyone has got the chance to read the full question, and I'll move on to the third question of this evening. Another descriptive question. Lambert Adolphe Jacques Quetelet was a Belgian astronomer, mathematician, statistician, and sociologist who founded and directed the Brussels Observatory and was influential in introducing statistical methods to the social sciences. In his 1835 text on social physics, in which he presented his theory of human variance around the average, with human traits being distributed according to a normal curve, he proposed that normal variation provided a basis for the idea that populations produce sufficient variation for artificial or natural selection to operate. In terms of influence over later public health agendas, one of Quetelet's lasting legacies was the establishment of a simple anthropometric parameter, which is still used in modern applications and referenced in the development of many consumer-based products. You have to tell me what we are talking about. This statistician, astronomer, a polymath, basically, was famous for his contribution in statistics as well as social sciences, and he devised something. You have to tell me what that thing is. This is picture of Adolf Quetelet, and he gave the concept of the average man. And he is also famous for something else, eponymous thing, which you may know by another name. Anything will do. If you can give the eponymous name, or like the thing which we usually know it for. Fairly straightforward question, I feel. I'll move on to question number 4. Again, a snippet from a journal published in none other than our very own Indian Journal of Endocrinology and Metabolism. Part has been blanked, and it's written, did he suffer from the disorder of the hypothalamus? In this article, the authors described a certain Ramayana character to be having a disorder of the hypothalamus. They argue that the features exhibited by the character in the epic resembles Klein-Levin syndrome, which is considered to be a hypothalamic condition. You have to guess which character are the authors are talking about. If you need a hint, I think this is also very straightforward, but if you need a hint, this is what Klein-Levin syndrome comprises of, the clinical features of this syndrome. Again, these should be very straightforward for endos, but like these have been kept, keeping in mind the physicians to be the participants. So another straightforward question, you just have to tell what the blanked out character name of the character is. Okay, so question number 5. So I think we are all familiar with keto diet. Here is a newspaper article raising the alarm that a certain actress's death was due to his extreme obsession with this fad, this keto diet fad, and it was blamed for her eventual death. Now we all know what keto diet is. I think we all ought to know, and it has become a fad for many for achieving a quick weight loss. But you have to tell me what this ketogenic diet was originally devised for. It was not devised for weight loss. It was devised for something else, and then it became a part or a option for using diet as a method for weight loss. So you have to tell me what it was originally devised for. So this was question number 5. I'll move on to question number 6. See the picture carefully. I'm talking about a hormone, X, which is predominantly made in the adipose cells and enterocytes in the small intestine that helps to regulate energy balance by inhibiting hunger, which in turn diminishes fat storage in adipocytes. And it acts on cell receptors in the arcuate and the ventromedian nuclei of the hypothalamus and certain other parts, and also the dopaminergic neurons, consequently mediating feeding. And this was an experiment where it was shown that there has to be a factor, a hormonal factor, controlling the obesity, where two mice were joined together, and one was obese, one was lean weight, and then when they were joined together, this factor influenced each other, and consequently one of them lost weight. So when the OB mice, which is obese mice, was joined with the lean weight mice in the last picture number C, actually this helped the mouse get, the obese mouse get even more lean. So you have to tell me what this hormone is, which is derived from the Greek word for thin. So this question wrongly has also been marked as question 6. Anyway, I'll go on with the question. Another straightforward question. Pfizer, the multinational pharma company, came up with this drug by accident. They were trying to use it for something else, but noticed a strange side effect, which later made them repurpose this drug for a different condition. They named the drug X, which according to popular belief is derived from the Sanskrit word for tiger. You have to give me what X is, what the condition it was originally tried for, what condition it has been repurposed for, and X is a brand name given by the company Pfizer. What is the name of the original molecule? So 2.5 into 4, something related to endocrinology. The brand name has been derived from the Sanskrit word for tiger, and it was originally being researched for one thing, and it led to a discovery of something else. I think there are a lot of clues in that, and it's pretty straightforward question for regular quizzes. And so there are part marks. If you can get part right, you will get the part marks. So let us move on to the next question. Again, a very straightforward question. You can see 3 pictures. You have to connect. You have to name the scientist, and you have to give me what he discovered. You can see the scientist picture of the scientist, Asian fellow. Then there are pictures of some microorganisms of certain shapes. So, and something was derived from these microorganisms, which you can get a hint from the picture on the right. The scientist died recently, I think in early this year or just last year only. Okay, so 5 plus 5 for the scientist and his discovery. Question number 8, I'll move on to question number 8. There's a map you can see, and a locality is blanked out from this map, and you have to identify the locality with which a specific type of diabetes has been associated. It has been called by many names. It has been called temporary diabetes in adult Nigerians, atypical diabetes, then a certain diabetes in Afro-Caribbean patients, type 1.5B diabetes or diabetes type 1B. And now it is known mainly as DASH diabetes since 2002, where a review was done regarding this disease. But colloquially, this disease gets its name from this area. You can see some, I hope you can see some places named there, Kensington, then Brooklyn, where you can get a hint where this area is. So I'll move on to the next one. Again, a bit of description for this question, straightforward for endos, but I think it will be a bit challenging for physicians. So the idea of using X for the treatment of type 2 diabetes came while studying the metabolism of migrating birds. It was noted that they developed seasonal changes in body fat stores and insulin sensitivity. Many vertebrate species developed obesity and insulin resistance during hibernation, migration, and overwintering when food availability was very low. During transitions to this insulin resistant state, the basal lipolytic activity increases to spare glucose utilization by the peripheral tissues, and fat oxidation becomes predominant. This adaptation helps survival in times of seasonal famine. At the end of the season, animals revert to the insulin sensitive or glucose tolerant phase, and they become lean. And a certain activity of a certain hormone helped develop treatment for type 2 diabetes. So you have to give me X. X is a certain chemical, you can characterize it as a hormone, and or you can tell me what the treatment came from this pathway or this physiological phenomena which is seen in birds, migratory birds. So there is a picture also to help you, assist you, how the hormone is working and how is it is transitioning, causing insulin resistant state, and then again helping the birds transition to an insulin tolerant state. So with that, I think I'll move on to the next question. So question 10, in his description of diabetes mellitus, Aretius of Cappadocia compared it to which disease, considering it to be an important differential diagnosis of diabetes mellitus? By many historians, it is said that Aretius of Cappadocia was one of the first. He gave one of the first documented descriptions of diabetes mellitus in history, and he compared it with a certain condition or a certain disease or a certain thing which you can say it as a condition with which diabetes mellitus shared a lot of similarities. You have to tell me which condition. So there might be a confusion with question numbers. I think maybe there is one question more. You can just answer it one by one after the other as the questions are appearing, and we can just mark the questions as it is. Okay, so question number 11. Again, a very straightforward question. You have to name this radiological sign, which we can see in thyroid ultrasound Doppler study, and you have to also tell me in which condition we see this sign. The radiological sign and also the condition, 5+5. I'll move on to the next one, question number 12. Again, a bit of trivia. Question 12, in 1996, Danny Welch's lab in Hershey, Pennsylvania isolated a complementary DNA from a cancer cell that was not able to undergo metastasis after the human chromosome 6 was added to the cell. This gene was named X because of the location of where it was discovered, which is Hershey, Pennsylvania, and also the home of Hershey's Kisses. Y is a hormone product of the X gene, which is involved in the initiation of puberty. And the X gene was first isolated as a tumor spreading gene by investigators, and it was named as metastin. Metastin is derived from the protein Y and is a natural ligand for the receptor known as GPR54. You have to tell me what is X and what is Y. What is the gene X and what is the hormone product Y? Again, a very straightforward question for endos, but I hope that physicians find this challenging. Okay, so the last three questions, I'll just go forward. There are two chemical structures given in this picture. One you can see, it's already written, icodec, and that has been compared with something that has come out in the market very recently. And you can see that there are two chains, B chain analog and A chain analog, which has been added via linker to IgG2FC domain, and that is giving the single cell insulin molecule a very prolonged half-life, even more than the half-life of icodec. Half-life of icodec, as it is written, 8.2 days, and the half-life of this thing, BIF, is 17 days. You have to name the drug, the molecule, which has been shown on the right frame. So the penultimate question, very straightforward. You have to name the blanked out drug, which has been recently found to have significant beneficial effect in the recently concluded fine arts HF trial. Dash in heart failure with mildly reduced or preserved ejection fraction. As you know, in preserved ejection fraction, we have very few drugs which can work and give a beneficial effect regarding morbidity and mortality. And so this is one of the drugs that recently the results came out on 1st September 2024, and the trial was fine arts HF trial. You have to tell me which drug was used. So after a series of, I think, quite easy questions, I'll end with a comparatively difficult one as the last question, and then we'll see the answers. So going to the last question, there are two pictures shown as A and B. You have to tell me the two radiological signs that you can see in these two pictures, and you have to also mention the conditions they are seen in. So 5 plus 5, 2 radiological signs are there, and you have to also mention the conditions that they are seen. If both, you get both right, then you get 5 for each sign and condition pair. So this is a bone scan, nuclear medicine MDP scan, and you can see that there are some increased blackening in different parts of the skull, of the face, and they are constituting 2 different radiological signs, and they are seen in 2 specific conditions. You have to name both the signs and the conditions. So with that, I would end my series of questions and go on to the answers. I think you can now exchange the answer sheets and we can begin the marking process and then see who comes out at top.
First, ensure that all the answer sheets have been exchanged.
Yeah, I think some of them are in sitting as a couple, but then there are some single fellows also.
প্রদীপ চেঞ্জ করে দাও, মানে একজনেরটা আরেকজনকে আরেকজনেরটা আরেকজনকে রো এদিক ওদিক করে দিলেই ভালো, ওদিকের রো এদিকে এদিকের রো আর যদি 2-1টা এক্সট্রা পড়ে থাকে আমাদের দাম হতে পারে।
So I think the exchanges are done. Piyash, we can go to the answers. ওই পিছনে একজন আছে, ও বোধহয় এক্সচেঞ্জ করতে চাইছে। I think sheets are exchanged, right? No one left, all ready for the answers, and it's time to grab those nice cash prizes. So I'll start with the answers. Piyash?
I think so. Anyone left?
I think it's done.
Anyone left? Oh, in back.
আচ্ছা, অলরেডি পিছনেও করে দিয়েছে ওটা চন্দন। I think it's done. So let us move on to the answers, and of course I would like now for the audience to shout out the answers. I think it was a pretty straightforward, easy quiz. So this one, first question. Yes, it is Klinefelter syndrome, and Dr. Fuller Albright was the mentor for Harry F. Klinefelter, and Fuller Albright published a lot on this syndrome. So although we know Dr. Fuller Albright to be associated with calcium metabolism, we must not forget that he also forayed into a lot of other segments of endocrinology as well. This one, X, Y, and Z. X, Y, Z. X. I want exact answers. So X is thyrotoxicosis. Y? Y is hamburger. Okay, and Z? Beef thyroid extract. Okay, so for X, you have to write hamburger thyrotoxicosis. That is the name of the disease, not thyrotoxicosis only. Y, it's fine, hamburger if you have written. Z also, beef thyroid or thyroid gland, thyroid tissue, whatever you have written, you will get 3 marks. So absolutely right. This is outbreak of thyrotoxicosis, or typically hamburger thyrotoxicosis caused by consumption of bovine thyroid gland in ground beef. So This one, a very easy, straightforward one. BMI, yes, exactly. Or known as Quetelet's index, exactly. So this was body mass index, BMI. This is question number 4, another very guessable question from IJEM. Character in Ramayana, anyone? Yes, exactly, it is Kumbhakarna. Kumbhakarna exhibited all these features of hypersomnia, maybe some cognitive dysfunction. I don't know how much altered perception was there, but certainly eating disorder was there. So this character has been compared with patients of Klein-Levin syndrome by our very own Dr. Om Lakhani, and this was published in 2015 in IJEM. Let us move on to the next question. Yes, this keto dot question. Anyone? Watch what? Yeah, seizure, or maybe specific would be epilepsy, or more specifically pediatric epilepsy. Ketogenic diet was usually used to starve the brain of glucose so that the seizure cannot propagate throughout the electrical activity cannot propagate throughout the whole of brain, and this was actually very helpful. And now also, as far as my pediatric knowledge goes, this is also an adjunctive therapy for very recurrent and refractory epilepsy. But now we have repurposed this diet for weight loss. This one, this hormone, I would request endos not to answer. I think everyone would know. Physicians, anyone got it? Leptin, exactly. Leptin coming from the Greek word leptos, meaning thin. And now, I mean, for quite a long time, this is one of the, being regarded as one of the very important hormones of the body. And in certain conditions where there is, the body is leptin deficient, or say in conditions like lipodystrophy, we have now come out with drugs like recombinant leptin called metrileptin to cure patients of those ailments. Question number 6, although I think I have made a recurrent, the 2 question 6s, but again, very simple answer. Anyone? Yes, Dada? Yes, it is Viagra. It is Viagra. And what about the other parts? Except for the name of the original molecule, I think every one of us know it. Exactly. It was being tested for pulmonary hypertension, but as a side effect, it showed priapism in a lot of patients, and it was repurposed as a drug for erectile dysfunction. The scientist and the discovery, anyone? Atorvastatin. And the scientist, name of the scientist? Endos can answer. Name of the fungus, genus of the fungus, from where the drug was extracted. So the name of the scientist is, he's a Japanese scientist called Dr. Akira Endo, and he discovered the molecule statins, not particularly atorvastatin, but statin from this actinomycosis fungus. Sorry, not actinomycosis, aspergillus. My bad. Aspergillus fungus, this certain species was there from which he extracted the molecule and then gave rise to this drug which we use universally, having many pleomorphic benefits beyond LDL control. And so this was Akira Endo. He died, I think, earlier this year or last year only. And this was his contribution. So let us move on to the next question. Again, a very straightforward for endos. Any MD, PGTs would like to answer? Certain type of diabetes, 1.5. Ki, tu bolbi? Flatbush diabetes, exactly. Or known as? আর কি নাম ফ্ল্যাটবুশ ডায়াবেটিসের? কেপিডি। সেটা কি, পুরোটা কি? এক্স্যাক্টলি, কিটোসিস প্রোন ডায়াবেটিস। শুধু কেপিডি বললে অনেক কিছু ভাবতে পারে। ঠিক আছে, তো এটা হচ্ছে ফ্ল্যাটবুশ ডায়াবেটিস ফ্রম দ্য ফ্ল্যাটবুশ নেবারহুড অফ নিউ ইয়র্ক, অ্যান্ড ইট ইজ termed as ketosis prone diabetes, and it has been given many terminologies like type 1.5, type diabetes type 1b, etc. This drug, anti-diabetic drug, found from the physiological concept in migratory birds. Anyone? Saptoshi? Huh? Dopamine agonist. What is it called? Dopamine agonist? So bromocriptine is actually the drug. If you write dopamine or bromocriptine, whatever, bromocriptine has some, can be used as a adjunct OHA, has some glucose lowering effect. And the concept of using bromocriptine in diabetes came from the migratory birds and how the dopamine levels soared and then again got down, consequently contributing to the insulin sensitivity and resistance respectively. Question number 10. Which disease? Diabetes mellitus. Arrhythmias of Cappadocia. Yes, anyone, any guess? Diabetes insipidus এর সাথে স্যার মিলছে, বাট ও এক্স্যাক্টলি কি বলেছিল সেটা সাইফারিং হয়, কিন্তু একটা ডিজিজের সাথে মানে একটা কন্ডিশনের সাথে কম্পেয়ার করেছিল। A condition which is cause of death in a lot of patients, especially in tropical countries like India. Huh? Tuberculosis is a key symptom diabetes সাথে মেলে, মানে except for weight loss maybe. Let us see. It is snake bite poisoning. It is snake bite poisoning. So he noticed that snake bite patients also exhibited this polyuria, polyarthralgia-like symptoms. So in the original text, it is described to be having similar features with snake bite poisoning, which is a cause of mortality in many in Indian context. And diabetes insipidus can happen in snake bite patients also. So maybe he noticed that, I don't know, but this is described, compared with snake bite poisoning. So another simple question, radiological sign and the condition, especially medicine PGTs. Bol, jore bol. Graves' disease is the condition. Sign? Anyone? Ball, Piyash ball? Ring of fire. What is the ring? Ring of fire alada, it is inferno sign. So this is called the thyroid inferno or inferno sign. And this is indeed seen in Graves' disease. So 5 plus 5. Whoever got one right should get 5. Yeah. I messed up with the number. I think there are 16 questions. So that doesn't matter. Just answer it one after the other. This one, any medicine PGTs? So, yeah, exactly. Brilliant answer. Kisspeptin is the hormone and the gene is KISS1. Anyway, KISS, if anyone has written KISS also, I think mask can be given. So KISS1 gene and kisspeptin is the hormone which actually has a lot of role, predominantly in initiating puberty, but maybe in other places also. We'll find out in the future. Question number 13. This drug, Efsitora key. Efsitora alpha, exactly. This is the another long-acting insulin brought out by now. Icodec was brought out by Novo Nordisk, and if Novo Nordisk is in the game, then Eli Lilly will not be far behind. So they have brought out their own very own molecule, long-acting once-weekly insulin, Efsitora alpha, and they have already started comparing it with Degludec. So why not? It is indeed Efsitora alpha, very new launch. Still, there are trials going on. This one, medicine PGTs? Finerenone, yes. Fine arts, finerenone, very straightforward. And the last one, sign and condition, A, B. Piyash? That is what? A, image A. What about B? So that is right. That is a very good answer. That is right. Lincoln sign, Lincoln beard sign, named after Abraham Lincoln's beard, and it is seen in Paget's disease. What about the image B? Anyone? So A is Abraham Lincoln beard sign in Paget's disease, and B is pirate sign seen in McCune-Albright syndrome. If you see, it looks like someone is wearing a mask like a pirate, and that is the area, the patchy uptake seen in the fibrous dysplasia of the skull in some patients of McCune-Albright syndrome. So that was it, the 16 questions. we can, I think, after calculating the marks, we can exchange the papers and then hand it over to the organizers, and we'll see
I think
who has.
easy way of doing it would be to just a raise of hands. Let the papers be with whom je thakuk jar kache jar আছে. Anyone who has got all the questions correct, please raise your hand. মানে যার কাছে আছে পেপার, all the questions কত 15 ছিল না 16টা ছিল?
16টা ছিল।
16টা. Anyone who got 15 correct, raise your hand. Anyone who got 14 correct, raise your hand. Anyone who got 13 correct, even partially, raise your hand. আচ্ছা গুনবে, গুনে নিক। আচ্ছা গুনে নিক।
10 প্লাস যদি কেউ হয়ে থাকে
let us give them 2 minutes. হ্যাঁ নেগেটিভ
10 প্লাস যদি হয়ে থাকে তারপর ওইভাবে একটা ইয়ে করা যায়।
তো ঠিক আছে বলছি আবার, I think by now the calculation has been done. So anyone with 13 correct, 13 correct. Anyone with 12 correct, 12 correct. Anyone with 11 correct, 11টা ঠিক হয়েছে? হয়নি? Anyone with 10 correct, 10?
একজন হাত তুলেছে ওখানে।
স্যার আমি বলেছি 10 মানে 10।
এক্সপেরিয়েন্স।
আচ্ছা দুজন 10 পেয়েছে বোধহয়।
আচ্ছা ওইটা নিয়ে ওটা খালি আবার ক্রস চেক করতে হবে যেটা 10। Anyone with 9 correct? Full and half? Okay, 9 and half. এটা নিয়ে নাও। Anyone with 9, ওটা 9 correct? তাহলে এই তিনটে তো হয়ে যাচ্ছে। এই তিনটে একবার ক্রস চেক করে নিলেই হয়ে যাবে। 11? আচ্ছা we have 11 also here. 11 questions correct, তাই তো? So we have 11 partially correct, 10 partially correct, 9 partially correct. So anything better than that?
স্যার পার্শিয়ালি কারেক্ট গুলো তো মার্কস দেওয়া আছে, মানে ওটা কতটা সেটা
করে
করে হয়তো
দেখে নিতে হবে, করে দেখে নিতে হবে। এগুলো একটু করে নে তো। পিয়াস করে দিচ্ছে, পিয়াস করে দেখে দি।
এই চারটে করতে হবে। আমি করেছি।
দেখেন। আচ্ছা তুমি একটা একটা করে দেখে নাও।
সেকেন্ড কোশ্চেনে কত মার্কস ছিল?
each part 3 marks, total 10.
Total 10 for each question to?
Total 10 for each question, but there were 3 parts in the second question. If anyone has got 2 right, we'll give them 6. 1 right, 3. So 3, 6, 10, 8 marks possible. Five plus 5. 12 নম্বরটা গ্রেভসটা, হ্যাঁ ওটাও 5 plus 5. ইনফার্নো সাইন, থাইরয়েড ইনফার্নো 5, গ্রেভস ডিজিজ 5.
10, 5 but 2.5, 2.5.
এটাকে নিচ্ছি না, এটা অন্যরকম দেখে।
ঠিক আছে, ঠিক আছে। টোটাল করে নাও, এই একটা আমার হয়ে গেছে, আরেকটা করে নাও।
10, 10, 10, 10, 50, 50, 60, 65, 75, 85, 85, 10, 10, 4, 4, 10, 50, 60, 65, 75, 85, 85 স্যার।
আর ওদিকে কত হলো? আর কারোর কাছে আছে? Okay. So I have the 3 winners with me. ওটা দেখি কত আছে? টোটাল করে বল আমার কত আছে? I think I have the 3 winners with me, and okay, it has been a very closely fought contest actually. So the first runner-up is Dr. Saptarshi Das. So I know Saptarshi well. So Saptarshi Das, I'll request our organizing secretary, Dr. Rana Bhattacharya, to hand over the checks. Stage e giye kore dao. Saptarshi, please go to the stage. And Dr. Debaditya, our quiz master, he did an excellent job. A big round of applause for him. The questions were very interesting. The second runner-up was Dr. Saptarshi Das. The first runner-up is Dr. Ayush Agarwal. Dr. Ayush Agarwal is the first runner-up. A single line about yourself, Saptarshi. I know you. Everyone doesn't know you. A single line about
Currently,
yourself.
I am a second-year postgraduate trainee of general medicine at RGK Medical College and Hospital.
Okay, big round. So Dr. Ayush Agarwal is the first runner-up.
I am first year PDT endocrinology at IPGMR.
Okay. So, and the winner of this quiz is Dr. Debashish Mondol. Dr. Debashish Mondol, please. So, big round of applause for all the three winners and all the participants and the quiz master as well.
Dr. Debashish Mondol is the winner of our quiz, and we would like him to introduce where he is working.
আমি দেবাশিস মন্ডল, সেকেন্ড ইয়ার মেডিসিন পিজিটি মেডিকেল কলেজ কলকাতা।
Congratulations to everyone who won the prizes, Dr. Saptarshi, Dr. Ayush, and of course Dr. Debashish, our winner. And with Saptarshi.
So there's dinner, a Sumter's dinner at the ground floor. So all of you are requested to proceed for dinner.
Before leaving everybody, I'd like to remind everyone